good morning. I would like to thank the organizer, Malaysian Society of Infection Control and Disease, as well as NIH, for inviting me to this seminar and for giving me the opportunity to talk about management of dengue in Malaysia. My name is Dr. Tazlina.
Good morning, ladies and gentlemen. Good morning. Welcome to this webinar this morning. I know it's a Saturday morning and we are looking forward to a good weekend. And this is a very good way of starting this weekend in a beneficial way. So let me welcome all of you to the Managing Dengue, the COVID-19 Pandemic webinar. This is jointly organized by the National Society of Infection Control and Infectious Diseases, or MyICID for short, and the National Institutes of Health based in Setia Alam. This is held in conjunction with the Neglected Tropical Diseases Awareness Month for 2022, and I'm quite sure you may have read or seen some of the public messages we have about NTDs. Now, I'm Christopher Lee. I will be moderating the first half of this morning's session. And once again, I thank you for spending time with us this weekend. A few housekeeping rules. I have to do that. Number one, for Q&A, I think those familiar with the NIH platform, we will be using the Slido app. Please feel free to put in your questions. As soon as you have questions, don't have to wait until the end of the presentation and just put it into Slido. Depending on how many questions we have, we will try to do as many questions as we can. But for the sake of consistency and relevancy to the topic, we will select questions that have strongest link to the topic at hand. Plus, we will also not be discussing, let's say, policy matters that really comes under the purview of the authorities and the Ministry of Health. Yeah. Now, something important we have to talk about is CPD points, and I'm sure all of you are aware of that. And it's just for the professionals as well as the allied health teams. Please do collect your CPD points and fill up the online registration form or attendance form. If you have missed it, we will broadcast it again after the Q&A session. All right, so do double check your email addresses before submitting. Now, the organizers have been very kind, and after the webinar, the presentation slides will be made available on our social media, on the website, as well as the email newsletter. So don't worry about it. You get all this stuff for free. And if you do like to rewatch this session, you can go to the Clinical Updates in COVID-19 YouTube channel, which has been there for nearly 2 years now. And it's very popular. So by all means, if you want to look at it again or share with other people, by all means, you have the option. Right. Okay. So let's get on with business. Yeah. So this morning, we'll start off the party that we have this weekend will be Dr. Fazlina binti Muhammad Yusof. She is a family medicine specialist from Klinik Kesihatan Nikah in Klang. And she will be talking about managing of dengue in primary care. I think all of us agree that that is crucial in the way we address dengue, both in the public health setting as well as in terms of treatment and therapeutics, because early diagnosis, early detection or warning signs makes a big difference in terms of morbidity and mortality. So Fazlina will be focusing on how we manage dengue in the primary care setting. Let me introduce Dr. Fazlina, in case for those of you who may not know her so well. As I mentioned, she's an FMS physician based in Anika in Klang, and she has been FMS since 2009. She has served in many clinics in Selangor, and she has been involved in developing numerous KKM or MOH guidelines and CPGs. She has also been actively teaching master students for family medicine. So without further ado, let me welcome Dr. Fazlina to share her presentation this morning. Dr. Fazlina, you have the floor.
Assalamualaikum and good morning. I would like to thank the organizer, Malaysian Society of Infection Control and Infectious Disease, as well as NIH, for inviting me to this seminar and for giving me the opportunity to talk about management of dengue in primary care. My name is Dr. Fazlina. I am a family medicine specialist in Klinik Kesihatan Anika, Kelang. Dengue is one of the most important arthropod-borne viral diseases with high morbidity and mortality. It affects tropical and subtropical regions around the world, predominantly in urban areas. This is the CPG management of dengue infection in adult 3rd edition 2015. This is the latest CPG so far and should have a new one soon. We have here a 20-year-old man with no known medical illness. He came with a complaint of fever for 5 days, joint pain for 2 days, and he was living in a dengue area where there was a fogging at his house last week. He had no warning signs. On examination, he was pink. Temperature was 37.6. BP was 120/70 and pulse rate was 90 beats per minute. All other systemic examinations were normal. Investigation showed that his WBC was 2.8, HB was 12, platelet was 110, and hematocrit was 38. His dengue combo test, NH1 was positive, IgG and IgM was negative. So this is one of the among so many dengue cases in Malaysia. In Malaysia, dengue cases and incident rate has been increasing from year 2000 but somehow decreased by 17% in the year 2017. The trend tends to increase back in 2019. During COVID pandemic 2021, there is further drop of dengue by 74% compared to the dengue cases in 2020. At the end of 2021, there were about 26,000 cases of dengue with 20 deaths. There were 2 peaks of dengue trend in Malaysia throughout 10 years, where they peaked in 2015 and 2019. It is postulated that the dengue will increase back in 2023. Thus, we need to be ready to curb this peak. This graph shows that early in 2013, there were 4 serotypes of dengue, but over the years, serotype 2 and 3 has been predominant, and serotype 4 has been markedly decreased. So how to diagnose dengue? Dengue is diagnosed using WHO criteria 2009. That is fever plus 2 other symptoms. The 2 other symptoms could be nausea, vomiting, rashes, itches and pain, leukopenia, or any warning sign. We define dengue disease severity using WHO criteria 2009. That is dengue with or without warning signs or severe dengue. Patient with severe dengue could have severe plasma leakage or severe hemorrhage or severe organ impairment. We manage dengue cases by using 3 stepwise approaches. The step 1 is overall assessment, and we are taking the history. The clinical course of dengue infection has 3 phases. First, the patient will go into febrile phase, and then the patient will go into critical phase, and lastly, the patient will go into recovery phase. When patient got dengue, they usually start with febrile phase, which usually lasts for 2 to 7 days. And then patient will go into critical phase, where it usually occurs at the 3rd day of fever. The clinical presentation will depend on the presence and degree of plasma leakage. But this critical phase usually lasts for about 24 to 48 hours. If the patient survives, the patient may go into recovery phase. In severe dengue, during this phase, the plasma leakage will stop and is followed by reabsorption of extravascular fluid. Dengue infection is actually a dynamic disease, and the clinical course will change as the disease progresses. After history, we will go to physical examination. In physical examination, first we will assess the patient's mental state and GCS, and then we will assess the patient's hydration, followed by assessing the patient's hemodynamic. A quick way of assessing hemodynamic is by using CCTV-R. The CCTV-R is one of the signs to indicate severe dengue. It is called a magic touch. Holding the patient's hand is a quick way to evaluate the peripheral perfusion. In less than 30 seconds, you can tell whether the peripheral perfusion is normal or reduced or very reduced. First, we look at the patient's skin color, whether it is pale or pink. Touch the patients to assess the capillary refill time, whether it is delayed or normal. Feel for the patient's temperature, for warm or cold and clammy. Find the patient's pulse volume, whether it is normal, weak or trendy. Count the patient's pulse rate, whether it is normal, tachy or brady. The picture at the left shows how we want to assess the capillary refill time. First, we have to press the patient's skin and then lift the finger. Then we count how many seconds it takes for the skin to become pink again. If it is less than 2 seconds, it is normal. Then we have to check the patient's BP and pulse pressure. Patient with dengue can go into hypovolemic shock. When patient is having compensated shock, the BP is still normal, but the heart rate will start to increase more than 100. And then, if the patient go into decompensated shock, the BP will start to drop, and the pulse pressure will become narrow. Other systemic examination, we have to look out for tachypnea and also pleural effusion. Check for abdominal tenderness or any hepatomegaly or ascites. Other than that, we can also examine for bleeding manifestation. What are the investigations that we need to do for dengue? Full blood count is a very important investigation to be done. In dengue, we will see the decrease in WBC and platelet. However, there is no correlation between disease severity and platelet count, and it is not a predictive of bleeding. In recovery phase, the WBC will normalize, followed by platelet. A rising of hematocrit is a marker of plasma leakage in dengue infection. We need to know the normal value of hematocrit to compare with the patient. In dengue, we need to monitor the full blood count and hematocrit as the dengue infection progresses. The next investigation is a diagnostic test. Rapid combo test consists of dengue NS1 antigen and dengue IgM and IgG antibodies. NS1 antigen will usually become positive at 4 to 5 days of illness onwards and will become negative at recovery phase. A positive test usually indicates that the patient is having acute dengue infection. If it is present after 5 days, it may predict severe dengue. For IgM test, it is usually positive after day 5 to 7 of illness, and a positive test usually will suggest that the patient is having recent dengue infection. For IgG test, it is usually positive after day 7 of onset of fever, and a positive test will suggest that the patient is having acute or past infections. A titer of 1 in 2,000 is consistent with acute secondary infection. The other test is dengue viral RNA detection, which is useful for determination of circulating dengue serotypes in the country. Step 2, diagnosis, disease staging, and severity assessment. These 5 points should be included in dengue diagnosis. For example, for the case that we illustrate earlier, the complete diagnosis will be dengue fever day 5 in a febrile phase without warning signs, patient is not in shock, and patient is not having severe dengue. Step 3 is plan of management. Not all dengue cases need to be hospitalized. The patient can be treated at home if the patient are able to tolerate orally well, has good urine output, and no history of bleeding, has absence of warning signs, physical examinations all normal, investigation shows stable serial hematocrit, and no other criteria of admissions like the patient doesn't have any comorbidities, the patients are not pregnant, or doesn't have any social factors. Patient can be sent home with symptomatic and supportive treatment. However, patient needs to do daily or more frequent follow-up if necessary from day 3 onwards until afebrile for at least 24 to 48 hours without any antipyretics. The doctor needs to use dengue clocking sheet to clock the patient, and the patient should be provided with outpatient dengue monitoring records and home care advice leaflets, and advise the patient to come or return to the hospital as soon as possible if they have any warning signs. This is the dengue monitoring record that is available in primary care. Patient who is diagnosed as dengue will be given this card and need to submit this card to the attending doctor every time they go to the clinic. The doctor can monitor the patient's progress from this card, and the doctor needs to fill in the whole column, including the next appointment, so that the patient will know when to come back to the clinic. And this is the home care advice leaflet that is given to all dengue patients. In this leaflet, the patient can know what they can do and what they should avoid. And for example, in the avoid part, the patient should not take any NSAIDs, example aspirin, Ponstan, or steroids. And the patient should not take any antibiotics or take any injections or do any massage, cupping, or quasar. At the back of the leaflets, there is a danger signs that the patient should monitor. And if, let's say, they have any of these warning signs, the patient needs to go to the nearest hospital as soon as possible. Patient needs to be admitted if they have warning signs, bleeding manifestations, inability to tolerate oral fluids, reduced urine output, or seizure, or if they have dehydration, shock, or bleeding, or any organ failure. Special group of patients have high risk of getting severe dengue and need to be admitted early if indicated. And this special group of people are patients with comorbidity, for example, diabetic, hypertension, ischemic heart disease, coagulopathy, morbid obesity, renal failure, and so on. Or elderly patients more than 65 years old, patients who are on antiplatelet or anticoagulants, patients who are pregnant, or patients with social factors. Other than that, if the patient has rising hematocrit accompanied by reduced platelet count, this patient also needs to be admitted. Fluid is very important in dengue management. For non-shock patients have to increase their oral intake. IV fluid 0.9% saline is recommended in patients with increasing hematocrit with evidence of ongoing plasma leakage despite increase of oral intake. Other than that, if patients are vomiting and having severe diarrhea or cannot tolerate orally, they also need to have IV fluid. When giving IV fluid, we need to calculate the fluid regime. For non-obese patient, fluid is given by 1.2 to to 1.5 ml per kg per hour. For obese patient, we have to adjust the body weight first before giving the fluid regime. And patient who is in shock should have given bolus regime and start with 5 ml per kg per hour for 1 to 2 hours, then reduce to 3 ml per kg per hour for another 2 to 4 hours, and then reduce some more to 2 ml per kg per hour or less according to the patient clinical response. When referring the patient, we have to optimize the patient conditions before and during the transfer. The ED, ICU, or medical department of the receiving hospital must be informed prior to the transfer. Adequate and essential information must be sent together with the patient that includes the fluid charts, monitoring charts, and investigation results. All dengue cases have to be notified. All suspected and confirmed dengue cases from private or public health facilities must be notified by the attending doctor via telephone, fax, or e-notification to the nearest health office within 24 hours of diagnosis. We notify by using the disease category as dengue fever or dengue hemorrhagic fever. And failure to notify is liable to be compounded under the Prevention and Control Infectious Disease Act 1988, and the compound can be up to 1,000 ringgit. And this is the notification form. Now we have e-notification, which is a real-time web-based system used to notify all notifiable disease based on MOH requirement. All dengue cases will be registered by the respective district health officer after they already verify and also investigate the case. And this is done in e-dengue V2. In primary care, we need to get thorough history taking, and we have to use this dengue assessment checklist so that we won't miss anything. All this information will determine whether the patient can be managed in primary care or to be referred to the hospital. First, we have to get the patient's correct name, IC, phone number, and also address. And then we have to diagnose the dengue. The patient have to fulfill the fever with any two of the symptoms. And then we will look at the patient whether they have any warning sign. If they have any warning signs, they may need to be referred immediately. Special group of patients will have high risk of getting severe dengue, so we have to have low threshold of referring them early. Vital signs and blood investigations are very important to determine the patient's condition. The patient who has severe dengue needs to be referred immediately. And then, correct and complete diagnosis is important to plan the patient's next management. In a management, notification should not be missed, and the patient should be given dengue alert card. Dengue mortality are discussed in the state level, and the common errors at primary care is failure to recognize dengue infection in a febrile patients. So all primary care doctors have to have high index of suspicion in febrile patients who is coming from the dengue areas and any patients with symptoms of dengue. The other common errors at primary care is failure to recognize dengue shock in an afebrile patient. So all primary care doctors should have high index of suspicion for patient who has nausea, vomiting, abdominal pain, and warning sign, and any manifestations of compensated or decompensated shock, and have to look at the hematocrit rather than just platelet alone. Signs or symptoms of warning signs are any abdominal pain or tenderness, persistent vomiting more than 3 times over 24 hours, persistent diarrhea more than 3 times over 24 hours, or any third space fluid accumulation such as ascites, pleural or pericardial effusion, or patient has spontaneous bleeding tendency, or patient are feeling lethargy, restlessness or confused, or any tender liver, or any raised hematocrit with rapid drop of platelet. All these patients should be admitted early. Not all fever is dengue. So dengue can also have differential diagnosis. If the patient presents with fever, the other diagnosis could be influenza, measles, chikungunya, adenovirus, or acute HIV. If patient presents with rashes, it could also be rubella, measles, meningococcal meningitis, chickenpox, drug-induced. Or if patient have diarrhea, it could also be rotavirus or food poisoning. Patient who present with acute abdomen could also be acute appendicitis, acute cholecystitis, perforated bowel, or viral hepatitis. Patient may come in shock, but it could also be septic shock. And patient with respiratory depression, we need to rule out whether this patient is having DKA, acute renal injury, lactic acidosis, or maybe COVID or drug poisoning. And patient who presented with leukopenia and thrombocytopenia and bleeding can also be, other diagnoses can also be malaria, leptospirosis, acute leukemia, TTP, or SLE. The challenges that we face in primary care is that the patient may present as atypical and non-specific presentations, and the presentation also can mimic many other diseases, thus will delay the diagnosis. Patient also has other comorbids and have other co-infection, and some patient will even come very late at presentation. So this also can cause acute progression with the multi-organ dysfunctions. We also need regular training on clinical management of dengue to update the healthcare providers, as there are also high turnover of healthcare providers in the health facilities. As a take-home message, in primary care setting, we need to do accurate and prompt diagnosis and notification. All patients should have appropriate monitoring. If the patient can be monitored at home, we need to give them proper patient education and home management. We need to be alert to the dengue warning signs and criteria for admission. And before we transfer the patient, we have to stabilize the patient. Good inter-facility communication and handover is very important in managing dengue. And lastly, there is no prophylaxis for dengue, so prevention is better than cure. Let's fight against dengue by conducting 10-minute search and destroy every week. Number 2, protect yourself against mosquito bite. And number 3, seek early treatment if you have fever and any 2 other symptoms. And in klinik kesihatan, we usually give ABID to the dengue patients so that they can put this ABID into their boiling water. With that, I thank you.
Thank you, Fazlina. Thank you very much for your very concise and clear presentation. It comes to the time for questions, and I'm sure there are questions, and I remind everyone to go to Slido and punch in your questions. We will try to answer as much as we can, all right? So time is short, so I'm going to rush a little bit now, all right? Now, as you can see, we will only pick questions that we feel most relevant to the topic, to be fair to the speaker. Right, first question, Fazlina, she's with us now.
What can be done to reduce bleeding?
Okay, can you do the first? What can be done to reduce the bleeding tendency if dengue patients require emergency operations, especially for the first 24 hours post
op. I think this question may be best answered by Dr. Yasmin in the second presentation. Is that all right? Or Fazila, you want to answer this question as well?
Yeah, we usually refer this patient to the hospital anyway, for them to reassess the patient. I think Dr. Yasmin is the best person to answer this question.
Okay, it is a very challenging scenario, and just watch out for, make sure you send this question in for Yasmin afterwards. Perhaps you have the next question. Right, okay. Shall we go down the list? Someone asked here, is severely low platelet count an indication for admission? This is a very relevant question because in the primary care, that's what patients have. They will come with the full blood count. So the question that they have for Fazlina is, what is the suggested threshold? Fazlina?
Yes, we usually in KK, we in primary care, we usually monitor the patients, and daily we will do the full blood count. And if let's say the platelet is going down trend and the patient doesn't look well, we will straightway admit the patient. This is one of the warning sign anyway. Low platelet count is one of the warning sign.
Right. Okay. Thank you. Move on to the second question, a third question.
It depends on the condition of the patient.
Of course. Yeah. Now, I think I want to add on to. Okay, I'm not sure whether we could hear you properly, Fazlina. Can you repeat that again, Fazlina? Can you repeat that again?
Other than that, we also monitor whether, like sometimes the patient will come today with platelet 100, but the next day straightway going down to 50. So that kind of patient, even though only one day different, we still refer the patient. Sometimes the patient will have abrupt lowering of the platelet, then that one need to be referred early. Basically, what primary care have to do is to monitor and also to be alert of the warning sign.
Right, good. I just want to add, I think Fazlina mentioned this in passing just now as well. I think it's important not just to look at the platelet count by itself in making decision to bring a patient in. You must look at the overall condition of the patient and the other warning signs as well. All right? Platelets, sometimes we overemphasize the importance of platelets. We get very excited when the platelets are 30, 50, 60,000. But even if the platelets is 100,000, if there are other warning signs, that the patient should still be referred to hospital. Right, let's move on to another question. The question is, do you recommend NS1 antigen for everyone who comes into KK or a GP clinic with a fever, even on day 1 or day 2 of presentation? Fazlina?
We ask for any, first we have to see the criteria, whether the patient is having dengue or the other cause of fever. So if let's say we have one fever and 2 other criteria that shows that maybe this patient is having dengue, then we will do NS1 even if the patient present in the first day of fever. And sometimes the patient are unaware that they have fever for a few days already because they didn't feel that they are unwell, but actually they already become unwell early on, and they only notice that they have fever only one day. So any person who you suspect, and especially if the person said that they live in the dengue prone area, better check for NS1 because that is in Malaysia is very high risk of getting. I mean, the first diagnosis, any fever, the first diagnosis is you have to think about dengue. So it's not wrong for you to do NS1, but first you together with NS1 you have to monitor the full blood count also, because one of the indicator to know whether this patient is having dengue is full blood count other than symptoms. Okay.
Okay. All right. Thank you, Fazlina. Now, the next 2 questions are interlinked. So I'll read both questions at the same time, and then Fazlina can address them maybe as one answer. Okay. The first question is, can we rule out dengue if NS1, IgM, IgG is negative at day 5? First question. The second question, which I think is linked, what if at day 5 of illness, only IgG is positive, NS1, IgM negative? can we be sure this is not dengue? Basically, I think the person who's asking this question wants to know how best to interpret the various diagnostics that we have, which is NS1, the IgM, IgG serology, at a particular point in illness, which is, and they have picked day 5 here. Perhaps, Faslina, you can give an overview about regarding these 2 questions.
If the patient come with fever and you thought that this could be probably dengue, even probably dengue also we have to notify. NS1 and IgG, all the diagnostic investigation is only supporting the diagnosis. So basically the most important thing is you have to monitor the patient, see maybe the next day you have to see the patient and monitor the patient condition and also full blood count. And let's say there is indication for you to repeat the test, you can repeat anytime also. I mean, after a few days or so. It doesn't mean that once you do the test and it all negative and it won't become positive again. So what my advice is, you have to see the patient and you have to have a high suspicion. If let's say you think this is dengue, you can repeat the test again the next day.
Right, okay. Thank you. I'll take one more question with regards to diagnostics. Here it's about dengue PCR. It's obviously not something that we send routinely from primary care, but the person who's asking this question is, in what circumstances is dengue PCR useful? Often we know that PCR results do come back quite late. So at the primary care setting, what role has dengue PCR have?
Actually, we don't have any PCR in primary health setting. Most of the PCR is available in hospital, I think, in ED. So if let's say they are not sure whether this is dengue, because dengue, like as we said just now, dengue have differential diagnosis. It can mimic anything. So we are not sure whether this is dengue or this is leptospirosis or other, maybe COVID also. So we have to do dengue PCR. But during at that point of time, the patient is already referred to the hospital. So I think in primary care, we will refer if the patient have warning sign and it's not looking good. So we will refer the patient to the hospital, and this in the hospital maybe they will do dengue PCR. I'm not sure about the how to see the dengue PCR. Maybe Dr. Yasmin also can help me with to answer this later.
Right. Okay. Well, we can, I'm sure Yasmin will talk about that later on in the presentation. But just as a summary about PCR, really in the way our primary care is set up, PCR's role in the primary care level is actually quite small, really fairly minimal. And also, if patients are it's often used basically when there's uncertainty about the diagnosis. And for most patients, if the patient is still a worrying patient for the clinician, I think they should be referred to the hospitals where there's more diagnostic support. Yeah. One final question, I see it, but I know many doctors do talk about this, and just a simple thing to deal with. Faslina, some doctors advise us to drink 100+. Okay, I'm not trying to support any brand, okay, any brand of drinks, but 100+ for hydration. They want to know your opinion about this. Or you want to drink coconut water and all that. First climb the coconut tree, drink the coconut water. Please don't fall down because you have dengue, you might bleed. So that's probably not so safe. Go ahead, Faslina, go ahead.
I think it depends on the patient's condition also. If let's say 100+ for some people, macam like for me, I don't like 100+. So I prefer to drink other water. So it's not only 100+, you can drink any water. The most important thing in dengue management in primary care is to drink a lot of water. It can be 100+, it can be just coconut water like Dr. Datuk Chris said, or any just plain water also is okay. We usually advise in the clinic, we usually advise the patient to drink a lot of plain water. But 100+ for certain patient like diabetic, you have to be careful because 100+ has a lot of sugar inside it, and we are scared that if a patient who is diabetic drink 100+, then the diabetic control will become very bad and the dengue severity will become worse. So depends on people, but you can drink any water. The most important thing is you have to hydrate if you have dengue infection. So any water is okay. And some of the contents of 100 plus for the young people who doesn't have any comorbids is good because they have a lot of electrolytes inside it, which can also improve their electrolyte imbalance in the body. So you can advise the patient to drink any water, but be careful if the patient have certain comorbids, you have to stop them from taking certain drinking water.
Okay, well said, Faslina. Spoken like a true public physician, all right, who will not support any brand, all right. But yeah, I agree with you. Anyone who likes to drink 100 plus and who can drink 100 plus, meaning no other contraindications, go ahead. It's okay, all right. But for those patients who shouldn't be drinking 100 plus, don't drink 100 plus now, okay? You make things just worse. Now, there are many more questions. I have avoided questions that relate to management in the hospitals in relation to complicated or severe cases. I'm leaving it for Dr. Yasmin afterwards, all right? So because time is just, I'm trying to keep time. That was my number one responsibility today. I'm going to thank Dr. Faslina for spending that time with us this morning. Thank you very much for your presentation and also for your very clear and concise answers. Thank you very much, Faslina. Thank you very much indeed.
Thank you, Dato'. Thank you.
Right. Okay, so now let's move on to the next speaker. Well, we started off with primary care, and now clearly the next step is to move towards the hospital. And to speak about approach to severe dengue or more severe dengue, that is from the emergency department to the ICU. We have Dr. Yasmin Muhammad Ghani. She is an ID consultant from Hospital Sungai Buloh, and she has been at the forefront of dengue management for many, many years. I dare not say too many times, because if she is many years, I'm a lot more many after that. So I try not to be too old, all right? So Yasmin has been working with us in Sungai Buloh. She has been very active in especially infection control activities. She has been very involved in our antimicrobial stewardship programs, and she has a special interest in dengue as well. Of course, in the last 2 years, she has been heavily involved in the care and management of COVID-19 patients as well. So if you want to talk about dengue management in the COVID-19 pandemic, she might be one of the good people to talk to as well. But we have a special presentation on that after Yasmin's presentation. So with that, I would like to invite Yasmin to the floor to start the presentation on approach to more severe dengue from ED to the ICU. Yasmin?
Thank you everyone for the invite. I'm honored to present on severe dengue from emergency department to ICU care. Sorry. This is my disclaimer. I'm basically presenting on behalf of the dengue webinar series by MyICID. So what do we know? So what do we know about dengue infection? So some of the basic facts, as we know, it's three-phase disease where there's a febrile phase, there's a critical phase, and the reabsorption phase. Febrile phase typically lasts about 1 to about 4 days or less than that. And critical phase typically lasts for about 48 hours. And the recovery phase follows shortly the critical phase where the patient actually starts getting better. Some of the complications that we generally see during this time, during the febrile phase, very often than not, patients can present with some dehydration. They can present with some CNS impairment, some mild organ impairment with some acute confusional state, which is very self-limiting. And during this time, blood test results, if done very early, may not show anything. But by the second or the third day, we can start seeing platelets coming down. And during this time, the hematocrit must still be stable. But if they have any signs of dengue with warning signs, then they will go ahead and develop hemoconcentration. Right? Just bring in my pointer. Okay. And during this time, viremia is also very high, peak viremia at this point, and most of the diagnosis is basically made by some blood tests, and it's one antigen and some blood tests, which basically picks up patients early during the febrile phase. Critical phase lasts for about 48 hours. During this time, they may or may not be any more fever. Patients generally present with patients may be asymptomatic during the critical phase, but the ones with warning signs, they can go on to develop some pretty critical organ impairment over here. They can start developing shock, bleeding, plasma leakage during this time. Hemoconcentration can start happening, and during this time, platelet will start dropping further with a further drop in white cell count. And towards the end of critical phase, those start picking up. And patients during the critical phase, they typically last for about 48 hours. It hasn't been longer than that. But if they have other immune activation like HLH or hyperstimulation syndrome or cytokine storms, sometimes the critical phase can actually be prolonged. During the recovery phase reabsorption, generally what happens is we can start seeing platelets recovering during this time. White cell count recovers first before the platelet starts recovering, and will soon normalize. Now, this is more of like a payback period. So if we have been sort of not very judicious with our fluids, then we'll start seeing fluid absorption, because there will be fluid overload, because there will be quite a bit of reabsorption during this time. And dengue IgM will start going up by day 7 and IgG beyond day 10. And patients with secondary dengue, however, may not have an IgM response, but the IgG will be those of high titer, and if they present early, the NS1 will still be positive, right? So this is the typical spectrum of dengue infection that we generally see. All we know, and we've learned from before, that it's a very dynamic nature of disease, right? So what you sort of perceive about 2 hours ago may not really stand. So it's a very dynamic nature. So you need to have timed interventions and time review of the patients to pick up some of these complications that we just briefly talked about. And we talked about the complication of each phases. And of course, we were starting to see newer complications, may not be so new right now. Bleeding and leaking syndrome, where the patients may be bleeding, but of course leaking at the same time. Typically, patients here will have still very high hematocrit, but will be hemodynamically unstable or in compensated shock with very, very high lactates that may not respond to fluid resuscitation, right? And we started seeing quite a bit of organ failures, myocarditis, CNS abnormalities. I've seen bleeds, I've seen vasculitis, I've seen cerebral edema, epidural hematomas, liver failures, and of course, a hyperinflammation state caused by an overactive immune system due to a dysregulation of our immune system. It's more like a secondary form of hemophagocytosis. Right, and we know what the warning signs are: abdominal pain, persistent vomiting, persistent diarrhea, developing ascites, pleural effusion, pericardial effusion, sort of like a leaky capillaries, right? Spontaneous bleeding tendencies, lethargy, restlessness, confusion, a tender liver, and of course, a very raised hematocrit, the rapid drop in platelet. These are quite significant. Now, before we make the diagnosis of dengue infections cannot be made from the patient's chart. Dengue diagnosis or your response to your clinical decision cannot be made at the patient's chart or at a computer without actually touching the patient. So we need to actually ascertain the phase of illness based on what our knowledge already is, examine clinically to look at the peripheral perfusion per se, and of course, look at the vital signs, and only then look at the blood results and come up with a more holistic position. So this is the 4 cornerstones of dengue. All right, and we went through this, and of course, some of the complications that we can get, like dehydration, encephalitis. We talked about organ failures, organ dysfunction, bleeding, and of course, sepsis is something that we can expect at every stage, right? And some of the causes of shock in dengue: volume deficits, bleeding, organ dysfunction, and of course, sepsis, right? So let's look at Mr. JD, JD at emergency department, all right? 32-year-old male, obese, 100 kgs, adjusted body weight's about 80 kgs now, presented with fever for 3 days, arthralgia, myalgia, vomiting 5 times a day, loose stool, no bleeding tendencies, no other symptoms. Clinically, warm peripheries, CRT less than 2 seconds, about 2 seconds, sorry, good pulse volume. Lungs were clear. There was no signs of any leakage at the moment. Blood pressure was 130/90, slightly tachycardic at 100. So this was his VBG, pH is 7.37, bicarb of 23, lactate was 1.5. Hematocrit was high at 49, platelet was still 105 at this point, white cell count 6.6, right? So an impression, dengue fever, day 5 of illness in febrile phase with warning signs, persistent vomiting, diarrhea with hemoconcentration and low platelet, not in shock and no leaking and NS1 positive. So quite a mouthful of a diagnosis there, right? So the plan was to encourage orally, strict IO chart, continue 3 cc per kg per hour, and of course, a timed visit and as well as blood test results and trace all the blood test results and given a time to actually take the bloods and trace the blood results. Okay, so patient came in at midnight. Okay, at this point, this was the hematocrit 49, platelet was 127. We know that he was a bit tachycardic, so it was started in lactate high 3.0. Okay, so it was started on 5 cc per kg. It was started on 5 cc per kg, and then subsequently at 3:30 p.m. 3:30 a.m. Sorry, responded to the 5 cc per kg, and the hematocrit actually came down significantly, right? So from 49, it actually came down to 45, and then was lingering around there. Okay, at this point, platelets started coming down too. The lowest platelet that we saw at about 7 a.m. in the morning was 103. Lactate's definitely normalized. Okay, and at 7 a.m. it wasn't detected. But look at the blood. Look at the IV drip. Right, so 5 cc per kg, 5 cc per kg, and then somehow someone brought it down to 3 cc per kg, and then subsequently 3 cc per kg. So the intervals of assessment here was actually quite there was a long lapse in terms of the medical assessment here. So patient was actually seen at 123, and subsequently, although blood results were timed to be taken, but it wasn't properly traced, and not until 7 o'clock where someone decided to actually cut down the drip to 3 cc per kg. At this point, he had very good urine output, 400 cc's. Blood pressure was about the same at that point. Blood pressure normalized a little bit to 120/80. Right. So what was the impression? Why was the first hematocrit was high at the same time? Is the patient dehydrated? Is the patient leaking? Is the patient bleeding? Or the patient's leaking and bleeding at the same time? Because he was a little bit tachycardic, right? So at this point, the most logical explanation will be that this guy was dehydrated. So after a good bolus, his hematocrit came down, right? But it was not necessary for us to continue that high infusion rate all the time, because patient showed no signs of compensated shock. Blood tests actually normalized, and if we had timely seen him, we could have actually brought down the drip or even offed it if the patient was taking orally very well. So some of the frequent pitfalls that we generally see is there's no timed or frequent reviews which is actually done. So we assume that whatever state or phase of illness he was 5 hours ago will persist even now. So that is one wrong thing that we often do when it comes to reviewing patients with dengue. It is so dynamic that it may change even every 2 hours. So it's important to have some form of sort of like a rhythm to seeing these patients, right? A review every 4 hourly, or even write down when is my next review time date, so at 7 o'clock, I have to actually see this patient. So not realizing that the initial presentation could be dehydration and leading to high fluid boluses, like this particular case where this gentleman came in with a high hematocrit. Yes, he was given 5 cc per kg, but after achieving what we wanted, where the lactates all came down, the hematocrit came down, the infusion rate could actually be cut down, but this was not done so in this patient. And of course, not reducing the drip after an outcome was actually achieved. Okay, so in a huge ward, dengue ward, where you actually see 20, 30 patients, it's difficult. If it's 1 or 2 patients, it's okay, it's like 20, 30 patients. It's actually difficult for us to remember which patients actually need to be seen, right? So in a dengue ward, we generally have this board that basically tells us, okay, this patient, when is the next review time and when is the next blood taking, okay? So it's important to specify the next review time in the case notes or in the computer so that, someone remembers now, right? So in a busy emergency department also, when we're giving fluid boluses, right? Sometimes it's difficult to know how much the patients actually get, right? So unless you have a specified way of actually keeping track, like if you actually put them on an infusion pump and then you can actually be sure that these patients got what they want. Sometimes a kinked, a granula, a line which is not running, may actually account for, we may actually think the patient's getting 5 cc per kg or 200 cc's of fluid, but they may not be actually getting it at that amount. So a simple practice like counting amount of IV drip bottles to get an accurate measurement of what actually went in is some of the things that we used to use, right? And compared to the old CPG, if you look at the practice guideline 2015, there was a good emphasis on oral fluid intake. IV fluid therapy only indicated certain groups, easier calculation of the maintenance fluid. And of course, there was a stress on adjusted body weight in obese patients because a lot of people felt that we had to account for the body mass and the actual amount of fluid that was actually needed. So the same patient came up, JD at ward. So day 4 of admission, okay. So day 4 of admission, day 4 of illness, day 4 of illness, 7 a.m. As we know, platelet was 103, hematocrit was 45 at that point. Lactates all came down. So this is the lactate, this is the hematocrit. So when we reviewed him at 7 a.m., we realized he was on a big positive balance. So we decided to, cut down the 3 cc to 1.5 cc per kg. He was still a bit tachycardic, so we were worried about taking off the drip. And subsequently, he was maintained on a 1.5 cc per kg. Okay. However, his fluid intake, oral intake was actually very good. Okay. Hemodynamically became no more tachycardic. Still a high infusion, 1.5 cc per kg was actually continued. So during this time, as you can see, slowly the hematocrit started going up. Okay, so about 24 hours of admission, you can see that the platelet started plummeting. Okay, there's a rise in hematocrit. Okay, and there's also rise in the lactate. So when the patient was actually reviewed at this time, they noted he was a bit more tachycardic. Blood pressure was about 110 over 79. There was no documentation of what the peripheries were, but there was already a reduced right base. At this point, because of the infusion that he was actually given, it was almost about 3 liters positive balance. Okay, urine output was decent. Okay, it was not urine output was not documented at that point, right? And then subsequently, when we saw that the hematocrit went up, we thought, okay, he needs more drip. He's starting to leak. He needs more drip. So the infusion was actually increased to 3 cc per kg. We were worried about giving any although he was tachycardic, and there is slight narrowing of the pulse pressure here. He was not given a bolus because he was already 3 liters positive balance. All right. So at after 11 p.m. bloods, the next blood was actually at 6 a.m. in the morning. At this point, the hematocrit was very high. It was a 55. Platelet plummeted even more. ALT, AST was significant. It was 3 to 4 times more elevated. Here, the lactate actually went up to 4.7. And this patient was still on 3 cc per kg. So from 11 p.m. up to about 6 a.m., patients continued on 3 cc per kg. All right. And urine output was documented as ×1. At this point, blood pressure was 110/80, still narrowed. There was still reduction in the right base, and he was still a bit tachycardic, although less. Okay. So this is why they say. So we ideally, what should have happened is when the patient first came and his hematocrit was corrected, should have reduced down the drip to a very bare minimum or even offed it if the patient was taking orally well. So by the time 24 hours later, when he actually went into critical phase, he did not have such a big positive balance at that point, all right? But however, when we really need to actually give him a fluid, we are reluctant to do so because the patient may be, the patient may have ascites, have a pleural effusion like this particular patient, you know. So what we do is we gradually increase the drip, 3 cc per kg, okay, not working, then 5 cc per kg, okay, not working, then 7 cc per kg. But this patient is continuously leaking and is actually intravascular volume depleted. So even if this patient is overloaded, but he's smack in the middle of critical phase, his intravascular volume is low, this patient needs to get that 5 to 7 cc per kg of fluid that he should be getting, right? Because intravascular volume is depleted, and if we don't replenish that, he'll continue to leak, right? So this is what I meant by initially it was actually okay, and then it actually started narrowing around this point here. So this is what narrowing of pulse pressure looks like. So in a non-shock dengue patient, if a patient without comorbidities can actually tolerate orally, adequate fluid intake 2 to 3 liters should be encouraged. So if you don't need to give them, if they're taking orally well, do not give any fluids, all right? Inappropriate intravenous fluid therapy can actually prolong hospitalization and can contribute towards the overload, especially during the time when you actually need to give the patient. So we all agree that this patient is a compensated shock was and pulse rate was very high. You know, everything fits, right? Pulse rate was very high. Of course, peripheries were not documented, but hematocrit was high, lactate went up to 4. So this patient significantly, okay, fitted all the parameters in compensated shock. He also had a narrowing of pulse pressure, right? So he was entering critical phase during that time. So what is a critical phase? So what is the best marker of critical phase? A lot of people have asked us before, what is the best marker of critical phase? So drop in platelet, increase in hematocrit is one of the best markers of critical phase. Sometimes if you don't see white cell count, the lowest white cell count during that time, with lymphocytosis and an increase in liver enzymes can happen during critical phase, can give you sort of like a picture when critical phase sort of started, right? Or if everything else fails, critical phase often occurs after the day of fever, may occur earlier or around the defervescence period, indicated by a rapid drop in temperature. Normally, this coincides with increase in capillary permeability, and patients start developing complications during this time. Why is it important? It's very important because we need to ride the storm during that time, right? So going back to our patient, so hematocrit was 55, platelet was 20, had a bit of hepatitis, worsening hepatitis, sorry. Bicarb was 18, lactate was 4.7. This is when we panicked. So from 3 cc per kg, we gave him 10 cc per kg, all right? Right thing to do, we gave him that, right? And patient improved. Blood pressure from narrowed became better, 120/80. Tachycardia improved slightly. He was lactate reduced from 4.7, went down to 3. Bicarb was about 19. Hematocrit went down, so 55 to 49. Okay, and at this point, warmer peripheries is documented. He was warmer peripheries and reduced air entry. Right now, because we had given him quite a bit of fluids even before he entered critical phase, he was already 4 liters positive balance, and this actually somebody had put in a CBD at this point, so urine output was about 80 cc per hour. Okay, so at this point, all right, clinically peripheries were actually cool. CRT prolonged. You know, they put in a CBD. It's about 300 cc's, CBD inserted, so about 300 cc's is the residual urine, and he was actually given the 10 cc per kg as shown here in the table. And with that 10 cc per kg, he really responded, right? But because he was so positive balance, the drips were actually reduced back to 3 cc per kg and then to 2 cc per kg as the patient was already 4 liters positive balance. Okay, and during this time, yeah, I responded, but he rebounded back again. At this point, lactate did come from 4.7 to 3, but 3 hours later, a repeated blood test actually showed the lactate was worsening again from 3, it went up to 3.5. Acidosis worsened, and platelet was down some more. Hematocrit about the same, 49 went up to 50. Urine output is about 50 cc per hour for about 2 hours or so. Warm, good. CRT is about 2 seconds. You know, pulse rate seems to be good volume, but still a bit tachycardic. All right, and he started becoming a bit tachypnic by then. All right. So after the specialist actually saw the patient with a hematocrit of 50, no, not really budging much with a hematocrit of 50. As you know, his baseline hematocrit was about 44 to 45, right? So this is hemoconcentration, and he is obviously not well yet, right? After a review by specialists, given 7 cc per kg and 5 cc per kg of 1 hour of colloids, okay, as persistent high hematocrit with an increasing lactate. Repeated hematocrit was 40. This is a rapid drop from 50 to 40. HB was 14, platelet was 15. Lactate did not budge much. Lactate was still 3. Bicarb was 18. But blood pressure was better, and tachycardia was about the same. Okay, so what do we think which is actually going on at the moment? All right. So some of the pitfalls that we see was fluids were cut down too fast. All right, because this patient, we achieved what we wanted. The hematocrit came down, but because he had such a big positive balance, we cut down the dip immediately. But the capillary leakage is still ongoing. All right, whatever bleeding or leaking, whatever that's happening at that point is still ongoing. So by cutting down the drip so fast, we are not plugging the holes of which are leaking in the capillaries. You know, not plugging the holes properly. You know, we're pulling back too fast. All right. So we did not recognize that this patient was still was still leaking and requires more fluid. You know, so we cut down the fluid too fast. And of course, it's important for us to time the use of colloid at the right time. All right. So how to use a colloid? So unmask a bleed for decompensated shock, because it restores the cardiac indexes faster and reduces the hematocrit. High hematocrit with massive positive balance and poor reserve. Sometimes what happens is in a saline drip, the molecules are much smaller. So sometimes whatever you give just passes out. Okay, so during this point, in order to retain the fluid in the intravascular space, sometimes we use a colloid. The colloid by anything. It could be albumin, it could be a gelafundin, you know, gelafundin. Some people use albumin or gelafundin, right? Okay, so colloid should not be used as a prolonged infusion, okay, because it can actually cause some coagulopathy. It can cause fluid overload, renal impairment, and of course, patients with severe liver dysfunction can start developing a bit multi-organ failure and coagulopathy if we use colloids at a prolonged infusion, right? So basically here, fluid management, so compensated shock, we give fluid resuscitation with isotonic crystalloids saline, okay, 5 to 10 mils per hour. If they improve after 1 hour of giving, repeat the hematocrit. Okay, another case, sort of like pitfall in this case is the hematocrit estimations actually were very spaced out. So we didn't really know whatever infusion or boluses that we were giving was working or not, right? So it's important to have a pre-bolus blood and a 1 hour later post-bolus blood, right? So if the patient here, after giving the bolus, if the patient improves, okay. If the patient does not improve, then you actually check the hematocrit. Okay, and what are the parameters that you actually look for? You look for improvement in well-being, warm peripheries, capillary refill time, is the BP stable, is pulse pressure better, is tachycardia reducing, is good urine output, is the patient less tachypnic, and of course, we need appropriate estimation of the hematocrit response, as well as to see whether metabolic acidosis is improving or the lactate is reducing or not. Right? So if the patient is improving, yes, and you slowly cut it down, 1 to 2 hours, you slowly cut it down. So if you start with 5 to 7 mils per kg, then you reduce it 3 to 5 mils, and then you reduce it to 2 to 3 mils, and you continue to reduce it over a period of 4 to 6 hours, and with frequent estimation of hematocrit, especially if the patient was very unwell to start off with, right? If the patient is not stable, then you have to act according to the hematocrit level. If the hematocrit doesn't come down, then you may need to give another fluid bolus or consider a colloid as a replacement fluid, right? If the hematocrit comes down but the patient's not stable, then consider transfusion with packed cells as the patient's hematocrit is inappropriately low, but patient is actually unstable, all right? Okay, so check the hematocrit. If the hematocrit is low and the patient's unstable, consider consider packed cell transfusion, okay? If the hematocrit high, you either give a second bolus, either with a colloid or with the crystalloid, depending on how much positive balance that you already have, okay? So in our Mr. JD's case, all right, was bleeding. As hematocrit dropped and he was still unstable with tachycardia, lower limit of normal in urine output, and the lactate was high. Okay, so it was bleeding. Who are high-risk bleeders? They have prolonged shock, they have refractory shock, they have hypotensive shock, or renal or liver failures. Those with persistent metabolic acidosis are given non-NSAIDs, those who have pre-existing peptic ulcer disease, those who are on anticoagulant therapy, who have any form of trauma, including intramuscular injections. Right? Not so silent bleeder, of course, we always have these patients who are coming in late. So just to summarize, case 1, day 4 of illness, compensated shock, decompensated shock, serum lactate is 5, hematocrit is 43, platelets only 5,000, liver is impaired, all right? Thought process is considered bleeding as the hematocrit is inappropriately low in an unstable patient. Second case is day 4 of illness, decompensated shock, serum lactate is 5, hematocrit is 50, platelets 5,000, so impaired liver as well, right? So this patient, you probably need to give up fluid bolus, all right? Fluid bolus first, because patient's probably also leaking at the same time, all right? And get blood on standby while we are giving the fluid boluses. And after you give the fluid bolus, make sure check the hematocrit again, right? Of course, the underlying comorbidities can also make things more confusing. So in decompensated shock, it is advisable to actually start off upfront with colloid because it restores cardiac index better. Hematocrit comes down even faster for us to actually identify patients who are improving or not. So if they are improving, yes or no. So no improvement after the 10 to 20 ml split. You look at the hematocrit. Hematocrit is high, means to give a second bolus. Hematocrit is low, transfuse blood. If the patient improved, then slowly cut down the patient. Okay. If the patient shows no improvement, again go through the same scenario of guided by our hematocrit. If the hematocrit goes down again, of course, consider bleeding at this point. Yeah. All right. When it's not about fluids, all right, there's always some patients in where the intravascular volume is actually quite good. Okay, is well maintained. So peripheries are warm, or CRT is good, you know, or you've given multiple boluses, but whatever problem that you're dealing with is actually not improving, right? So it's time to actually consider other causes of shock. Septic shock, you will have warm, dilated peripheries, may need to, you know, white count may be high, patient may be spiking temperature, may be thinking of some community-acquired and nosocomial infection. Patients who are leaking and bleeding at the same time, these are the patients where you will have high hematocrit, high-ish hematocrit. You will have very high lactate. You give fluids also, hematocrit might still come down the same, but lactate will be persistently high. So these are the patients we might be thinking of leaking and bleeding at the same time, right? Cardiac dysfunction, you'll have patients who are sort of shut down in the peripheries, all right? Hematocrit may never be high, but their blood pressure might be low. Lactates may just linger about 2 to 3 like that, okay? In these patients, of course, the lactate is very, very high, may consider blood transfusion, but these patients generally need to think whether there is cardiac dysfunction, so myocarditis going on, so they need a quick echo or a tropi estimation. for us to see whether this patient will actually benefit from low dose of inotropes or not. And of course, patients with multi-organ failure, we need to shift our thinking to organ failure management. And of course, in patients with cytokine storm, these are patients who have stable hematocrit, worsening markers of hemophagocytic syndrome. These are generally normally CNS and liver, and sometimes even all the organs will be involved, including multi-organ failures, right? Of course, if think normal anion gap acidosis due to too much saline always, especially if patients have hypochloremic metabolic acidosis. Think about starvation ketosis in patients with normal lactate, normal sugar acidosis. Think normal anion gap acidosis in pregnancy, okay? This probably just need to type through, okay? So let's look at a second case. 23-year-old Malay lady admitted to a private hospital day 4 of illness. Fever never settled, was on Panadol, transferred to HSB on day 8 of illness because of worsening transaminitis, right? Upon review, alert, tachycardic, good pulse volume, CRT is less than 2 seconds, warm peripheries, urine output is 100 cc per hour, and she's got the typical dengue rash, right? Lungs showed leaking, okay? Right lower zone reduced entry, crepitations bilaterally, and of course, enlarged liver, right? This is a blood test. Hematocrits 37, 38, 37, 37. So when she was admitted, this is the private blood test. So day 5 of illness, she came in with a hematocrit of 37, platelet was 107. Day 6 of illness, it started going down. Weird enough, when you're actually supposed to see patients' white cell count getting better and the platelets getting better, you start seeing here day 8 of illness, the white cell count comes down, a platelet comes down, AST just plummets up, you know, continues to worsen up to 2,000. INR worsens, lactate 5. So everybody panics, so the patient gets transferred, right? At this point, ferritin is more than 20,000. CRP is not high. Renal profile is still normal at this point, right? Besides dengue, of course, number 1 diagnosis is dengue with hemophagocytic syndrome or a dysregulated immune response, right? Leading to multi-organ failure. But despite that, would there be any other diagnosis? So you have community-acquired sepsis with DIVC. You can have nosocomial infection. You can have dengue shock with bleeding and leaking that wasn't picked up earlier, and now you're just paying for all the multi-organ failures, right? So this was the chest X-ray on admission to Sungai Buloh, and you can see they actually have some evidence of bilateral pleural effusion here going on, right? With so what will you do? Are you going to give blood and fluids? Okay, because you know she's a bit tachycardic, lactate all high, liver all gone, you know, platelets slowly coming down, hematocrit lowish, 30, but you know, it never really budged, right? Dexamethasone, antibiotics, or you're going to give methylprednisolone and antibiotics, or you're going to give methylprednisolone or dexamethasone alone. Okay, since it's a webinar, I'll answer my own question. Okay, so impression, dengue fever with HLH and acute liver injury, basically because there was worsening. This patient was not given any fluids in the private center because she was taking oil quite well. So of course, ischemic hepatitis is always the first instance. So this patient was actually given a fluid bolus, 7 cc per kg over 1 hour, and gradually reduced it. All right. And IV dexamethasone 8 milligrams TDS was actually started. She was started on N-acetylcysteine because INR was actually high, and she was admitted for ICU for close dynamic monitoring. These kind of patients should be in an ICU setting, should have an art line so that you can actually see how well perfused they are, you know, whether they are still fluid responsive or not. They need the echo to see whether they are fluid responsive or not. Sometimes what they do is they lift up the patient's leg. You know, they lift up the patient's leg up for about 45 degrees, keep it for about close to 1 to 2 minutes, and then do an echo to see whether the filling is better or not. So that's positive. Then straight leg test is positive. Then most likely this patient will benefit from some fluids, right? And by day 10 of illness, she was already, so at this point, she was already 2 days of dexamethasone. She was given some fluids, now maintained at a very low level. Lactates responded to the fluid resusc and responded to the dexamethasone, okay? But LFT was worsening, and so was the coagulopathy. At this point, yes, patient was tachypnic because we were giving fluids and she was worsening. Lethargic, GCS was still full, but BB was unsupported at this point, all right? AST worsened from 2,000, went up to 2,638. ALT worsened, total bilirubin also worsened. Ferritin was up to 40,000, LDH was 10,000, lactate was 4.5, at one point INA even failed, right? So it was actually looking like we were losing the gun. So what did we do? We upgraded antibiotics, okay? Obviously, rosapine went up as a sin. We standing orders, KIV for antifungal if the blood pressure drops, off the DEXA, and we switched to methylprednisolone, 500 milligrams. So when that methylpred was started, slowly the AST started coming down. Okay, don't know whether it was a delayed effect from dexamethasone or whether it's methylprednisolone working suddenly, working very well. Not sure, but whatever it is, the AST started coming down. All right, and the LDH also started improving. Of course, ferritin is still fine. Okay, by day 13, however, so these are the, after COVID, we all know these are the side effects of giving a lot of steroids. Patient developed tons of nosocomial sepsis. Okay, BP stable, however, never really required any oxygen. Benchmark 40%. GCS was full. It started going down, and liver function also improved very well, and the platelet normalized almost. Right. She had a stormy state. Multiple antibiotics, even fluconazole was given at that point. Blood cultures were all no growth. And by day 14 or so, she was afebrile, platelets have gone up, ventilation was down to nasal prong. Subsequently, she was transferred to ward by day 16 of illness. And after 8 days in ICU, she was eventually discharged well, right? So why liver failure? Prolonged shock, ischemic hepatitis, this direct cytopathic effect of the virus is another cause. Dysregulated host response, and of course, drug-induced liver injury, and of course, a pre-existing liver damage, right? Suspect true HLH, presence of persistent fever. When you suspect someone actually has dengue, induced HLH, secondary HLH from dengue, right? Persistent fever beyond day 7, patients with multi-organ failure and shock beyond plasma leakage, those with worsening cytopenias, those with very high ferritin levels, 5-figure above ferritin levels, and of course a high triglyceride level and a raised LDH, right? And the three important players are the macrophages, the natural killer cells, and cytotoxic lymphocytes. All of them traditionally, their role is actually to engulf infected cells and to get rid of the body from pathogenic cells, right? But all this leads up to a dysregulated in HLH. All these three players, they become over activated and they lead to a very dysregulated immune response. In turns, that cytokine storm actually ends up causing more of a multi-organ failure to our friends, to our patients. Okay, and this is a study that was actually done in Jozo. It's a collection of 4 cases. All right. And looking at HS score as a predictor of HLH, all right? It may still be under-recognized, so HLH obviously may still be under-recognized. If we do bone marrow evidence, definitely, we may find evidence of HLH, but with very low platelets and so much of coagulopathy, a lot of people might not be very comfortable doing a bone marrow. So more often than not, it's never done. As you can see, we see super high ferritin levels, all right? And HS score probability may be low in some patients, but generally it seems to be the most user-friendly that picks up HLH. Of course, it's not a validated score for infection associated with hemophagocytosis, right? It's not validated for infection, but generally the clinical judgment is what we need to use. So this is a 5-year retrospective single center study, basically looking at all those severe dengues who were admitted with a tertiary intensive care unit. So they looked at 180 cases, and 22% of these patients actually died due to HLH, okay? And at 12% of them had defined as an HLH, only 12% of them actually had a HLH probability of more than 70% according to scorings, right? But 43% actually died. So we know that it actually has a very high risk of mortality. Okay, and the presence of CNS symptoms can also strongly suggest hemophagocytosis, right? And one of description of a patient was peeing on the floor. I couldn't remember me, but could not remember when he first met me. But he knew I sort of exist. He was disorientated to time, a place and person. This patient was red as a chicken, he black chicken, he was red, and then he was spiking temperature, and you could see the liver enzymes going off, and they get a bit confused. So these are quite suggestive of hemophagocytosis. So some of the pearls of care are true hemophagocytosis versus hypotensive, inadequate resuscitation, driving the hyperinflammatory syndromes. Of course, people have used steroids, IVIG, and immunosuppressants in various contexts with various outcomes, right? So the need to normalize parameters often adds to the volume. As you see, with regular dynamic monitoring is very necessary so that we don't jump at every lactate, don't jump at every hematocrit, and keep on giving a lot of fluids for patients, right? Many of them actually require a lot of supportive therapy like CVVH, and they require Lasix, NECs, we need intubation. They're all high-risk bleeders. So at any one point, if there's a drastic drop with hematocrit with a very high lactate, give blood, but don't give continuous blood transfusion. It'll actually lead to more damage than good, right? Watch out for vasculitic bleeds, antibiotics for bacterial translocation, and think about empiric antifungals whenever necessary, okay? And targeted transfusion, as we talked about, and of course, shifting to acute liver failure protocols. Some of the important points in acute liver failure protocols is actually to establish a good, adequate volume repletion, early intubation, all right? And empiric antifungals if necessary, and of course, antibiotics, regular surveillance cultures, and correct all the electrolytes, NEC, and keep sodium 140 and above. This is to avoid cerebral edema, and of course manage the HLH with any of the available therapies. Most common will be steroids, right? And don't forget, not all HLH requires us to do something about it, right? Platelet starts increasing, appetite improves, and AST may peak, but INA starts spontaneously improving. These patients may not need any aggressive treatment, right? So I want to finish off by saying, no one is an expert. Don't forget the basics. Improve the recognition of compensated shock, Don't act on just one parameter. Everything is a therapeutic trial. And of course, these two guidelines are superb in terms of improving our knowledge. With that, I thank you.
Right. Thank you, Yasmin. Thank you very much indeed. Thank you for all the information and data you tried to cover in a short period of time. I know it's extremely difficult because there's so many things to look into. I could see that she was getting a little bit breathless with time. She was rushing to cover so much. Now, there are a lot of questions. Now I really have my work cut out for me because I have to decide what to ask first. Now, a lot of questions on HLH, which is actually the most difficult part of the whole discussion, all right? So I'm going to pick up certain questions that may be more relevant to more generalists before we move on into the ICU area. Okay, I think the common question that came up was the use of colloids. So people wanted to know which colloid replacement would you suggest? I know in your presentation you talk a little bit about it, all right? So they wanted to know what is the role of hypertonic saline, albumin, or as colloid for resuscitation. Maybe you can just give a short discourse about colloid use, Yasmin.
Thanks, Dr. Chris. Sorry, can you all hear me? I think my internet connection is quite,
We can hear you.
A bit unstable. Okay, So generally we use colloid and hypertonic saline. Some people in Sungai Buloh, we don't use much hypertonic salines, but I know in some other ICUs, they do use hypertonic salines, especially when they are in dealing with patients with liver failure and very low sodium, which comes part and parcel of severe dengue in those settings. So I'll talk about it in a conjoint way. So generally colloids are not recommended for continuous infusion. So colloids can actually cause a lot of hypercoagulability. They can actually lead to a lot of multi-organ failures, kidney failures, and all that. So generally, colloids should be used short and sweet. So even in the guidelines, it's very clearly stated when do we actually use colloids. So in patients who come in with decompensated shock, colloids used up front as a cardiac sort of stabilizer. It improves the retention of fluid in the cardiovascular system, right? So we use colloid up front, and it probably helps in restoring the blood pressure better, as well as number two, it can actually also help us to unmask any bleeding tendency. So when I think I mentioned about unmasking bleeding in my presentation, and it's basically patients where we are suspecting a very high risk of bleeding. It's probably bleeding right in front of us, but the hematocrit is so high. So by dropping the hematocrit faster, so it actually also helps to drop the hematocrit faster and more efficiently, because it retains. It's a slightly larger high molecular fluid, so it sort of retains in the vessels better. So in that way, the hematocrit drops faster. So your response to a bleeding is expedited by actually using colloid. So generally, colloid, use it up front when you have decompensated shock, or you're dealing, you have a very high suspicion of bleed and you actually want to unmask the bleed. I would never recommend colloid as a continuous infusion. We've come a long way, Dr. Chris, I'm sure you know, we've come from continuous blood transfusion, we've come from continuous, I remember, 2 cc's of blood transfusions for like 1 day also we've seen, but all this probably will do more harm, just like colloid. So once you get what you want, you achieve whatever you want, I would suggest switching to a normal saline or even Hartmann's, because we also see with a lot of saline transfusions, we also see a lot of hypochloremic metabolic acidosis, and that kind of confuses us a little bit. So sometimes I'll step down to an isotonic saline, or I would step down to Hartmann's for this one. So short and sweet use of colloids and hypertonic salines.
Yeah, thank you, Yasmin. I mean, I just want to echo what you've just said. Remember, colloids, it's a very touch and go use of it. Go in, get what you want, and get out. All right, because leaving it too long, I think we have learned from our past experiences. We have actually major issues with prolonged use of colloids. Right. There are a lot of questions on HLH, so I cannot avoid asking about that. This question here: if a patient who is febrile in critical phase and having leakage, ferritin is more than 500. Is fluid boluses enough, or is there a need to consider methyl-pred, either VIG or plasma exchange?
Right. So I would want to caution again the diagnosis. Number one, caution against the diagnosis of HLH. So like I said, HLH happens later, generally happens later on in the illness. And normally it's when you do not have problems with fluid imbalances. So the patient can be continuously leaking, yes, but you need to correct all the other common things that we see, okay? So if a patient's not enough fluid resuscitated, so resuscitate that first, fluid boluses first. Correct the volume deficit first. If you have patients with your ferritin may be more than the HLH that I've seen. The ferritin is normally more than 40,000, more than 50,000, or it's not even red. If we don't routinely do ferritin for all our patients in the critical phase and everything, and maybe if we do those markers, you can actually see probably a very high ferritin as well. But you have not corrected the volume deficit or the common mistakes, common scenarios that we actually see in patients with dengue shock, right? So you need to get them out of the shock. You get them out of the shock with either fluid boluses, with blood transfusion, or whatever problems that you see. So generally, those two are the ones. And when they have restored their cardiac index and you are no longer suspecting patients are having any fluid deficit. So for example, forget about the platelet. For example, the hematocrit is stable, pulse volume is good, the peripheries are warm, blood pressure is stable, but you have still a guy in danger. So liver enzymes will start worsening, your white cell count and your platelet may not really recover, your ferritin comes back as 5-digit, very high. These are the patients that we consider they are actually having HLH, right? So one of the most common problems that we see in HLH is liver failure, right? Liver failure and CNS abnormalities. So sometimes these patients are actually intubated, right? Probably because of cerebral edema, they get intubated, or because of restlessness, they get intubated. And you can see that the liver enzymes are actually going into the thousands with worsening of INR. So these patients, we will start steroids. Now, we've tried dexamethasone. Our first one is always Dexa. We were quite comfortable using dexamethasone. Most patients do not require anything. They actually get better, right? By themselves, they get better. These are the patients where the INR never goes up. INR is still within the normal limit. So I'm not worrying that this patient actually has liver failure. But some patients actually go into acute liver failure. This is where you need to switch to acute liver failure protocol. When we switch to acute liver failure protocol, sometimes we start dexamethasone. So it's not very clear to actually answer this question. I need to go all through these scenarios before I can actually steer you towards my thinking, all right? So we start dexamethasone, and sometimes they get better, and sometimes they don't. They continue to worsen, like the case that I showed. And this time, we actually try high doses of methylpred. We actually tried methylpred. Our ICU colleagues have tried IVIG before, but the problem with IVIG is a lot of fluid. They give a lot of fluid. So normally IVIG is accompanied by multi-organ involvement. So by this time, patients in ICU, actually from the start itself, patient would have been in ICU already. They would have given CVVH and probably have to extract all those fluids because most of these patients are overloaded. They probably have a lot of ascites, so you need to balance it. So IVIG has been used before. Now we have tried using etoposide before. Etoposide is something that has been used in secondary HLH caused by EBV, and we sort of have an ongoing study that's actually going on, and we've had variable successes with etoposide before. IVIG plasma exchange, I'm probably not the right person. ICU colleague.
Right. Okay. Yasmin got cut off, is it? I think. Right. Yasmin, you back with us?
Sorry, Dr. Chris. Sorry.
Okay. We know somebody been pay internet bills now. We know who. Okay. Right. I know you tried to cover a lot of HLH, and there are a lot of questions regarding that. But I think you have generally covered an overview about all the questions related to HLH. Yeah. I just want to re-emphasize what Yasmin has said just now. Make sure volume is adequately sorted out before jumping the gun. All right. I think that's always standard teaching remains true. Make sure volume is adequately addressed. And if you are thinking, and if all those parameters suggest as HLH and suggestive of it, I think if you're considering intervention, as you mentioned, DEXA usually is first. If not improving, then perhaps you can try methylpred. The others becomes a little bit esoteric, let's be frank, at the end of the day, all right? So it's not in the normal use. I just want to ask one more question before we cut to the break, because we are a little bit short of time, because there are so many questions I want to keep Yasmin longer. That's my way of bullying her anyway. Yasmin, we have a lot of patients, especially the older patients with dengue nowadays, and many of them come in with poorly controlled diabetes. And the question here was, I'm I'm not sure how to interpret this question, but the question here, any cutoff points of platelets level that are preferable for IVI insulin instead of sub-Q? I think they are worried about bleeding as far as sub-Q is concerned. But perhaps that's not the major issue here, but maybe you want to say a few words about managing dengue in patients with uncontrolled diabetes, plus minus renal failure, things that we see on a regular basis.
Yeah, so I suppose if we've used subcut insulin before, there's no real cutoff for platelet, because it is subcut injections and the risk of intramuscular injury is very low. But of course, in some patients, we've had a lot of patients with diabetic ketoacidosis, right? Or that's health managed, diabetic ketoacidosis and severe dengue, never sleeping the night. So when we have patients like that, we do start on IVI insulin. And but the risk of once they're corrected, we do switch over to subcut insulin. I know even in ICU setting, they still use subcut insulin only when it comes to, when you're having trouble controlling the diabetes. We use IVI insulin. Generally, we're fine with subcut, but of course, if the method is not right and you start seeing a lot of bruises, I suppose it's okay to go into IVI insulin. So I have no real recommendation when it comes to this, right? Renal failure patients, chronic liver disease patients, patients with a lot of comorbidities like heart failure and all that, go back to the basics of dengue, right? That's why I say never act on a single parameter. Don't be pushed to try and normalize every single abnormal investigation that you have to see. So you need to make it a holistic decision. So these patients, generally, I would avoid fluids if I can, but if the patient's entering critical phase and we're dealing with your standard hematocrit increasing, lactate increasing and stuff like that, and you have a patient with end-stage renal failure right in front of you, give the lowest level. So sometimes we say 5 to 7 cc per kg or 7 to 10 cc per kg, right? So give the lowest level of cutoff fluid boluses, right? If there's 5, just give 5 cc per kg and try to use infusions, try to use fluids that have a better capability of getting a quick response. So in this case, I may use albumin. Some people use albumin, may use albumin. I'll start off with saline. It doesn't work. I'll quickly switch to something like a colloid or albumin that helps me achieve what I want, cepat. So I do that, and I will always give. I'll be quite judicious with the fluids that I give.
Okay, Yasmin, sorry I'm holding you back because there are a lot of questions.
Might cut off again?
No, you're not cut off. You're fine. I just want to ask one question that's a bit off.
Hello, can you hear me?
Yeah, we can hear you fine. So the last question for you, all right, and we have not talked about it because we assume people are fairly clear about the use of platelet transfusion. The question today here is, would you give platelet transfusion if the platelet levels is 2,000? So maybe you want to say a few words about the role of platelet transfusion and when you would consider giving it. Yasmin? Okay, can someone hear me as well? Am I cut off? I'm not sure now. Oh dear. Secretary Ching Hu, am I still on? Oops. Yasmin, are you back?
Yes, I'm back. I'm really sorry, Chris.
Oh, I thought it was me. I got worried. I thought I was talking to myself, which happens a lot nowadays. I'm old already. Okay, Yasmin, did you hear my last question about this question? Just mention something about role of platelet transfusion to be clear about this.
Right.
We haven't
so we
addressed this very much.
So we don't routinely give platelet transfusion, everyone, okay? Generally, when patients get admitted to ICU, sometimes we do, my intensivist generally does give platelets because they're trying to put in lines and stuff like that, right? So platelet transfusion per se, just responding to a platelet level, I think there are enough evidence out there that it doesn't really work. I saw another a question there about which is better, platelet apheresis is better or platelet concentrates are better. Generally, platelet transfusion is only used in the context of several things. My ICU uses it, like I said, to establish lines and make sure to minimize bleeding and stuff like that, or as a part and parcel if somebody is actually acutely bleeding in dengue. But even then, in an acute bleeding, I've had a lot of discussions with a lot of hospitals where they give platelet. No, in acute bleeding, you actually give blood first. You do not waste time in giving platelet transfusions and FFP and all that. You need to give blood first. And then if continuously the patient is bleeding, then of course, if there are a lot of factor deficiencies and stuff like that, then we will give DIBC screen lab for these patients. So they're used as part and parcel of the DIBC. Routine platelet transfusion, just to increase the platelet count, has never altered a patient's outcome. So I would strongly suggest against it. But as a part and parcel of an acutely bleeding patient, or just a little bit of platelets to establish lines. That's about it.
Right. Okay. Thank you, Yasmin. Sorry, so many questions. Not my fault. They keep asking a lot of questions, which is good. So once again, thank you, Yasmin, for the time and the effort that you put in and all your energy trying to answer all the questions. Just goes to show there's still a lot of things that we have to revisit as far as dengue is concerned. I just want to end Yasmin's session here by reminding something that she talked about a lot during the initial period. Please monitor the patients through and through in a systematic fashion over time, because it is dynamic. Things can change easily. You might start a regimen at 7 a.m., but by 10 a.m., that regimen may not be relevant anymore. So please monitor them well. So with that, thank you, Yasmin. Thank you. All right. Okay. Now, yes. Okay. And do pay your internet bills, please, quickly. I mean, KKM can afford that now. Oh dear. Did I say that? Right. Just we have to stop for a break now because apparently MyICID wants to give me a virtual coffee. So Casey, please send my coffee over to my house. We will break for 10 minutes. And if I'm not mistaken, it's 10:20 now. Can we come back at 10:30? Because the next topic is pretty cool. That is talking about COVID-19 versus dengue. How do we differentiate the two severe diseases? And this will come. This is already beginning to happen, and it will come. These two epidemics or these two diseases will meet in Malaysia. This will be presented by Dr. Ong Hang Ching from UMMC. So do join us at 10:30. Thank you very much. Enjoy your coffee.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh and salam sejahtera. World Health Organization has defined 20 diseases as neglected tropical diseases that require direction and planning from all parties to formulate a strategic plan to control, prevent, and eliminate neglected tropical diseases. Dengue is one of the neglected tropical diseases listed in the Roadmap for Neglected Tropical Diseases 2021 to 2030. Over the past 4 decades, the global dengue burden has increased exponentially. It has largely contributed to climate change, with the global warming phenomenon having directly impacted dengue transmission dynamics. Dengue remains a public health threat amid the COVID-19 pandemic, not only in Malaysia, but globally, particularly in the tropical region. More countries situated in the temperate regions have reported local transmission of dengue during the recent 10 years. In the absence of an effective treatment or vaccine against deadly virus, the dengue control program in Malaysia focuses on public health measures for early case detection and integrated vector management. Malaysia is the first dengue endemic country globally to evaluate Wolbachia efficiency under real-life conditions by assessing epidemiological and entomological endpoints. The Ministry of Health conducts community engagement sessions from time to time to raise public awareness on dengue threats and empower individuals to maintain Aedes-free environment in the neighborhood. community participation is crucial in curbing domestic mosquito breeding and virus transmission. Hence, we would like to emphasize to the public 3 essential components in fighting against dengue at the household level. Firstly, search and destroy any potential Aedes mosquito breeding site by conducting frequent inspection and cleaning at own premise. Secondly, self-protection against mosquito bites via the use of indoor aerosol, mosquito repellents during outdoor activities, and taking extra precautions when traveling to dengue outbreak area. And last but not least, the individual who experiences signs and symptoms suggestive of dengue, such as fever, muscle ache, joint and back pain, and rashes, are advised to seek early treatment. In line with the celebration of the 3rd annual World Neglected Tropical Diseases Day 2022, Malaysia has opted to champion dengue disease. This shows our commitment towards combating dengue together with the rest of the world. We earnestly hope that Malaysians will keep our country safe from dengue. Let's beat neglected tropical diseases together.
Established in 1998 and formerly known as Clinical Research Center, the Institute of Clinical Research, or ICR, is one of 6 research institutes under the National Institute of Health, Ministry of Health, Malaysia. From humble beginnings, the institute witnessed growth and expansion over the years and now comprises of 5 centers and a network of 36 branches in major hospitals across the nation, including periphery in Sabah and Sarawak. Strategically located within the National Institute of Health's headquarters in Setia Alam, ICR comprises a welcoming, modern, multifaceted structure with shared state-of-the-art facilities. With a deeply rooted mission to improve patients' health outcomes through ethical and quality clinical research, ICR positions itself as an institute that provides patients access to leading research in medical and surgical fields.
As a national institute, ICR's primary core role is driven by critical strategic, interrelated functions such as providing leadership in development of clinical research capacity.
Establishing and maintaining clinical database has additionally been an imperative and ongoing functions for the institute as they continue to deliver for the Ministry of Health.
Attributes of CRC Hospital is that there are different specialties of research within each of CRC. For example, CRC Sarawak is renowned for its cardiology research, CRC Ampang for its hematology research, and CRC Sultanah Bahia for their hepatology related research.
As part of their objective to provide ethical and quality research, ICR takes pride in coordinating the conduct of industry-sponsored research, while additionally promoting the conduct of investigator-initiated research.
The Institute continuously establishes collaboration with local, regional, and international research organizations in the pursuit of excellence in clinical research for the country. Through these collaborations, the Institute for Clinical Research is also able to facilitate the establishment of hospital clinical research centers. These interrelated core functions go on to fundamentally converge into one overarching principle, that is to provide research that matters for patients.
The Institute of Clinical Research essentially operates under different areas of expertise: clinical trials, bioavailability and bioequivalence study, BABE, clinical epidemiology, national healthcare surveys, digital health research and innovation. More importantly, the scope of research is not only confined to these specific areas. The Institute acts as a platform that provides an entire ecosystem of clinical research for medical professionals and academia in Malaysia, both public and private. Together with its unique attribute of being a civil, service-driven institute, ICR is poised to become a leading clinical research institution in Asia. As ICR continues to lead nationally, the Institute is also no stranger to making its mark in the global healthcare and medical industry. Through its clinical research and trials, Malaysia has become the first country in the world to provide affordable tablet treatment for hepatitis C. This is a step in the right direction as the Institute further solidifies its commitment in translating medical innovation into the very essence of its motto, providing research that matters for patients. Built upon a strong foundation and strategic functions to providing leading research in medical and surgical fields, the path is set for ICR to continue creating global impact and become a leading clinical research institution in the face of Asia.
Hi everyone, welcome back. Thank you for staying on with us. Hope you had your coffee. I had to make mine, so it's just so sad, isn't it? But let's go back to happier things and move on with our webinar this morning. As I mentioned just now, we're going to discuss a very important topic and relevant topic as we move out of, hopefully, begin to move out of the COVID-19 pandemic. We will expect to see more patients with dengue coming in this era of COVID-19, and how do we differentiate these two diseases that both can cause life-threatening situations. Now, to address that, we have Dr. Ong Han Ching, who is an up-and-coming ID physician from UMMC. Dr. Ong finished his postgraduate in 2015 and joined UMMC in 2018 as an ID fellow. He has a special interest in tropical diseases and has been involved in studies looking at amyloidosis and dengue. And I think some of you who have attended dengue workshops or training courses would have seen Dr. Ong in some of them. So with that, I would like to invite Dr. Ong now to speak to us about COVID-19 versus dengue, differentiating the two severe diseases. Dr. Ong, you have the floor.
Good morning to all the participants of today's webinar. And a very good morning to the distinguished panels of moderators, Dr. Christopher Lee, Dr. Chow, as well as Dr. Patrick. Today, I will be talking about COVID-19 versus dengue fever and how do we differentiate these two severe diseases. These are the outline of my talk for today. So I will start with introduction of both the diseases. Then we will talk about the epidemiology of dengue as well as COVID-19, the similarities of both these diseases, the differences of both diseases, the management outline of both diseases in terms of similarities as well as differences, the prevention measures of both diseases, and lastly, the conundrums of both these diseases. Let's start with dengue fever. Dengue is a viral infection transmitted to humans through the bite of infected mosquitoes. The primary vectors that transmit the disease are Aedes aegypti and, to a lesser extent, Aedes albopictus mosquitoes. Dengue is found in the tropical and subtropical climates worldwide, mostly in urban and in suburban areas. There are 4 dengue virus serotypes, namely DenV1 to DenV4. And it is possible to be infected 4 times. While many dengue viral infections produce only mild illness, dengue virus can cause an acute flu-like illness. Occasionally, this develops into a potentially lethal complication called severe dengue. Dengue is caused by a virus from the Flaviviridae family, and there are 4 distinct but closely related serotypes of the virus that cause dengue. Recovery from infection provides lifelong immunity against that serotype. However, cross-immunity to other serotypes after recovery is only partial and temporary. Subsequent infection, which is also known as secondary infection by other serotypes, increase the risk of developing severe dengue. Dengue virus is roughly spherical. Inside, there is a nucleocapsid which is made up of the viral genome and C proteins. The nucleocapsid is surrounded by viral envelope, a lipid bilayer taken from the host. E and M protein is embedded in the lipid bilayer. The diagram on the right depicts the replication of a dengue virus. The virus attaches to host cell and enters the cell via endocytosis. Once deep inside the host cell, the virion fuses with the endosomal membrane and is released into the cytoplasm. The viral particles come apart and releases the viral genome. The viral RNA is translated into a single polypeptide, cut into 10 proteins, and is then replicated. Then the viral assembly occurs on the surface of the endoplasmic reticulum. Now, let's look at the global incidence of dengue fever. Although an estimated 100 to 400 million infections occur each year, over 80% are generally mild or asymptomatic. 96% manifest clinically, with 70% of actual burden is in Asia. Increasing incidence eightfold over the last 20 years, whereby 505,000 cases in 2000 rose to 2.4 million cases in 2010. And it increases further to 5.2 million in 2019. Africa, the Americas, the Eastern Mediterranean, Southeast Asia, and Western Pacific are the main places where dengue fever occurs. Now, how about in Malaysia? A total of 490 cases with no deaths were reported during the week of 47 in 2021. As of November 2021, the cumulative number of reported cases was 23,547 cases. This is a significant decrease of 73% compared to the same period in 2020. A total of 18 deaths due to dengue have been reported in 2021 as compared to 137 deaths during the same period in 2020. This diagram shows the vector of dengue virus, which are the Aedes aegypti on the left, as well as Aedes albopictus on the right. On the bottom of the diagram, it shows the eggs of the Aedes mosquitoes. An adult female mosquito lay their eggs on the inner wet walls of containers with water above the waterline. And mosquitoes generally lay about 100 eggs at a time. The eggs are very hardy. They stick to the walls of a container like glue and can survive drying for up to 8 months, even over the winter in the southern United States. It only takes a very small amount of water to attract a female mosquito. This slide shows the life cycle of an Aedes aegypti mosquito. The Aedes mosquitoes have 4 life stages: the eggs, the larvae, the pupa, and adult. Mosquitoes can live and reproduce inside and outside homes. The entire life cycle from an egg to an adult takes approximately 8 to 10 days. Bowls, cups, fountains, tires, barrels, vases, and other containers that can store water makes for a great mosquito nursery. Dengue causes a wide spectrum of disease. These can range from subclinical disease. In some cases, people may not know that they are being infected, to severe flu-like symptoms in those infected. Less commonly, some people develop severe dengue, which can be any number of complications associated with severe bleeding, organ impairment, and/or plasma leakage. Severe dengue has a higher risk of death when not managed appropriately. Today, severe dengue affects most Asian and Latin American countries and has become a leading cause of hospitalization and death among children and adults in these regions. Dengue fever is categorized as dengue fever without warning signs, dengue fever with warning signs, and severe dengue. The common symptoms are fever, nausea, vomiting, rashes, body ache or joint ache and pains, leukopenia, and the warning signs are abdominal pain or tenderness, persistent vomiting, persistent diarrhea, clinical fluid accumulation, mucosal bleeding, lethargy, confusion, restlessness, tender liver, laboratory increase in hematocrit, concurrent with rapid decrease in platelet counts. And severe dengue is defined as having a shock, or fluid accumulation with respiratory distress, or severe bleeding, or severe organ involvement. And this is defined as having a transaminitis with AST or ALT of equal or more than 1000. There is impairment of conscious level and heart or other organ involvement. After an incubation period of 4 to 7 days, which can range from 3 to 13 days, there are 3 phases of dengue fever. The critical phase often occurs after the 3rd day of fever, but it may also occur earlier or around effervescence, indicated by a rapid drop in temperature. This coincides with an increase in capillary permeability. In other viral infections, the patient's condition improves as the temperature subsides, but the contrary happens in severe dengue infection, wherein the patient may deteriorate and manifest third space plasma leakage or organ dysfunction. The critical phase lasts about 24 to 48 hours. Thrombocytopenia and hemoconcentration are usually detectable in this phase. Recovery or reabsorption phase is when plasma leakage stops and is followed by reabsorption of extravascular fluid. Patient's general well-being improves, appetite returns, gastrointestinal symptoms improve, hemodynamic status stabilizes, and diuresis ensues. Some patient may have a classical rash of Isles of Wight in the Sea of Red with generalized pruritus. So how do we diagnose dengue fever? Diagnosis can be made by detection of viral components directly or indirectly by detecting the antibodies that the body produced. NS1 protein is a hallmark of flavivirus infecting mammalian cells. It can be found in dengue, yellow fever, and West Nile virus infection. False positive results have been reported in chronic diseases and hematological malignancies. The detection rate of primary infection is 75 to 97%, whereas in secondary infection, it is 60 to 70%. The sensitivity of NS1 antigen detection drops from day 4 to 5 of illness onwards, and it is undetectable in the convalescent phase. If it continues to be present, it may predict severe dengue. Dengue viral RNA detection is a molecular method that utilizes reagents that will target specific genomes of the virus to enable amplification and detection of the target genome. The method is useful only during the viremic stage of the disease and can detect the viral RNA target up to 5 days after onset of symptoms. This test is highly technical and is only done in a few centers as it requires a highly specialized lab and highly trained personnel. As for virus isolation, the few facilities that are able to isolate dengue viruses are IMR, National Public Health Laboratory, and University Malaya Medical Center for Research. This technique is mainly used for surveillance and genotyping purposes. How about indirect tests? Serological tests such as the detection of IgM in a single specimen obtained from a patient with a clinical syndrome consistent with dengue is widely used to establish a presumptive diagnosis. The diagnosis may be confirmed via IgM seroconversion between paired acute and convalescent sample, which is obtained 10 to 14 days after the acute phase specimens. A diagnosis of acute dengue viral infection may be established by a 4-fold or greater rise in antibody titers. How about the management of dengue fever? Dengue management is done mainly as outpatient, but in certain patients, they have to be admitted for inpatient care. So When will the patient be admitted? If the patient is able to tolerate orally well, not staying alone, does not have warning signs, and not having any special situations, such as staying far away from healthcare facilities, no transportation to come to a healthcare facility, etc., they can be considered to be managed as outpatient and monitored by the primary care doctors in the health clinics. However, if they have the signs above, then admission is warranted. Management of dengue fever generally revolves around fluids. If the patient is able to tolerate orally, they need to be encouraged to take oral fluids as adequately as possible. If there are warning signs, then maintenance intravenous fluids, mainly crystalloids, is probably needed. If there are signs of compensated or decompensated shock, then boluses with frequent reassessment is vital. If there are signs of bleeding, then blood products should be given. How about dengue vaccine? The first dengue vaccine in the world, the Dengvaxia, was developed by Sanofi Pasteur and licensed in December 2015. It has now been approved by regulatory authorities in about 20 countries. However, a pre-vaccination screening is required to determine a previous dengue virus infection before someone is eligible for this vaccine. This is because in November 2017, the results of an analysis to retrospectively determine the serostatus at the time of vaccination was released. The analysis showed that the trial participants who was seronegative at the time of first vaccination had a higher risk of more severe dengue and hospitalizations compared to unvaccinated participants. There are several additional dengue vaccines under evaluation. So how did this happen? If a person who has never been infected with dengue virus is vaccinated, as shown in this diagram, they skip the first natural infection. If the person is then infected after vaccination, they will experience an infection that is similar to the second dengue virus infection, which poses the highest risk for severe disease. What is causing greater severity of the second dengue virus infection? This includes antibody-dependent enhancement, which can lead to plasma leakage and severe disease. However, if a child who has been previously infected with dengue virus is vaccinated, the child skips the second dengue virus infection. If is infected after vaccination, in this scenario, the child will experience an infection that is like the third or fourth dengue viral infection, which has the lowest risk for severe disease. Next, let's talk about hemophagocytic syndrome in dengue. Hemophagocytic syndrome is a potentially fatal syndrome. It is caused by extreme immune activation leading to cytokine storm. There is an increase in interleukin-2, TNF-alpha, interleukin-6, and interleukin-8, interferon gamma, which was generated by uncontrolled activation of histiocytes and T cells. The clinical cause is generally severe and may sometimes mimic sepsis. In milder forms, it recovers spontaneously. Severe hemophagocytic syndrome may need IV methylprednisolone or dexamethasone and KIV intravenous immunoglobulin. It commonly presents with an unexplained persistent fever or resurgence of high-grade fever after an initial defervescence. Other presentations are hepatosplenomegaly, rash, bleeding, central nervous system manifestations, and jaundice. As for dengue prevention and control, there are a few principles that we need to adhere to. We need to prevent the breeding of mosquitoes. This can be done by removal of uncovered water containers, old tires, and other containers which may store water, as dengue mosquitoes require just a little stored water to lay eggs, and the eggs are very, very hardy. Then we can use personal protection from mosquito bites, such as wearing of long sleeve shirts and long pants, preferably with mosquito repellents, are highly recommended. Engagement of community is important to eradicate the breeding sites of mosquitoes, and active mosquito and virus surveillance by the health authorities can be very helpful. Next, let's look at COVID-19. COVID-19 is an infectious disease caused by the SARS-CoV-2 virus. Why is COVID-19 important? Isn't it just another flu? Well, there has never been so many deaths in such a short span of time attributable to one single virus like this before. With the entire healthcare system literally collapses, with no ambulance to go around, no hospital beds, no space even in the mortuary to put bodies of those who died from COVID-19, you know, this is a big deal. The entire planet Earth was turned topsy-turvy by this virus. Many businesses had to close down, borders of countries had to be shut down, vehicles had to be stopped. Everybody must take vaccines. Everybody must mask up. Then vaccine again. And then vaccine as a booster again. Up to 8 February 2022, there are a total of 398 million confirmed cases of COVID-19 and 5.76 million cases of COVID death worldwide. In Malaysia, there are a total of 2.9 million cases of COVID-19 and a total of 32,000 COVID deaths up to 8th of February 2022. So what is a coronavirus? Coronavirus are widespread among birds and mammals, with bats being host to the largest variety of genotypes. COVID-19 is a novel coronavirus discovered at the end of 2019 and was previously designated 2019 nCoV. This is the phylogenetic tree of coronaviruses. The contents in bold or italic red font is the latest edition of newly emerged SARS-CoV-2 virus. The phylogenetic tree shows the relationship of SARS-CoV-2 to selected coronavirus is based on nucleotide sequences of the complete genome. The viruses are grouped into 4 genera, which are the alpha coronavirus, beta coronavirus, gamma coronavirus, and delta coronaviruses. The subgroup clusters are labeled as 1A and 1B for alpha coronaviruses, and 2A, 2B, 2C, 2D for the beta coronaviruses. This tree based on the published trees of Coronaviridae and reconstructed with the sequences of the complete RNA-dependent RNA polymerase coding region of the representative novel coronaviruses. This is a schematic diagram of a coronavirus showing the spike protein labeled S, the membrane protein labeled M, envelope protein labeled E, and nucleocapsid protein labeled N. It is a medium-sized envelope positive stranded RNA viruses whose name derives from their characteristics crown-like appearance in electron micrographs. It has the largest known viral RNA genomes with a length of 27 to 32 kb. The host-derived membrane is studded with glycoprotein spikes and surrounds the genome, which is encased in a nucleocapsid that is helical in its relaxed form, but assumes a roughly spherical shape in the virus particle. This diagram shows a group of coronavirus particles negatively stained with phosphotungstic acid. Some variation in size is seen, but shape is relatively uniform. It has a magnification of 144,000 times. As for variants of coronaviruses, why are there so many variants? This must be the question that has been playing in our minds in recent months. Scientists monitor all variants, but may classify certain ones as variants being monitored, variants of interest, variants of concern, and variants of high consequence. Some variants spread more easily and quickly than other variants, which may lead to more cases of COVID-19. An increase in the number of cases will put more strain of healthcare resources, leading to more hospitalizations and potentially more deaths. So how are they classified? They are classified according to their ability to spread, the severity of symptoms, how the variants respond to treatment, and how well vaccines protect against the variants. Two of the famous examples of variants of concerns are the Omicron and the Delta. What are the symptoms of COVID-19? I think we all are familiar with the symptoms of COVID-19 by now. They include fever or chills, cough, shortness of breath, fatigue, muscle or body aches, headache, new loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting, as well as diarrhea. The patient also can have difficulty in breathing, persistent pain or pressure in the chest, confusion, delirium, or cyanosis. COVID-19 is staged according to the severity of symptoms. Stage 1 means the patient is asymptomatic. Stage 2 means the patient is symptomatic with no pneumonia. Stage 3 means the patient is symptomatic with pneumonia but does not require oxygen. Stage 4, symptomatic with pneumonia and requiring supplemental oxygen. Stage 5 means the patient is critically ill with multi-organ involvement. How do we diagnose COVID-19? Respiratory specimens can be taken for nucleic acid amplification testing, such as reverse transcriptase polymerase chain reaction or RT-PCR, repetitive testing of upper respiratory tract or lower respiratory tract specimens might be needed. If deceased, we can consider the collection of post-mortem specimens. SARS-CoV-2 antibody tests are not recommended for diagnosis of current infection with COVID-19. There are few risk factors which are found to be associated with more severe disease. These include age of more than 60 years, non-communicable diseases such as diabetes, hypertension, cardiac diseases, chronic lung disease, cerebrovascular disease, dementia, mental disorders, chronic kidney disease, immunosuppression, HIV, obesity, and cancer have all been associated with higher mortality in COVID-19. Smoking, higher SOFA score, and higher D-dimer on admission were associated with higher mortality as well. In pregnancy, increasing maternal age, a high BMI, a non-white ethnicity, chronic conditions, and pregnancy-specific conditions such as gestational diabetes and preeclampsia are also associated with more severe COVID-19. This slide shows the warning signs that may predict deterioration. Clinically, The patient might have persistent or new onset fever, persistent symptoms, reduced level of consciousness in absence of alternate explanations, respiratory compromise. In terms of laboratory values, a rising CRP value or a single CRP value of more than 50 milligram per liter, dropping absolute lymphocyte count, or neutrophil lymphocyte ratio of more than 3.13 are also associated with more severe COVID-19. In terms of radiological features, features of severe pneumonia with multilobular involvement or rapidly worsening chest X-ray is a warning sign that predicts deterioration. As for the management of COVID-19, isolation measures is important. In cases of mild COVID-19, symptomatic treatment with antipyretics are generally adequate. Nutrition and rehydration is important as well. For moderate COVID-19, patients can be treated as for any other viral pneumonia. For patients at high risk for deterioration, isolation and management in a hospital setting is preferred. How about antivirals? Favipiravir has been used by us for COVID-19. There are new drugs such as nirmatrelvir, ritonavir, and molnupiravir for COVID-19. Corticosteroid is an important tool for us to manage COVID-19. However, corticosteroid is not recommended in non-hypoxic cases unless they are used for other indications. It can be used for category 4 COVID-19, and the main drug of choice are dexamethasone phosphate, 8 mg. If the patient has a BMI of more than 30, then 12 mg is appropriate. A total duration of 10 to 14 days or until the patient is being discharged can be given. A step down to oral dexamethasone should be done once there is improvement. Antivirals can also be given together with immune modulators. Dexamethasone and IV remdesivir 200 mg loading and 100 mg daily for 2 to 5 days is recommended. Corticosteroid and tocilizumab, or corticosteroid and baricitinib, if tocilizumab is not available, are recommended. As for the prevention of COVID-19, we need to get the people vaccinated. SOPs has to be adhered to. People has to stay at least 1 meter apart from each other. Properly fitted masks need to be worn, especially when physical distancing is not possible or when in a poorly ventilated settings. Choose an open, well-ventilated spaces over closed ones wherever possible. If indoors, open the windows. Hands should be washed regularly with soap and water or clean them with alcohol-based hand rub. Cover the mouth and nose when coughing or sneezing. And if someone is unwell, they should stay at home and self-isolate until recover. As for the vaccination effort worldwide, up to 25th of January 2022, there has been 9.6 billion doses of COVID vaccine being administered. The situation in Malaysia has been encouraging. There has been a total of 63.4 million doses of vaccine administered up to 30th of January 2022. In addition to that, there has been 11.8 million doses of booster doses being given to the Malaysian population. Let's put the two diseases, the dengue fever and the COVID-19, side by side, and let's look at their similarities and differences. What are the similarities of these two conditions? Well, both are caused by viruses, both cause fever and myalgia. Both of these diseases cause symptoms that range from mild to severe. This paper looks at the differences between COVID-19, influenza, and dengue fever. The clinical presentation of COVID-19 patients ranges from asymptomatic to mild, non-specific acute symptoms such as fever, dry cough, and fatigue. Close to 20% of COVID-19 cases may be severe. Influenza is prevalent globally and remains an important cause of morbidity and mortality from respiratory virus infection. While dengue is prevalent in tropical countries with geographic expansion. From this study, it shows that shortness of breath and diarrhea were more common in COVID-19 patients than in influenza patients, while fever, cough, running nose, and sore throat were less common. Cough, shortness of breath, running nose, and sore throat were more common in COVID-19 than in dengue patients. A lower proportion of COVID-19 patients had fever, diarrhea, muscle ache, fatigue, malaise, abdominal pain, bleeding, conjunctivitis, headache, joint pain, skin rash and vomiting, nausea compared with dengue patients. Who are at risk of these two conditions? For dengue fever, travelers or locals in tropical and subtropical regions are at risk. Someone who has previous dengue infection are at risk of more severe dengue if they are infected again. As for COVID-19, traveling to or living in an area with uncontrolled community spread of the virus is a risk factor. Seniors and those with underlying medical conditions put this group of patients at risk of more severe COVID-19. So what are the differences? Can you tell them apart? In terms of transmission, dengue is transmitted via mosquitoes, whereas COVID-19 via infected droplets. How to protect against COVID-19? Well, to protect against infected droplets, one is advised to wear masks, wash their hands regularly, avoid crowded areas, especially indoors, and physical distancing. On the other hand, how do we protect against dengue? We have to remove mosquito breeding areas. We have to wear long sleeve clothing and use mosquito repellents. Lastly, let's talk about the dengue and COVID-19 conundrums. I am sure false positive dengue serology is a big issue to many of us. The serological tests for dengue have been shown to cross-react with other flaviviruses such as JE, other non-flaviviruses such as malaria, leptospirosis, toxoplasmosis, and syphilis. And it can also test positive in certain connective tissue diseases such as rheumatoid arthritis. 22% of COVID-19 infections may be falsely identified as dengue. This may lead to spread of COVID-19 infections due to lack of isolations, as well as vaccination of dengue-naive individuals. Given that a possible cross-reactivity between dengue virus and SARS-CoV-2 could lead to false positive results for both diseases, this paper aimed to assess the magnitude of such possible cross-reactivity in a large cohort of individuals who were known to have either SARS-CoV-2 or dengue virus. This paper analyzed clinical data and serum samples from 55 individuals with severe acute respiratory syndrome coronavirus 2 infection. To assess dengue serology status, they used dengue-specific antibodies by means of lateral flow rapid tests as well as ELISA. Additionally, SARS-CoV-2 serology status in patients with dengue was performed and in silico protein structural analysis to identify epitope similarities was done. Structural similarities is predicted to be a factor to cause cross-reactivity. Comparison of folds of chains and structures that are known to be in the outer surface of a protein antigenic cross-reactivity between dengue and COVID-19 raises questions regarding the possibility of protective immunity overlap between these two diseases. On the one hand, or worsening of a disease through antibody-dependent enhancement on the other hand. Finally, observation of structural similarity of specific SARS-CoV-2 and dengue protein structure could explain the observed cross-reactivity. These results suggest that protein structure similarities, regardless of genetic distance, could predict cross-reactivity between viruses from distant phylogenetic lineages. In silico protein structure analysis reveals possible similarity between SARS-CoV-2 spike protein and dengue envelope protein. There are a few papers that reported on COVID-19 with dengue co-infection. With the epidemiological overlapping in the tropics, the menace of COVID-19 and dengue, and potentially for other arboviral and tropical diseases, is more a real additional burden during the ongoing pandemic. In this study, some clinical manifestations were similar, such as fever, general malaise, headache, nausea and vomiting, and some rash. Co-infection of SARS-CoV-2 and dengue virus is associated with significant morbidity and mortality. Overlapping clinical and laboratory features of each infection poses a challenge in the accurate diagnosis and treatment of cases. Delayed diagnosis of co-infection can result in serious patient complications with poor outcomes. The review underscores the importance of accurate and timely diagnosis using viral-specific tests. This report shows the increase in dengue incidence in Singapore during their movement control or social distancing measures. It is found that social distancing is associated with an increase in the number of reported dengue cases in Singapore. And one key pathway that may explain this result is the increased time spent at home addresses due to social distancing policy, together with the propensity for dengue infections to surface at home rather than work places in Singapore. Finally, stay safe. In this COVID pandemic, do not forget about dengue fever.
Right. Thank you, Dr. Ong. Thank you very much for your presentation. I know it's a difficult topic when you have to talk about two different diseases, which has similarities and of course has its differences as well. So as usual, for all of you who have questions, please just punch it into Slido and we'll try to address as many questions as we can. We are a little bit behind time, but we'll get on with it. Right. First things first, Dr. Ong, in regards to your reading about COVID and dengue, you showed data from Singapore that showed that during the movement restriction order in Singapore, the dengue cases actually went up to some degree. But in Thailand, in Malaysia, the opposite occurred. During the movement restriction order, especially data from Malaysia, the number of cases last year was very, very low. Of course, the number of deaths, fortunately, was also extremely low. What does that tell us about how dengue is transmitted in our country, in your mind?
Oh, thank you, Dato. Can you guys hear me?
Yes, we can. We can.
Yeah, I think because the people is not moving, and as we all know, I mean, unless us healthcare workers who are still working, the rest of the population is actually being kept at home. Even many of them is not even allowed to go out to their neighborhood padang, to do their exercises. And also, I believe this is one of the main factor of the dengue cases that is lower compared to the same period of time last year.
So does it imply that in Singapore that it suggests that most of the dengue transmission occurs at the home environment. But does it mean that in Malaysia, significant amount of dengue transmission occurs in workplaces or in public spaces? Does it imply that? Because everybody stayed home during the first, especially in 2020, but the dengue cases are very, very, very low, isn't it? So does it mean that is that the dynamic or narrative in Malaysia?
I cannot be sure, Dato', but maybe we should have an audit or have a look at the.
Sure. I just wanted your opinion because I appreciate you sharing data from other journals, especially data from Singapore. I have a lot more questions, so I have to move on. That was my own personal question. Right now, in your reading, has there been documented evidence that in a co-infected patient with dengue and COVID, does dengue make COVID more severe? Does COVID-19 make dengue more severe? Is there any evidence of that?
Yeah, definitely there's evidence. I've included that piece of evidence in one of my slides earlier on. So vice versa, both these diseases can cause a more severe presentation of either these diseases if they are infected with both, especially. So the disease progress generally has a higher risk to turn more severe.
Right. I think, and that data is very worrying because obviously with COVID-19, there is certain amount of restriction in terms of how the patients are managed in terms of isolation. And if they have COVID-19, even if they are not severely ill, they are supposed to stay at home. They can't be moving around, doing full blood counts on a regular basis. It's not so easy. So we foresee issues there. There are some questions addressing that, but perhaps we won't have time to answer that now. But certainly it gives us a lot more challenges. I'm going to ask a question which I think is very pertinent and relevant. We know that in COVID-19, one of the major breakthroughs in management was the use of anticoagulation. We know that it's increased significant thrombotic embolic phenomenon that occurred in COVID. But if a patient is co-infected with dengue, how does anticoagulation factor in that? The other thing is, of course, we use a lot of steroids in COVID-19. Now maybe we use a bit less, but during the early months of COVID-19, we use tons of steroids. So how does that factor in terms of managing someone with both infections?
So in this kind of this is a difficult situation to handle, but definitely it falls back to us when we are dealing with the patients. So I believe the clinical picture of the patient and at what stage that the disease of dengue fever that the patient is in need to be factored in big time, as well as close monitoring of the blood biochemistry, the platelets, the disease process, at what stage of dengue fever that the patient in, whether is the patient like in dire critical phase of dengue fever with very low platelet. Definitely we do not want to put the patient on anticoagulant during that time, as the risk of bleeding will be higher. So I think there is no straightforward answer to this question, but we have to look at the entire clinical picture in its entirety, and we have to always weigh the risk and benefit of all the drugs that we are about to give the patient. Of course, the steroids, if in high dose, there is a high risk of causing a GI bleed. And in fact, we have actually seen some patients that presented with GI bleed with high dose steroids in our ICUs, which is not uncommon. But then again, we have to look at the whole picture to see if the patient is in a very bad CRS that requires the steroid to suppress the CRS. Well, it all comes down to weighing the risk and benefit of each drugs. And I think a very important thing in managing this group of patients is the multidisciplinary approach, together with our ICU colleagues, our ID doctors, and GI doctors, etc., is very important.
Yeah. I mean, to be fair to Dr. Ong, it is going to be extremely challenging. I think all of us would agree if you have a patient with significant severe COVID on top of a dengue? I think all of us know, and that question that was asked is pertinent, but I think we really don't have a clear answer for that. I guess it requires close monitoring, and we have to decide which is the priority at that moment in time. But certainly anticoagulation, use of anticoagulation in a co-infected patient would be extremely challenging. Clearly, as you know, we have seen many patients with dengue having pulmonary congestion with fluid being flooded in the lungs. They get breathless, but so does COVID. So it's going to be extremely challenging deciding what needs to be done for these patients. So clearly, I think all of us would agree on this point. Let's make sure we prevent both infections well, get us vaxxed and boosted for COVID-19, keep our SOPs, and make sure we don't forget our neglected tropical diseases like dengue to make sure we don't have another big surge. I just have two more quick questions to end this section on COVID-19 and dengue. These are, I guess, pragmatic or systematic questions for running services. How do you approach, how do you increase the room or bed use in patients with COVID-19 and also dengue at the same time? How do you foresee that playing out? Imagine we have a big surge a couple of years ago with dengue on top of a COVID-19 pandemic. I know it's a very unfair question, Ong. I'm sorry that came out. So let's see what your thoughts are on that.
Yeah, so I think it's quite straightforward, because in terms of isolation, we look at the duration of time that the patient need to be isolated based on their onset of symptom or their result of the positivity of their PCR or RTK, based on a lot of evidence in terms of the infectivity of the COVID virus and COVID infectivity that the patient might have. So I think we need to go by that lah.
Okay, I think as Ong has mentioned, it will require a lot of adjustments in hospital settings and clinic settings. When if we have these two outbreaks at the same time, we have to make some adjustments. We hope that doesn't happen in a big way. My final question, but I think maybe it's, I think you mentioned it to some degree, Ong, but maybe you should elaborate again, because someone asked, does COVID-19 infection gives a false positive NS1? And that's the final question today. Ong?
Yeah, it sometimes does give a false positive NS1 in certain patients. So it again, the emphasis is to look at the entire clinical picture, to look at the patient in its entirety, and also to always do the serial full blood counts, and also look at the patient's clinical presentation. Because COVID-19 is more of a respiratory tract infection, whereas dengue is more like a viral infection. And most of the time, it doesn't really involve, the lungs like COVID-19, right? So I would go with that.
Right, I agree with you. I think it's important to look at the clinical situation of the patient rather than just depending on one test. I think there's a common theme that's come up today for our first three speakers, that we look at the patient in totality and holistically, and not just depend on one result. So with that, Dr. Ong, thank you very much for spending time with us this Saturday. I apologize, they give you a very challenging topic, but I guess that's why they bully young ID physicians. Not my fault, Dr. Anusha. Remember that. So thank you very much, Dr. Ong. So with that, that concludes the first three presentations for the webinar this morning. I want to thank you for staying put with us up to now. Don't go away, because there's a lot more good stuff coming out immediately after this. Now I'd like to pass to my co-moderator for this morning, my good friend Dr. Chow Ting Su. There she is, I think. She's on already. Hi, Dr. Chow. Kong Hei Fa Choi. Where's my ang pao? Oh, okay. Sorry.
I think you need to give me ang pao,
You send to me later now. Okay. I take Bitcoin one. I take. Okay, with that, thank you very much, everyone. Have a nice day, and I'll pass you over to Dr. Chow now.
Okay, thank you. Thank you, boss. Very good morning to everyone. And once again, I would like to remind everyone that this is a seminar on managing dengue in COVID-19 pandemic, which is jointly organized by MyICID and NIH. And my name is Dr. Chow. I'm from Penang Hospital and ID consultants in Penang Hospital. Can be a dinosaur in Penang Hospital already. And as usual, for question and answer, I remind the participants to punch in into the Slido app. And for CPD points, all the frontliners of healthcare professionals and allied health, remember to collect your CPD points by filling out the online attendance form. In case you missed it, it will be broadcast after the seminar during the short resting session. So I believe that we have heard about how severe dengue infection can be, and also how detrimental if it is co-infection with COVID-19 pandemic and dengue infection. So currently, what can we do? As you know that in COVID, we have the vaccines. In dengue, the vaccine seems to be a little bit difficult. So we have to, brace ourselves and what can be done in the future. So without further delay, I would like to proceed with the fourth topic of today's webinar, A New Hope in the Horizon, which will be presented by Dr. Alberta Di Pasquale. She's a Regional Medical Affairs Head of Vaccines, Growth and Emerging in the Markets in Takeda, Singapore branch. Okay, she is an MD with a postdoctorate degree in the internal medicine from the University of Chieti, Italy, and a PhD in vaccinology from University of Genoa, Italy. She is the visiting professor of vaccinology in the University of Antwerp, Belgium, since 2019, and she has over 20 years of experience in vaccines. And without further delay, I would like to pass the platform to Dr. Alberta Di Pasquale to share with her view and the new hope in horizon in dengue management.
Good morning. Thank you to the organizer for the kind invitation to participate to this important webinar. It is my pleasure to be with such a distinguished panel of speakers and audience. In my presentation today on New Open Horizon for Dengue, I'm going to provide an overview of TAC-003 candidate vaccine clinical profile as a potential additional preventative tool for reducing dengue disease burden. Here are my disclaimers. The presentation is intended for healthcare professionals only, not for public, and the candidate vaccine discussed here has not yet been approved for any indication, and there is no guarantee that it will be approved for such use as discussed in this presentation today by any regulatory authorities. But let me start by describing the structure of this vaccine. So the vaccine is a live attenuated tetravalent vaccine containing a live attenuated dengue 2 virus strain in red and 3 recombinant dengue strains generated by replacing the gene coding for the envelope and pre-membrane proteins of dengue 2 attenuated virus with genes derived from dengue 1, dengue 3, and dengue 4, as shown in different color in the picture. The objective of this formulation was to activate a broad immune response against structural and non-structural components of the virus. This vaccine has undergone an extensive clinical development program, as you can see described here by looking just at phase 2 and phase 3 clinical trials performed. And you can see in different colors that this vaccine has been studied in children, adolescents, adults, in endemic and non-endemic countries, looking at immunogenicity, safety, and efficacy. The overview of this study has also shown that the activities, if we consider the full clinical development program, has been done in 18 clinical trials performed in 13 countries overall, and have involved more than 80,000 subjects, including seropositive and seronegative participants at baseline, aged from 1.5 to 60 years of age from endemic and non-endemic regions. TAC-003 was able to demonstrate that was able to activate multiple arms of the immune system, and the immune response was sustained against all 4 serotypes up to 4 years after the second dose. The 2 doses administered 3 months apart was the preferred schedule in terms of immune response. It was selected for the phase 3 pivotal studies I will discuss much more in detail. The candidate dengue vaccines also shown to have to be well tolerated with no important safety risks identified to date. So that's the overview, but let's move on now into the details of the pivotal phase 3 studies called TIDES that is still ongoing. Here is the content of what I will be presenting to you today. So I will focus on obviously on the study endpoints, the study design, and key results in terms of efficacy, immunogenicity, and safety. So starting from the TIDES endpoint and objectives, here are the details of all the endpoints, and I want you to focus the attention into the pyramid shown on the right, where you see the hierarchy of importance based on the statistical power of the study to detect the real effect of the candidate vaccine versus placebo. The primary endpoint in red was really to look at the ability of the vaccine to protect against virological confirmed fever induced by any dengue serotype at 12 months after the second dose. The secondary efficacy endpoint in blue was there again to look up to 18 months after the second dose to look at the ability of the vaccine to protect against hospitalization by any serotypes, by baseline serostatus, seronegative and seropositive, by severity, so dengue hemorrhagic fever, severe dengue, and by serotype. The last but not least were the exploratory endpoint that you can see in green. The exploratory analysis obviously are not powered, but they are there just to inform future study hypotheses and for which the study obviously finding might be interpreted with caution, and will look in a series of different elements into efficacy by serotype, serostatus, by age, and so on. Obviously, along the trial, there was assessment of safety and assessment of reactogenicity and immunogenicity in a subset of participants. So the study has been conducted and is still ongoing, as I said, in 26 sites across 8 countries. And the decision to go with such a large geography is really to cover different endemic regions of the world with different burden of diseases and circulating serotypes. The study design is quite complex. The study enrolled more than 20,000 children aged 4 to 16 years of age. The target age was selected to make sure enough proportion of seronegative subjects could be included, and considering also the age range with the highest risk of symptomatic severe dengue in the countries involved. The study participants received 2 doses 3 months apart of the TAC-003 or placebo in a 2-to-1 randomization ratio. An active and modified surveillance system has been followed throughout the trial, with participants or their guardians contacted at least weekly to ensure identification of dengue cases. And the study follow-up is quite extensive and has been printed in part, again, to assess the primary endpoint, the secondary endpoint, and then the long-term assessment into the exploratory endpoint. A booster study is also being launched at the end of the phase 3 trial in order to assess again the added value of a booster dose for such a vaccine. So moving on into the study population and demographic of the study recruitment, we can see here that there was obviously a very comparable split in terms of subject enrolled and characteristics. You see that about 27% of seronegative subjects were equally distributed among the placebo and vaccinated cohort. So this is important because the study really can allow us to assess the ability of inducing vaccine efficacy based on a baseline serostatus. It was also, there was a good split between different ages, with 12% of subjects that were in the younger age category, so a slightly smaller number of subjects there, and 45% were from Asia versus 55% from Latin America. So the efficacy data that have been obviously reported first because they were calculated up to 12 and 18 months respectively, are summarized in the slide I'm showing you now. So let's start with the primary endpoint up to 12 months after second dose, and here the results. So TAC-003 demonstrated 8.2% efficacy against symptomatic virological confirmed dengue fever up to 12 months. The primary endpoint of the study that was exactly that per protocol was met. And all 4 serotypes were reported, but very little presence of dengue 4 was there, as you can see on the image on the right-hand side. These data from a clinical perspective are important because they might give an indication of possible reduction in number of outpatient dengue fever cases that we might observe. Moving on to the secondary endpoint, again, this time looking up to 18 months post-dose 2, here the results in terms of hospitalization rate. TAC-003 demonstrated 9.4% efficacy against hospitalization caused by virological confirmed dengue fever. And the secondary endpoint, again, in this case, for hospitalization was met. And this is, again, is important because the hospitalization parameter gives an indication of the possible reduction in the number of inpatient dengue fever cases, potentially reducing the bed occupancy, burden and cost on the healthcare system. So that's also quite an important element to consider. Moving on into the severe cases, TAC-003, you see here the split of the cases observed, demonstrated 85.9% efficacy against dengue hemorrhagic fever up to 18 months, and according to the WHO 97 criteria. However, we had also dengue case adjudication committee that was an independent group of experts assessing the cases in a very objective manner, and they identified very few severe cases based on their criteria, and this did not allow for a statistical significant evaluation of the two groups. As you can see here, we have very large confidence interval. Moving into the efficacy by dengue serotypes, here the results, we see that obviously the vaccine was able to demonstrate a high efficacy for dengue 2, followed by dengue 1 and dengue 3. And the secondary endpoint were met for these 3 serotypes. However, the vaccine efficacy against dengue 4 could not be statistically evaluated due to the insufficient number of cases. And as you can see, very large confidence interval, including the 0. Moving on into the efficacy by baseline serostatus, this is the overall results, again, up to 18 months. TAC-003 demonstrated efficacy against symptomatic virological confirmed dengue, regardless of baseline serostatus, with 73.3% overall, with 76.1% in seropositive and 66.2% in seronegative. So point estimate slightly lower for seronegative, but overlapping confidence interval. Moving on into the hospitalization, again, a similar example as before into the overall cases. We see a better picture because we see a higher protection against hospitalization in dengue seropositive, 91.4, and a slightly lower 88.1 in seronegative, but still with very overlapping confidence intervals. So it means that the efficacy is comparable between the two groups. Continuing the observation by serostatus and serotypes, here is the overall assessment up to 18 months. So TAC-003 demonstrated variable efficacy at this point, and the variable efficacy was really linked to the different serotypes. For sure, the vaccine efficacy in seropositive, seronegative was established for dengue 2 and dengue 1, and was established in dengue 3 seropositive. But there was no efficacy observed in dengue 3 seronegative with very large confidence interval, including 0. And in dengue 4, there were very few number of cases reported that did not allow for a statistical significant assessment. And let's move on now into the exploratory follow-up data up to 36 months, where we look again at efficacy, immunogenicity, and safety. So up to 36 months, that's where we are in terms of the study published findings so far, and that's what I will be presenting to you now. So here is the overview overall in terms of efficacy against symptomatic virological confirmed dengue fever. And here you see the overall seronegative and seropositive. So we see a tendency towards a decline between as compared to the 18 months and the 12 months I showed you before, but still with protective efficacy that is quite sustained. At the same time, what is quite interesting on the right-hand side of this slide is really the Kaplan-Meier curve. That shows really the percentage of subjects with cases into the placebo, that are the thick lines, seropositive, seronegative, versus the vaccine group that are in the dotted line. And again, what is important to see is that there is a sustained separation of the two curves already starting from the first dose, because there is the first separation already between 0 and 3 months. That's quite important and gives the idea that the population overall might benefit for such a vaccine regardless of baseline serostatus. And if we look in terms of the number of cases that could be prevented per 100,000 vaccinated subjects, this will be more than 4,600 in seropositive and 3,900 in baseline seronegatives. Moving on into looking into this hospitalization, again, the hospitalization looks and remains quite high sustained. So the good news is while there is a decline, this decline seems to really be linked to more outpatient subjects, while for the hospitalized dengue fever, the decline is not really there because it's quite sustained. We had 90 before, we have 86, 83 now. And still, again, overlapping confidence interval and a good picture for both seropositive, seronegative. And when we look again on the right, on the Kaplan-Meier curves, we see again this very strong separation between the vaccinees and control, showing again a possible benefit of this vaccine. In fact, per 100,000 vaccinated subjects, that we could prevent up to 1,600 cases in baseline seronegative, or up to 1,400 cases in baseline seronegative. Seronegative. Moving on again into the exploratory analysis up to 36 months against severe dengue and dengue hemorrhagic fever. We see dengue hemorrhagic fever efficacy was 65.4, again, based on the WHO 97 criteria. At the same time, obviously, once again, the efficacy against the severe dengue based on the dengue case adjudication committee group was, again, still not statistically significant because we had very few cases reported overall. Moving on now into the immunogenicity that was observed in the immunogenicity subset in this study. Here we look at the immunogenicity in the subjects that were seronegatives at baseline. And as you can see here, is that the graph represents the geometric mean titers reported in a logarithmic scales in individuals receiving the candidate dengue vaccine in thick line per serotype versus the individual receiving the placebo. These are the dotted line. So GMTs remained well above the baseline titers, especially for dengue 2, and stabilized around 9 months because they had the peak and then the decline, with 80.5% of subjects remaining seropositive against all 4 serotypes up to 36 months of follow-up. If we look at the same picture into immunogenicity in baseline seropositive, obviously the difference between the two is less evident because they had already antibodies. But what is very well shown here is that the GMTs for all 4 serotypes increased after TAC 003 and remained higher than placebo, with the similar pattern of stabilization from the 9 month onwards up to 36 months of follow-up. If we move now on into the safety profile, we start from the tolerability, so the local safety. And here again, the graphs on the left-hand side shows the injection site reaction up to 7 days after any vaccination. And on the right-hand side, we show the solicited systemic adverse events up to 14 days, divided again for young subject versus a slightly older subject. The solicited local reaction, the most frequently reported one were injection site pain, followed by systemic adverse events like headache, myalgia, malaise, and asthenia. But overall, the picture looks very reassuring and very similar in terms of profile between vaccinees and control. The big difference was really into pain at the injection site between the two groups. When we go into the total rate of unsolicited serious adverse events explained here in this table, we can see, again, by looking first of all at any and then the most frequently reported ones, that the rates and solicited adverse events were similar in the vaccine and placebo groups in terms of frequency. The most frequent serious adverse event was infection and infestation, but this was uncommon, in less than 4% in either arm of the study. And of those, mainly the reports were nasopharyngitis, upper respiratory tract infection, and viral infection. Moving on into what is the most important element that everybody is interested upon is really the severe adverse events reported over the study up to 36 months of observation or follow-up. As the data are showing here, there were no clinically meaningful differences in severe adverse events between the experimental and placebo arm overall and by serostatus, and that's extremely important. No severe adverse events were judged to be vaccine-related, including reported deaths. Overall, no important safety risks were identified up to 36 months of follow-up after the second dose, supporting the good tolerability and favorable safety profile of this candidate vaccine. Most importantly, there were no signs of possible enhancement of disease. And the last slide around safety, here is really looking at the frequency of severe adverse events, and you can see that they were similar across placebo and vaccine group. I remind everybody that this is 2-to-1 randomization rates. And here, as you can see, the list of most frequently reported one, there was no clinical meaningful difference between the experimental and placebo arm. And again, there does not appear to be an increased risk of severe diseases or hospitalization post-infection when vaccinated with TAC-03 for individuals seronegative or seropositive at baseline. And that's, again, a very important finding. So this brings me to the conclusion slides where I summarized the data I showed you because there were quite a few in a row. And here the key element I want to say is TAC-03 really demonstrated overall efficacy against symptomatic dengue in both baseline seronegative and baseline seropositive children aged 4 to 16 years. This was the efficacy for the primary endpoint. And here is the summary of the efficacy I presented to you for the secondary endpoint. The exploratory analysis in the long-term follow-up, we observed a tendency to decline in vaccine efficacy in outpatient subjects, as it is observed in other vaccines, but still a robust efficacy that remains up to 83.6% against hospitalized virologically confirmed dengue, regardless of serostatus at baseline. We have seen as well variable efficacy against serotypes, in particular lack of efficacy against dengue 3 in seronegative individuals, and very few dengue 4 cases that will require further assessment. Last but not least, the reassuring element of no important safety risks identified up to 36 months after the second dose, and most importantly, no signs of possible enhancement of disease. So these are overall the data observed in children and adolescents 4 to 16 years of age. And today, obviously, the question might be the generalizability of this finding to young adults and adults in general for countries where they see cases in these age categories. And to answer this question, what has been done in the clinical development plan of this vaccine, what we have done, we have performed what are called immunobridging assessment to link efficacy and immunogenicity of this pivotal trial with other trials in adults by showing that there is non-inferiority in the immune response between the what's observed in this efficacy study versus what observed in adult study. This data will be published in the coming months and have been submitted to regulatory authorities to support the indication from 4 to 60 years of age that we are seeking. In conclusion, the TAC-03 clinical benefit risk profile is favorable and is encouraging to consider this candidate vaccine as a potential additional tool that brings hope in the horizon to help reduce the burden of dengue diseases on individuals and on the healthcare system. And with that, I thank you for your attention.
Thanks, Dr. Alberta. I hope that the participants can punch in their questions pertaining to Dr. Alberta's presentation. And while waiting for the questions regarding TAC-003, I guess there's no name for this vaccine yet, right? So we have to call it as TAC-003, is it?
Yeah, that's the clinical trial tag name that we use, yes.
Yes, I see the Slido questions are more on clinical questions, but to start the ball rolling, I think as a chairperson here, I would like to ask, can Dr. Alberta explain that why is it TAC-003 is different from those Dengvaxia from the previous predecessor vaccine that we know that they are actually requiring the participant or the people to check whether they are seropositive before or seronegative, because those seronegative will tend to have a severe dengue infections, you know, after they receive the vaccine, if they do have the breakthrough infections. But why TAC-003 didn't show such a phenomenon?
There are many elements. I would say the first important one is that this vaccine is based on a dengue virus backbone and not on another flavivirus backbone, as it was the case for the precedent vaccine that was based on a yellow fever backbone. So having that, what we expose into the immune system is really structural and non-structural protein that are derived from a dengue virus. Obviously, what we did because this was based on the dengue 2 serotype, what we did was really including the genes coding for the pre-membrane and the envelope protein from dengue 1, 3, and 4 into this dengue 2 backbone. So that's already a very big difference between the precedent vaccine. In terms of why this vaccine has been studied, and this vaccine has really, in terms of phase 3 in particular, studied by looking already at the beginning, at the time of enrollment, at the baseline serostatus of all people involved. So this is more than 20,000 children, as I said, that were tested at baseline to assess if they were seropositive, seronegative. Really, this was coming from the request from authorities and from the assessment, because this study started when the Dengvaxia discussion start to come around the difference of impact of this vaccine depending on serostatus. So by having this type of trial, we were able really from the beginning to assess efficacy, immunogenicity, safety in all groups by serotype, by serostatus. And doing that was really reassuring that what we were observing is the real picture of what happens to these cases. And so far, again, from a safety profile, we have no safety signal, so this is very reassuring.
I see. So in your research or in that trial, the pivotal trial, I see that the data stretch up to 36 months, right? Yeah. So do you think that this vaccine is going to be lifelong vaccines?
I mean, that's the hope, but the study has such a long follow-up, again, in order to assess the possibility to see worsening of condition later, because we know that the dengue severity and what is worrisome is the second infection with the different serotype as compared to the first infection. So such a long-term follow-up allows really to assess if anything is happening later. For sure, in terms of efficacy, what we have observed, there is, as I said, a slight tendency to decline for the virological confirmed symptomatic dengue fever, but there is quite a sustained efficacy against hospitalization. So it seems that this vaccine is able, at least for 3 years of follow-up, what we have seen so far, to be able to maintain a good sustained vaccine efficacy. But there is still, obviously, and there will be time needed to really see whether this vaccine will require booster. That's also why a booster study is going to start at the end of the phase 3 trial, and also assess for how long this vaccine will be able to give an important protective efficacy. So the jury is still out. Vaccines usually evolve in their indication, in their recommendation, depending on the data that will be accumulated pre-licensure and, most importantly, post-licensure.
So, Dr. Alberta, with that, I probably would think that this group of patients or participants, subjects that had already enrolled by 36 months will continue to be followed up in years to come, correct?
Yeah.
All right. So I see that the study involved age 4 to 16 years old, but you are going to get approval up to 60 years old. What about those group that below 4 years old? I know the incidence of dengue below 4 years old may not be high, but we do see patients with below 4 years old getting dengue infection, also 2 years old, 3 years old. So what about this group of population?
Yeah, when we looked at the development program, obviously you have to really take an assessment of where you want to go to start first. And we really looked at the burden of disease, what was the highest burden of disease in countries in endemic areas. And that's where the reason why we went into 4 to 16 for phase 3 efficacy trial. And then we looked overall at what is the behavior of dengue, and we went to 4 to 6 in terms of indication that we are seeking. For the younger subject, because again, this is different depending on the countries, being in some countries a problem, but in others less of a problem, this will be further assessed after the primary clinical development program will be concluded. So we will not have the data immediately now, but it's part of our future thinking to how to progress further the clinical program.
I see. So another one is I would like to get the Slido question. Is one of the participants is asking, what is the reason that serotype 3 show a little bit low immunogenicity compared to DEN 1 and 2?
I mean, there are a lot of possible theories about that, and I mean, we are still assessing in different aspects why this might be the case. It's not straightforward, because for sure what we see in terms of immune response, all the 4 serotypes induce very good immune response, very good neutralizing antibodies. We have very good avidity, complement activation. We have also T cell response, CMI response. So officially there is no reason why the serotype 3 should not work in the proper way. And for sure, we also are looking if there was a specific genotype circulating at the time that maybe was not matching very well with the vaccine virus. And then again, we didn't see a strong reason why this might not be the case. I think we really are still further assessing what might be the rationale. Probably the booster dose might give us some additional ideas whether, again, a booster will help in that case. But at the moment, we don't really know what's going on. It's part of what we have to further assess in future studies.
So my last questions before I let Dr. Alberta go. I would like to understand, why is it the duration of 3 months from first dose to second dose being chosen? Did you have any before the trial to look at 1 month, 2 months, or 3 months? And the protectivity after 3 months, how soon will the protection confer the protection?
So the 3 months is obviously selected based on, there is a dose range study. So you try really different type of dosage, and you see which one is trying to give the best immune response against each serotype, and in seronegatives, and this seropositive and seronegatives. And this response must remain high and sustained for 4 years. So in one of the phase 2 trial, we really assessed that the best immune profile was for the 0-3 months schedule. And that's why it was selected as the final formulation for phase 3. Then in terms of what about the efficacy after the first dose, between dose 1 and dose 2, as I've shown before, the Kaplan-Meier curve that shows really the risk between the two populations shows already a benefit after dose 1. But the dose 2 that arrives 3 months later has been really administered 3 months later. So we know that in this window, people started being protected, but we don't know if a person receives 1 dose and then never a second dose, how long this protection will last. Because immunologically, the second dose will secure a better immune response.
Very, very clear. So thank you very much, Dr. Alberta. This is a very, very exciting field. And I hope that, with this new TAC 003, it will actually resolve a lot of issues of dengue infections in this Southeast Asia region. Thank you very much, Dr. Alberta.
Thank you.
So, and now we would like to proceed with the 5th topic, I would like to welcome Dr. Nur Hayati Mokhtar, a public health specialist from Vector-Borne Disease Sector, Division of Disease Control, Ministry of Health, Malaysia, to enlighten us with the presentation on updates in vector control in Malaysia. What is new? So after we hear that there is a possible in future a good vaccine, but what does it mean for us to do a vector control now? So Dr. Nur Hayati Mokhtar obtained her public health master in 2010 and PhD in 2017. Previously, she was working in CDC unit, Selangor State Health Department, as well as in charge of primary health clinics in Petaling District Health Office. Currently, she's the senior principal assistant director of Dengue Unit, Vector-Borne Disease Sector in Disease Control Division, Ministry of Health. And you are the expert in talking to us about updates in vector control. And without further delay, I would like now to pass the platform to Dr. Nur Hayati.
Assalamualaikum and a very good afternoon, everyone. I'm Dr. Nur Hayati Mokhtar from Vector-Borne Disease Sector, Disease Control Division, Ministry of Health. My presentation for today will be focusing on the public health aspects, particularly on the updates in dengue prevention and control methods and approaches that are being carried out in the field. And this is my outline of the presentation. First, I will touch on the dengue situational analysis in Malaysia, and we will also look at the vector control approaches in dengue prevention and control program in Malaysia, and what are the innovations or novel tools in dengue prevention and control, such as in Wolbachia mosquito release. We will also look at the sterile insect technique and dengue forecasting system. And finally, I will summarize my presentation in the summary. First, let's look at the dengue situation in Malaysia. So this is the dengue statistics or dengue cases for the whole of last year, where there were 26,365 cases reported, as compared to the year of 2020, where there were 90,304 cases, which brings to the reduction by 71%. And similarly, for the dengue death, there were also reduction by almost 86.2%, or reduced by 125 deaths, where in 2021 there were 20 deaths reported as compared to 145 deaths reported in the year of 2020. And for the case fatality rate, the CFR or case fatality rate reported last year was the lowest ever being reported, which is 0.08% as compared to the year before. The CFR was 0.16%. And this is the dengue situation until EPID week of 5, which is until 5th of February 2022, where we can see an upgoing trend in terms of cases, where in 2022, for this year, there were 3,573 cases reported as compared to last year, the same period of last year, there were 3,329 cases. So there's an increment by 7.3%, or 244 cases. And until now, there were no dengue death reported. And this is a graph that shows the weekly dengue cases in Malaysia for the year of 2021, represented by the red line. Cases in 2020 represented by the green line, and 5 years median cases, which is from 2016 until 2020, represented by the blue line. And as you can see in the graph, there's a huge gap in terms of number of cases reported last year compared to 2020 and 5-year median. And we can also see in the graph that there'll be always two peaks, or we call it as biannual dengue transmission period. And this is the dengue endemic pattern in Malaysia, right? So the peak usually will occur from September from June till September, that's the first peak. And the next peak or the next transmission, yeah, will occur from September until March of next year. So there will always be two peaks, or we call it as biannual dengue transmission in Malaysia, right? And this slide shows the dengue weekly dengue cases in Malaysia from the year of 2013 until 2021, where if we observe, there is always surge in dengue cases in every 4 to 5 years, yeah, with a notable case surge in 2015 and 2019. So as you can see in the graph, there's a case surge in 2015, and in another 4 years, there's another surge, yeah, in 2019, and we anticipate that there'll be another case surge, yeah, somewhere in 2024 or 2025, right? And this is just to share number of dengue cases and death, yeah. So the number of dengue cases is represented by the bar graph, and the line graph represents the number of death, yeah. So as you can see, number of death in 2021 was the lowest ever been reported, yeah, for the past 20 years, right? And this is the graph that shows number of dengue cases and incidence rate. And we can see a steady decline, yeah, in terms of the incidence rate from the year of 2019 until 2021. So in 2021, the incidence rate for dengue was 78 per 100,000 population. And this is just to show in terms of the number of dengue death and case fatality rate, as I've mentioned before. The case fatality rate for last year, yeah, was the lowest, yeah, ever been reported, yeah, for the past 20 years, which is 0.08%. And the number of deaths for last year, yeah, was 20 deaths, right? And this is the map showing dengue incidence rates by states in 2021. And as expected, the highest number of incidents were reported, yeah, from the states with highly populated, yeah, which is the Klang Valley, Selangor, and Wilayah Persekutuan Kuala Lumpur, right? And this slides actually shows two graphs, okay, where the upper graph shows the number of weekly dengue cases, yeah, reported from 2013 until 2021, whereas the graph at the bottom shows the dominant circulating virus, yeah, throughout the 9 years. And what I would like to emphasize here is that whenever there's a shift, yeah, in terms of dengue serotype, there will be surge in cases, yeah. For example, in 2014, there's a shift, yeah, from dengue serotype 2 to dengue serotype 1, and afterwards there'll be a shift or case surge. There is a surge in cases reported. And if we look in 2018, the same scenario occurs, where when there's a shift from DEN 2 serotype to DEN 3 serotype, there's a case surge in 2018 and throughout in 2018 to 2019, and throughout the year, the dominant circulating virus was DEN 2. However, when we look at last year, 2021, there was a shift from DEN 3 to DEN 4. However, we hardly see any surge, yeah, in cases, but this could be due to the lower sample, a low number of sample reported last year, right? And then let's move to the vector control approaches in dengue prevention and control in Malaysia, right? So the main objective of vector control is to reduce the abundance of vector population, which is the mosquito density, to the level that it may not allow transmission to occur. However, the threshold is still undefined. Yeah. And these are the mainstay of dengue control measures in Malaysia. First is the source reduction, or known as penghapusan tempat pembiakan, or PTP, yeah, among our health staff. Secondly is the larviciding, right? And third is space spraying, or known as semburan ruang thermal, or popularly known as fogging, right? And the fourth is the targeted outdoor residual spray, or targeted ORS. And apart from that, the health promotional activities and the law enforcement is still ongoing here, as the conventional way of dengue prevention and control. So the source reduction is by doing the search and destroy of Aedes breeding places. And this source reduction, yeah, has been and continues to be a key component of dengue and chikungunya control programs, where it must be initiated within 24 hours after the case notified in the e-dengue system. And the premise coverage must be 100% within 3 days, right? And in terms of the radius of the coverage, for single case, our health staff, must cover 200 meters for single case. And in the situation of outbreak, they must cover 400 meters. And the source reduction activities is done by the health inspectorates, yeah? The pegawai kesihatan persekitaran or pembantu pegawai kesihatan persekitaran at the district health office, the PKDs, or by the local council or the PBTs, yeah? And the source reduction is also carried out by the pest control operators, yeah, hired by the PKDs, right? So this is a few. This is a few pictures like showing the search and destroy activities being done at the ground, right? And secondly is the larviciding. They comes in various forms, yes, such as in sand granules or capsules or solutions. Usually, the larvicides that are being used is the Thermiphos or BTI, which is the biological form of larvicides, yeah. And the larviciding will be done at sites that has potential breeding containers, for example, at the back lane or empty lots or bushes or building structure or defect building structures. And that's a term called community larviciding, where the communities themselves, yeah, will conduct these larviciding activities, yeah. And these are pictures that shows a various form of larvicidal activities, where they can use spray cans or mist blowers or the conventional abating, yeah, using the sand granules, right? And this is the larviciding activities done by the communities, yeah, for example, by the combi volunteers, yeah, done at their neighborhoods or in their area. The third is the space spray of adult Aedes, space spray or fogging, yeah, popularly known as fogging. It must be done within 24 hours after the case notified in the e-dengue system, and the locality must cover 80%, yeah, 80% of the premises, and similar as in source reduction. For the single case, it must cover 200 meters, whereas in the situation outbreak, it must cover 400 meters. It must cover indoor and outdoor, and it is usually done during dawn and dusk, which is the peak biting hours of the mosquito. And in case the premises are closed or the owner quite reluctant to allow our staff to enter their premises, we encourage the use of the aerosol spray. And in terms of in the situation of outbreak, the thermal fogging or the spray must be complemented with the ULV, right? So these are a few pictures showing preparation of the preparation before the fogging activities being done. Okay, they are preparing the fogging machines before the space spraying, right? And these are the space spraying done, which is usually done during the dawn, yeah, and dusk. Okay, and there's another new approach or new initiative by IMR, which is the targeted outdoor residual spray, where the operators will apply a low dose of insecticides, yeah, onto the outer surfaces, usually onto the wall where mosquitoes are suspected to hide or rest. And these residual activities will last between 2 to 3 months. And this ORS is usually done as a preventive method in dengue hotspot localities or areas with recurring dengue cases. And it will be done at least for 2 cycles of spray, and it will be repeated for every 3 months. But the disadvantage of this method is that it is laborious. It needs more manpower to complete the task at one locality. Okay. And apart from that, there are these are the conventional ways of educating the public, okay, which is health promotional activities. And for the health promotion activities, it depends on the type of cases reported, whether there are single case, or control outbreak, or uncontrolled outbreak, or hotspots. And so these are the activities being done. Yeah, for example, announcements of Siar Raya, or hebahan in the TVs or radios or in the social medias. Yeah, there'll be also banners, posters, flyers, community mobilization, health educational kiosk at hotspot area, and also dialogues, right? So these are examples, yeah, of how the promotion activities being done, yeah, through the radio or TV interviews, right, posters and banners, and also announcements, right? And in terms of enforcement, there is an inspectorate and law sector or unit that look into the enforcement part, and they will also conduct a regular operation called this OGA, Operasi Gempur Aedes, and a compound of 500 ringgit, yeah, will be issued, yeah, to those found to breed disease-bearing insects. Yeah. Okay. And let's have a look at what are the new initiatives or approaches in dengue control. I will touch briefly on Wolbachia mosquito release, sterile insect technique, and dengue forecasting. So first is the Wolbachia mosquito release, right? So I'll explain briefly on what Wolbachia is all about. So actually, Wolbachia is a gram-negative bacteria naturally found in 60 to 70% of insects, and it can only live inside the host cells, not in the environment. Okay? It cannot be transmitted between insects, and since it cannot survive outside the cells, it has to be injected into the egg of Aedes aegypti using a technique called microinjection. Yeah. So this is how the Wolbachia is transferred to Aedes aegypti mosquito. Yeah, so Wolbachia is injected into the eggs, and eventually the eggs will hatch and become a Wolbachia Aedes adult mosquito. And this graph shows the impact of having Wolbachia in the mosquito. Yeah, as we can see in the x-axis, versus the existence of the dengue virus in the mosquito saliva in the y-axis. Yeah, so mosquito without Wolbachia, yeah, for the mosquitoes without Wolbachia, we can see that viruses were found in the saliva. Yeah, whereas for mosquitoes with Wolbachia, there is viruses found in the saliva. And how did Wolbachia block the virus replication in the mosquito? So this is the theory that were told to us. Yeah, first it will boost the natural immune system of the mosquito, and secondly, Wolbachia will compete with virus in consuming the cholesterol inside the mosquito, and this will make the dengue virus hard to grow. Right. And the field trial phase was initiated by IMR in 2017, with all of the localities shows reduction in number of cases, yeah, as compared to the control site. And in view of the promising results, yeah, from the field trial phase, Ministry of Health adopt this method in the operational phase that starts in 2019 with 11 localities with high dengue burden. And for this operation, the budget comes from Ministry of Health, and we distributed them to the PKDs and GKNs. And this project involves multidisciplinary teams. Yeah, it involves the epidemiologists, entomologists, health inspectors, health education officers, as well as the community. Yeah, the committee leaders, the GMBs, the local municipals. And in terms of prevention and control activities at Wolbachia release site, a big no, yeah, in terms of prevention is that there will be no fogging, as it will kill our Wolbachia mosquito. And in terms of dengue enforcement, it goes on as usual, right? And there are criteria, yeah, for the locality selection, right, that need to be fulfilled. Yeah, for example, it needs to be localities with high dengue burden or dengue cases. And in terms of the type of premises, the priority is the high-rise building, as we can see a significant reduction when it is released at a high-rise building or flats, right? There also need to be natural boundaries, yeah. For example, rivers, highways, or fields, yeah. This is to prevent immigration of wild mosquitoes to the area, yeah. And there shouldn't be any industrial sites, yeah, because it will kill our Wolbachia mosquito. Area of at least 0.6 kilometers square. We also look at the number of households, and most importantly, there must be a good public cooperation and support, right? And there are two Wolbachia strategies, that is replacement strategy and population suppression or suppression strategy. But in Malaysia, we adopt this replacement strategy whereby in replacement strategy, both the female and male Wolbachia were released, and over time, the Wolbachia mosquito will mate with the wild population, and eventually all of the population in the release area will carry Wolbachia, right? And these are the states involved in Wolbachia mosquito release, where we divide them into cohorts. Yeah, for the first cohort started in 2019, there are 11 localities consisting of Selangor and Wilayah Persekutuan Kuala Lumpur, followed by the second cohort where there is an additional of Pulau Pinang, and the third cohort we hope to accomplish 30 localities, but until now there were only 3 localities in the third cohort, and the remaining localities, yeah, we will try to release them for this year. And all of these 22 sites are all recalcitrant dengue hotspots, and majority of them are of high-rise building. Okay. So there are 2 endpoints that we monitor during the release. First is the epidemiological endpoints, or the weekly confirmed dengue cases in the area. And secondly is the Wolbachia frequency in the environment, or the entomological endpoints, right? And these are the results. Yeah, after 6 months, we are comparing 6 months before release and 2 years or 24 months after the Wolbachia release. And as we can see, all of the locality of the first cohort shows reduction in number of cases from 75% until 100%. So all of the localities shows reduction in number of dengue cases. And this is in the graphical form, where we can see number of cases before 6 months before release and 24 months or 2 years after release. All of the locality shows a reduction in number of dengue cases. And this is just to show a few localities that before the release, and in 2021, where we can see this is in section 13 Petaling. There's a significant reduction here from 2019 until 2020, where the cases starts to drop, and there were only few cases reported in 2021. And this is in Pelangi Damansara, also in Petaling. So we can see there's quite a number of cases. The burden is quite heavy in this area in 2019, but there were only few cases reported in 2020 and 2021, right? And this is PPR, Desa Tun Razak, okay, one of the recalcitrant dengue hotspots. But we can see, as time goes by, in 2020 there were reduction and lesser case, in 2021. Right. So these are the pictures of preparation before the release of Wolbachia mosquito by our health staffs in the ground. So they are preparing the release container, where we need to put water and eggs, as well as the food, the larvae food. And this is where we put the release container at the post box, right? And there are certain days that we need to come and open the lid to release the mosquito, the Wolbachia mosquito, right? And this is the preparation before release of adult Wolbachia mosquitoes, right? Okay. Then we'll move to the second innovation or novel tool, is the sterile insect technique. So the SIT was among the first biological insect control methods for wide area application. And for the past 70 years, the control methods were heavily dependent on chemicals. So there are issues on insecticides resistance on pollutions. And in view of that, IMR has conducted a trial phase study on SIT in 2019 in collaboration with the Malaysian Nuclear Agency. And until now, in terms of the radiation process, was done at the Malaysian Nuclear Agency. So SIT can be called as a birth control of insects, for suppression or to eliminate the target pest population. The advantages is that there are environmental friendly, species specific, cost effective and sustainable biological pest control method. And the radiation, the sterilized insects are considered radioactive free. And this method was developed in 1950s by these two scientists. So this is basically what SIT is all about. So there'll be a mass rearing of insects took place at a special facilities, and the male and female insects are separated. And then the ionizing radiation is used to sterilize only the male insects. And afterwards, the sterile male are released to the localities. And the sterile male will compete with the wild male to mate with the female. And the mating of the sterile male with wild female will result in a non-viable eggs the eggs produced will not hatch, and eventually it will cause a population crash or suppression, yeah, of the mosquito population. So this is another illustration that shows where the pupae will be radiated, and there will be a sterile male that mate with female insects, and there will be no offsprings, yeah, because the eggs will not hatch, right? So basically, there are two phases of study. The first phase is the lab experiments, yeah, and the second phase is the open field release, yeah. For example, there will be mass rearing and site selections, which is usually hotspots, and in this case, IMR has chosen Malacca as the trial location. And there will be community engagement, yeah, to tell the community what is SIT all about. And there will be surveillance of Aedes aegypti population. And these are pictures that shows the sterile males, yeah, per cup, where they will be fed with sucrose every day before the release, right? And this is the results where we can see that overall of the Aedes aegypti density reduced by 96%. Okay, so there is a suppression of the larvae by 96% at the release site compared to the control site after 16th release, right? And in terms of number of dengue cases, also shows a reduction, yeah, as compared to the control site. Right. I would like to acknowledge Dr. Nazni for all the slides on SIT, because at the moment, the SIT is only done under IMR. It is not yet being operationalized at KKM, yeah, right. And the third one is the dengue forecasting system, where we use this system to forecast dengue outbreaks with sufficient lead time to allow for effective interventions. And this is considered as an early warning system developed by the UK Space Agency, or DMOS, yeah. And we have used the system as a pilot project since November last year. And we noticed that it may serve as a decision support tools, yeah, to provide information for planning and decision making. And this system managed to predict outbreaks 6 months in advance, right? So this is the dashboard, yeah, of the dengue forecasting system that we're currently using now, the DMOS, where basically the system used 20 years of historical Earth observation data from satellites. So the variable that are being used or taken into consideration is the temperature, the humidity, rainfall, soil moisture, land cover, wind speed, and etc. And in terms of cases, KKM we have provided, yeah, the developer of the system with the 10 years epidemiological data, which is the dengue cases. So by using data, 10 years data, okay, this is when the forecast issued, and we have 24-week lead time, yeah, before the predicted occurrence of dengue took place. So we have ample time in terms of prevention and control, in terms of planning, yeah, in the prevention and control. So this is the dashboard, yeah, of the system that we are using now. And the forecast goes by district, yeah. For example, this is the forecasted area in Kuala Lumpur. Before this vertical line, before the vertical line is the actual number of cases, and after this vertical line is the predicted or forecasted number of cases. And as we can see, it is predicted that in June, yeah, from January until June, there will be increase in terms of number of cases in KL, but still it will not exceed the threshold, yeah. And coupled with a stratification of dengue locality, because the system only predicts increase in number of cases by district, but we do not know where to act on. So we have to also rely on stratification of dengue locality, which is the priority localities. There are 4 categories of priority localities. And we also have these priority premises, which varies within states and districts. So by using the system, the forecasting system, together with this stratification of dengue locality, okay, we will target on the prevention and control approaches, right? So as a summary, first is that dengue prevention and control is a shared responsibility. It is everybody's responsibility, and therefore continuous efforts are required to sustain cooperation from communities in maintaining search and destroy activities. And during the COVID-19 pandemic, we realized that there's a competing priorities in terms of financial support, attention, and synergistic collaboration from all stakeholders. And therefore, there need to be a refocus for the essential duty, especially among healthcare workers at the district and state level. And for the third point, we noticed that during current relatively low burden of dengue, there need to be a paradigm shift in terms of control mode to preventive mode by using the dengue forecasting system, right? And for the Wolbachia, by looking at the result, we believe this method is promising, and therefore we will expand this project to other high dengue burden localities. And finally, to combat dengue, there's no magic bullet, there's no standalone tool, and therefore we have to use integrated vector control management. We have to combine all of the methods, to combat dengue, right? And these are the messages that we always have to emphasize to the public. First is to conduct the 10-minute search and destroy every week. Secondly is to always protect themselves against mosquito bite by using repellents or using the aerosol spray at home. And most importantly is to seek early treatment if they have fever and any of these 2 symptoms. So these are the messages that we really have to emphasize to the public, right? And I would like to acknowledge the scientists from IMR, Dr. Nazdi and Dr. Nurul Husna, as well as to PKD Petaling and Kombi Pulau Pinang, for their slides and for the photos, right? And I think that's all for now. Thank you for listening to me.
Thanks, Dr. Nurhayati, for such a challenging topics to present within the 30 minutes time. And I'm sure that there are lots of questions on the Slido, and for the participants, please continue to put your questions into the Slido. So as chairperson, I think I have the priority to ask a question to Dr. Nurhayati. I just would wonder what happened to the Wolbachia mosquitoes that release in those target areas. Would they propagate and become the endemic mosquito in that area?
Yes, thank you, Dato, for the question. Definitely. So when we release the Wolbachia, they will propagate and they will become dominant population. Wolbachia mosquito will become dominant population of mosquitoes in the area that we release. So we can see as in Mentari Court, where the release has stopped in 2017, but until now, the population in Mentari Court is still a Wolbachia mosquito, and we can see a very significant reduction in terms of cases. And we found that the population of Wolbachia is stable there.
and the community is very happy because there's no more dengue cases reported there.
Oh, I see. So
Yeah.
that is you say that this project will expand slowly.
True,
And how soon or how fast is this project going to be, expanded?
At the moment, we have 22 sites, 22 localities, and we hope by end of this year, we will accomplish 30 sites. And after year after year, we will add 5 localities per year, Dato'. And we expect that in 2025, there will be 50 localities.
That's good. And on the Slido, there's a lot of questions on, how do you know that the reduction in dengue cases during these 2 years of COVID pandemic, is it due to restriction of movement controls, or is it really due to the, Wolbachia mosquito that released in the hotspots area?
It's a very difficult question. So actually, when we start on Wolbachia, which is in 2019, there's a high sky in terms of cases. So we have recorded 113,000 over dengue cases. But in 2020, which is in the middle of 2020, which is in March, where the government imposed the MCO, it actually coincides, with the reduction in dengue cases. So we believe that MCO gives a huge impact, to the dengue cases reduction. And in terms of Wolbachia, it is true that at the moment we cannot really prove that Wolbachia, in this 2 years time, we cannot really have the evidence that Wolbachia attributed to the reduction in number of cases. But we hope that in the long run, they will give some evidence.
So another interesting question, this must be some from some vector area. By using the sterile SIT, would it cause an imbalance in the ecosystem? Because you sterilize the male, and that's how there's no more offspring. Would you disturb the ecosystem?
Okay. Actually, SIT is not yet being implemented as a KKM policy. It is still in the trial area, a trial phase. But I think IMR is the best to answer this. But I don't think that it will cause imbalance, because the mosquito only lives 30 days, and then there will be new mosquito producing. Maybe I'll answer this later.
Okay,
I have to consult IMR about this.
Sure. So if, let's say, you think of all this technique like Wolbachia and everything, the larviciding activities would, no longer important?
Okay, in Wolbachia area, in Wolbachia locality, we have to be cautious when we do larvicidal activities. Fogging is definitely a no in Wolbachia locality, but larvicidal activities, when there's an increase in case, we have to somehow do larvicidal activities. Especially, we have to bear in mind that Aedes albopictus is still around, and Aedes albopictus is not affected by Wolbachia. So still, we have to emphasize on cleaning up the surrounding, do search and destroys, and keep your places clean, because we still have Aedes albopictus around that will cause dengue.
No, I see. So what is your opinion regarding insecticide growth regulator in biological control of dengue?
Insecticide
this is the question.
Regulator.
Yes.
I think this is another form of larvicidal activities, and it is also used in trial phase. It is not yet being implemented. as
Alright.
operational in KKM. It is still
Okay.
under study by IMR. It's
Alright.
IGR.
So for the dengue forecasting system, I'm very interested. It gives you 24 weeks ahead to forecast that, what area that is possible, being targeted. Do they also predict the dominant serotype?
Oh, no, they only predict number of cases, whether they will exceed the threshold or otherwise. So when it exceeds the threshold, that is when we have to act. The PKDs, the JKNs have to act. If the system, if the prediction or the forecasting only shows increasing trend and there's no alarm in terms of exceeding the threshold, then the dengue control and prevention will continue as usual. Only when there's an alarm, which shows by the changes in the color, as I shown before. So there will be special, more intensified in terms of dengue prevention and control. So,
all right.
Yeah.
Okay, I think time is really running out, and I would like to thank Dr. Nurhayati for her time, and of course, excellent sharing of experience in vector control, which I know it is very difficult. So thank you, Dr. Nurhayati, and now we proceed to a clinical area where children dengue, and I would like to invite Dr. Nick. Dr. Nick is going to present in managing of dengue in children and update. Dr. Nick Khairuddin obtained his MRCP in 1996, then diploma in tropical medicine and hygiene in London in 2002, and became a fellow of Royal College Pediatrics and Child Health in 2005. He has been the pediatric infectious disease consultant since 2003 and has, of course, he has published more than 40 papers, and they are all papers written by Dr. Nick. Without further delay, I would like to pass the floor to Dr. Nick to touch on the management of dengue in children.
Thank you very much. My topic today will be on managing dengue in children and an update. I would like to thank the organizing committee, the Malaysian Society of Infection Control and Infectious Diseases and Institute of Clinical Research, MyICID, for the invitations to be involved in the webinar today in conjunction with the World Non-Neglected Tropical Diseases Day 2022. I will be covering on 4 areas on dengue management in children. There will be the epidemiology, when to suspect dengue in children with the differential diagnosis that we have to consider, assessment in terms of a systematic way of assessing the child, history, examination, and lab study, and also looking at some updates on the management decisions, especially with the role of IV fluids in the management of dengue in children. So I'll start off first with epidemiology, just a little on the background in terms of epidemiology of dengue in Malaysia. As we know, dengue has been around for many, many years, and it affected all age group. And we can see that the dengue trends over the last 10 years or so in Malaysia has seen an increase and also a decrease, a waxing and waning pattern, which is seen all over the world as well. And if we look at the numbers of infected children over the years, it is the cases are about children are affected about 12 to 16% of the total number of cases in Malaysia. And the mortality is about the same. If we look at 2019 data, children made up 19% of the total mortality from dengue in Malaysia. So if you look at burden of childhood dengue, we know that dengue is a problem for most countries in Asia and also in Latin American countries. And this one study here able to quantify in terms of the burden of the disease in children in these countries. Okay, this is a published papers from New England Journal of Medicine a few years ago. It is basically a study that actually a dengue vaccine trial that was being conducted, and they were able to also to produce some results regarding burden of childhood dengue in those countries participated in the study. In this study, basically 5 countries were involved, including Malaysia. Total of around 3,424 in Asian countries, and about 6,000 plus, nearly 7,000 in the Latin American countries. So I think the significant part of the finding of the studies is that they found that about 10% of the febrile episodes are confirmed to be virologically confirmed dengue, the VCD, and the virologically confirmed dengue. So all the cases of fever presenting, children presenting with fever in this country turn out to be dengue, confirmed dengue. And the incidence tends to be higher in the Asian countries compared to that of the Latin America. The second important data here is that the hospitalization rate, where it's about nearly 20%, or 1 in 5 children with confirmed dengue infection will need to be admitted to the hospitals. So this obviously shows the burden of the disease is quite significant in Asia and also in the Latin American countries. So dengue can present with a spectrum of illness, as we all know, from asymptomatic infections, probably the major bulk of the infections, undifferentiated fever, and what that we are more familiar with, the dengue fever and the severe dengue. And we are all obviously very familiar with the WHO classifications of dengue and dengue with warning signs and also severe dengue. What we really want to prevent is to have children that comes in with severe dengue, where they can be very sick with high morbidity and mortality. Severe dengue can be due to capillary leakage, and they're presenting with fluid accumulation and shock, or they could be coming with bleeding, with area of or the and most common sites for bleeding is the gastrointestinal tract and also the mucosa, or they can present with severe dengue with specific organ involvement, including liver, brain, and also the heart. There are some challenges in managing dengue in children, we especially in these 3 areas. If we look at the diagnosis, sometimes the diagnosis is difficult, late, because we are not able to recognize dengue infections in children, especially when they present with atypical manifestations, not the usual fever, rashes, headache, the classical manifestation, but with some atypical manifestations like gastrointestinal or other system involvement. And the other one is in young infants, because assessment of young infants, sick young infants, sometimes can be very difficult, and the manifestation can also be different from the older age group. Obviously, the second problems that the challenges in managing dengue in children would be not just the diagnosis of dengue, but also recognizing signs of shock and also occult bleeding. And many times children are assessed or diagnosed late with shock, and because of that, the outcome may be affected. And the third one, obviously, is the role of using the judicious amount of fluids in young children's and in all children's basically, and the difficulties of making sure that we are giving adequate and not not giving too much fluid, and also not giving too little fluids. So I'm going to talk on some of the updates that in the management of dengue in children, and this will be based basically on the new management of dengue in children CPG guidelines, which just came out recently and can be downloaded from the Academy Medicine webpage. Yeah. So this is an update from the first edition, which was done many years ago, over 10 years ago. So there were certain things that I think I would like to highlight in this presentation today. Okay, so I will talk on the second area, which is now when to suspect dengue. So it's basically, we are very familiar with the with this list of symptoms and signs that we should be considering dengue in children. So live and travel in dengue endemic area. All Malaysians are considered to be dengue endemic area. And then presentations of fever plus 2 other symptoms and signs: nausea, vomiting, rash, ache, and pains, leukopenia, any warning signs. I think the very important points here is to have high index of suspicion. Whenever a child presenting with fever, they may or may not fulfill the criteria above, but dengue should always be considered as a part of the differential diagnosis. And be aware there are certain signs and symptoms which are a bit more different than the usual adult manifestations. And for example, headache and retroorbital pain is not commonly not a common symptoms in young children. And beware of the uncommon presentations, especially in young infants. So we should be looking for warning signs of dengue in children. It is similar to that those in adults. Abdominal pain. The abdominal pain usually tends to be continuous pain, not intermittent. Persistent fever. In the guidelines, it is defined as more than 2 episodes of vomiting that amounts to fatigue or requires intravenous fluid. They have mucosal bleed, lethargy and restlessness, enlarged liver, pleural effusions and ascites, and hematocrit, increase in hematocrit and reductions in platelet. And other signs that we should be considering as well in children include refuse to eat or drink, refuse to sit up. That is a sign that possibly the child may have postural giddiness or unexplained tachycardia. There was a study being performed and published from Thailand, which looks at the clinical manifestations of dengue patients in children according to age group. I think the study highlighted there are different manifestations of dengue in different age group. And if you look at the summary of the study here, basically some manifestations are common for all age groups, including fever, nausea, anorexia, and vomiting. Older children tends to present with abdominal pain and vomiting. Young infants tends to have some very peculiar signs and symptoms. For example, they may present with seizures, URTI symptoms like rhinorrhea and cough. They can have diarrhea, they can have rash, and they can have hepatomegaly and splenomegaly. These symptoms tend to be appears to have, at least in this study, shows to be more common in young infants compared to older children. So obviously there are quite a large range of differential diagnoses that we have to entertain as well, and it depends on the phase of the illness. The initial phase of the illness, when the febrile phase, then you could have flu-like syndromes, illness with rash, diarrheal diseases, and illnesses with CNS manifestations. And then you have, when during the critical phase, when they go into shock, then you can have other differential diagnoses, including infectious, malignancies, and other clinical features. With the COVID pandemic, COVID and its complication becomes an important differential diagnosis as well. So COVID-19 can manifest like flu-like syndromes or respiratory illness in the child, and MyICID, which is the multisystem inflammatory syndrome in children, can also present, can become one of the differential diagnosis in a child who presented with fever. And so these are becoming an important differential diagnosis that we have to entertain with during this COVID pandemic era. I just like to stress a little bit more about MyICID. This is basically a severe hyperinflammatory syndrome, and it's been described in children and adolescents up to the age of 21 years of age. It is a sort of a post-COVID conditions occurring usually 2 to 6 weeks after acute SARS-CoV-2 infection. And the clinical features is that of toxic shock syndrome or Kawasaki disease. So fever is a prominent feature there. It can impact 1 in 3,000 cases of after the acute COVID infection. Majority of them will require ICU admissions, and with a not so insignificant mortality, 1 to 2%. So this is condition that we have to be, all of us have to be aware of when the child presented with fever and appears to be sick with shock and possible rash as well. How can we differentiate between dengue and MISC? So many of the features are actually similar, especially fever, rash, abdominal pain, and altered sensorium. It can happen in both dengue and MISC. A few features that suggest more of MISC would be conjunctival injection, swelling of hand and feet, and the CRP could be extremely high in MISC. We're talking about a reading of more than 100 usually, and other inflammatory markers can also be very, very elevated in MISC. Okay, hemoconcentration is seen mainly in dengue and should not routinely be seen in patients with MISC, and left ventricular dysfunctions is also more common in MISC compared to dengue. So there are features that could differentiate between dengue and MISC. So when we try to look in more details regarding the assessment in terms of history, examination, and lab study, it is important that history is taken systematically, and there must be focus on certain areas of history that will highlight the possibility, not just for the diagnosis of dengue, but also the severity of dengue infection. So the sort of date of onset of fever, symptoms and severity that the child presented with. There are three important questions that need to be asked in more details. How much oral fluid is intake the child took? How much urine output in terms of frequency, volume, and time of most recent voiding? And what activities could the patient do during the febrile illness? Okay, other things that need to be asked for is other fluid losses, especially diarrhea and vomiting, and we have to quantify this and look for presence of warning signs. Other part of history that we routinely take should be the family history of dengue, other exposures, and risk factors and comorbidities. For physical examination, we have to look at the general assessment. Mental state of the patient is important. Check for hydration status. The child can be dehydrated because of vomiting and anorexia or diarrhea as well. And the hemodynamic state. The clinical evidence of warning signs should be looked for. Bleeding manifestations like mucosal bleed, abdominal tenderness, liver enlargement, fluid accumulations, for example, pleural effusions and ascites, and other important signs, for example, rash, tachypnea, and acidotic breathing. Okay, the hemodynamic assessment is crucial in assessment for dengue. And I think we are very familiar with this slide again to look at CC-TVR, the conscious level, capillary refill time, extremities, peripheral pulse volume and heart rate, and measurement of blood pressure, pulse pressure, respiratory and urine output. And it's very important point that assessment of a child, hemodynamic assessment of a child requires the child to be touched or examined or palpate. So if not, otherwise we might miss the early signs of shock happening in the child. Okay, important point for children is that we look at heart rates and blood pressure in children. Children can have a range of normal heart rate, and it depends on the age of the child as well. So it is very important that we acknowledge and know about this. The heart rate can be affected by child's activity, anxiety, or also fever. When we try to interpret whether it's tachycardia or not, please take this into account as well. Okay, the blood pressure also depends on the age of the child, so there are formulas to look at hypotension in children. I think it's also very important that wherever the child is being assessed or managed, whether in emergency department, also in the health clinics, for example, if you're going to manage a sick child with dengue, that a nomogram of normal values for heart rate and also blood pressure should be made available, so that interpretations of the heart rate and blood pressure can be done appropriately. Okay, blood pressure, when we do, make sure that we have a proper size cuff as well, because of inappropriate size cuff will give inappropriate reading, and the child may be managed inappropriately in this situation. We do some lab investigations to manage dengue. The usual blood investigation would include full blood count and dengue rapid combo test. I think this is available in most places, and that's usually enough for the early management of dengue. Okay, some of the patients that require admissions may require certain extra investigations, including renal function tests, liver function tests, random blood sugars, and also blood gases. And in some severe dengue or cases that die, and we should not forget to do dengue PCR or viral isolations, so that we will be able to diagnose dengue with certainty. But one caution is that laboratory results should be correlated with clinical presentations of children suspected of dengue. Sometimes children, other illness can present similar to like dengue, and if the child has had recent dengue infection, the serology test may be positive in a child who presented with another illness. Hematocrit value is also important and also have to be interpreted carefully in children. There's also a range of normal hematocrit value for different age group. Overall, we can see that very young babies will have higher hematocrit. Later on, they become much lower, and until it becomes adult value. So interpretations of hematocrit is also quite important for us. And we have to look at the baseline hematocrit on day 1 to day 3 will give us a good pointer to be used as a reference point in children. And it's also an important point to note that hematocrit should not be used on its own to decide fluid therapy. So hematocrit is very useful, but other hemodynamic status, urine output is also an important component when you try to assess whether the child requires IV fluids or not. Lastly, I'll be talking on management in terms of treatment and management decisions in dengue. I think this quote taken from a WHO guidelines 2009 still hold very true, and I think is the crux of the understanding on how to manage dengue. And the words is the key is early recognitions and understanding of the clinical problems during the different phases of the disease, leading to a rational approach to case management and a good clinical outcome. Okay, we just need to know what is happening, where in the terms of illness the child is in, so that we will be able to interpret the laboratory findings, the clinical features appropriately. So when to refer for admissions, these are fairly similar to the adults guidelines. Presence of warning signs, features of severe dengue, presence of comorbidities and social factors. Infants age group, infants less than 12 months of age is also considered to be a risk factor, and we recommend that children less than 12 months old, because of difficulty in assessments, because of more likelihood if they develop severe dengue to be in having more trouble in terms of management, that they should be admitted to the ward. So when we come up to management decisions, we have 3 situations. A child can present with dengue fever, a child presenting with dengue fever with warning signs, and also those presenting with severe dengue. Those presenting with dengue fever, the management usually can be managed at home. They don't need to be admitted to the wards. The important points is to have adequate fluids intake. Okay. These are home care advice that is available in the guidelines there and will be published as a pamphlets to be given to parents to bring home. They have to take an adequate fluids amount and then they have to manage fever with tepid sponge and antipyretics. And usually the antipyretics they suggested is to use paracetamol with a dose of 10 milligram per kilogram per dose, not more than 4 times in a day. We discourage the use of non-steroidal anti-inflammatory drugs like aspirin or brufen, and steroid obviously should be avoided. We need to identify warning signs early and follow up the patients daily. So the warning signs and the danger signs of dengue infections include certain things like poor feeding, obviously bleeding, vomiting, abdominal pain, drowsiness, pale cold or clammy skin, difficulty in breathing, and reduced urine output. And the child should be followed up daily, and you have the daily monitoring charts. Monitoring, which includes taking a full blood count and looking at the hematocrit value of the child. For dengue fever with warning signs, this patient is advised to be admitted to the hospital for inpatient care. They will require monitoring of hemodynamic status frequently, and we use hematocrit to guide interventions. Use of isotonic IV fluids judiciously, and we have to correct metabolic acidosis or electrolytes imbalances as needed. So in terms of IV fluids management for dengue fever with warning signs, we have the flow chart here, which is basically a very familiar flow chart that have been used in the pediatric protocol as well before. I think the important point here is that fluids need to be given. Usually we give isotonic crystalloids starting with 5 to 7 mils per kilogram for 1 hour. And if the child improves, then we start to titrate down the IV fluids according to the hemodynamic status, urine output, and hematocrit value. And usually the IV fluids should be able to be stopped within 24 to 48 hours. And the important point is not to use hypotonic solution. For example, dextrose 5%, half normal saline, or 1/5 normal saline. We have had cases of children being inappropriately resuscitated in health clinics with hypotonic solutions. A child walks into the clinic with a dengue fever with warning signs, was run with IV drips, hypotonic half normal saline, and half an hour later the child had a seizures because hyponatremia. In terms of for severe dengue, child with severe dengue, these children requires emergency treatment and urgent referral. With severe dengue with compensated shock, the algorithm here, it is very important that we make sure that at least the child has a continuous ECG and pulse oximetry monitoring, and that when we give IV fluids in children, that we use infusion or syringe pump, not just a drip method, drop method. The IV fluids need to be given at a bolus of 10 to 20 mils per kilogram over 1 hour. Then reassess again. The patient is stable, then we can gradually reduce the rate of infusion similar to that for patients with dengue with warning signs. Those unstable, we check the hematocrit value. If the hematocrit is high, suggesting that the patient has not get adequate fluids, we give second IV fluid bolus. If the hematocrit is low, then consider that it could be bleeding and that we might have to use fresh packed red cells or fresh whole blood. And the dose is 10 to 20 mils per kilogram. In children that presented with severe dengue and hypotension, the management becomes more urgent. We have to stabilize the child and run IV fluids 20 mL per kilogram over shorter period of time, 15 to 30 minutes. Reassess again. If the shock has been reversed, then we can gradually reduce the rate of infusion as we have done before. If the child is unstable, again check the hematocrit, and the hematocrit is high, we can give another IV fluid bolus, and we consider that probably for the second bolus that we use colloid solutions rather than crystalloid solutions. If the hematocrit is low, consider that the child may have occult bleeding and give fresh packed red cells or fresh whole blood. And if it's refractory, then we have to reconsider the condition and consider a few factors. The child may require assisted ventilation. Consider that the child continue to have bleeding and also leaking at the same time. Look for the source of bleeding if possible. We may need to transfuse fresh packed cells again and again, and also other blood components. And we have to check coagulation profile. Also consider, could this be co-infections and child is having septicemic shock, and we have to take blood cultures and start antibiotics appropriately, and consider using of inotropes or vasopressors. And then we have also consider whether there's myocardial dysfunction, and echo would be helpful in these situations, and inotropes or vasopressors will also be required in these situations. And we have to always correct the electrolytes and acidosis, as this will cause child to not respond to treatment as accordingly. So types of IV fluid in dengue, I've mentioned that crystalloid is crystalloid solution is the fluids that is recommended to be used for resuscitations and maintenance therapy. So the isotonic crystalloid solutions include full normal saline, Ringer's lactate, or Hartmann solution. You can also use stereofunding if you have that available for you. Colloid solutions can be used in certain circumstances. This includes persistent shock despite resuscitation with the crystalloid solutions. There are a few different colloid solutions that is available to be used. So in the circumstances where you have an obese or overweight children, so what weight should you use for these children? Yes, we use ideal body weight for children. There are multiple methods to calculate ideal body weight. There are at least 4 different methods in the literatures. Some of you will be familiar with at least one of the methods. So if normal height 5 to 95 centile, we usually recommend in the guidelines to use more methods, which is the ideal body weight is the weight for the age on the same percentile as height. Okay. If the child is tall and obese, it is more than 95 centile in terms of their height, use McLaren method, which is looking at the weight at 50th centile for height and age. This is an example of McLaren methods. So finally, take-home message. We have to consider dengue in any child presenting with fever. And remember that they may present atypically with, for example, upper respiratory tract infection, with febrile seizures in young children, and this sometimes can confuse in terms of diagnosis. Dengue should always be considered in any child presenting with fever. Secondly, you have to assess the child thoroughly and systematically. You have to have focused history taking and physical examination and perform relevant investigations to support the diagnosis and for monitoring of the patients. Monitor the child adequately, frequency of monitoring based on phase of illness and severity, and emphasis should be on hemodynamic status, hematocrit value, and urine output. And IV fluid should always be used judiciously in a child, because the child is at higher risk of developing whether under volume because inadequate fluids resuscitations, or overloading because too much fluids be given to the child. And most of the time, isotonic crystalloid solution can be used for resuscitations of the patients. Thank you very much.
Thank you, Dr. Nick, for such a wonderful presentation. So currently we have a few questions on the Slido, and to all the participants, please key in your questions into the slido.com, and then you can actually scan that QR code and then join the Slido and key in your question onto the Slido. There are a few questions pertaining to congenital dengue. Question on how to diagnose a congenital dengue in those cases.
Okay, thank you very much. Yeah, I think I purposely left out congenital dengue in my presentation because it will be, it's going to take a long time to when we talk about congenital dengue. It certainly can happen. The risk, the perinatal transmissions of dengue can happen. It could be a vertical transmission, you have a congenital dengue, or it could be just actually postnatal transmission when you just have a neonatal dengue infections. And it's sometimes going to be very difficult to differentiate between the two. Some of the features that would be helpful is obviously if the timing of the infections or the timing of representations of the child, of the babies. So if it's the first week of life, the baby already have symptoms, that it could more likely be that it's a vertical transmission and it's a congenital dengue should be entertained. We also obviously have to look at the mother's history. If their mom is obviously a dengue just prior to delivery, then there's the risk there of congenital dengue or vertical transmissions of dengue happening. So, so I think in a sense, if the earlier the presentation is, the more likely it is going to be congenital dengue. And investigation-wise, I suppose that if you can show the results that we can do the serology, IgM, because since IgM does not cross the blood, the placenta, then if its IgM is there early on, that might suggest that baby is infected with dengue infection. Commonly now we have PCR that is helpful as well to detect that. In terms of symptoms, in terms of manifestation, I think it's not going to be too different. Overall, dengue, neonatal dengue will present with fever, which is because fever is not a common neonatal sign. A baby with infection usually don't present with fever, but in a few special infections like dengue, they tend to have fever. So fever is a point there. Basically lethargy, looking like the baby is not active, not feeding well. They can have rashes and they can have bleeding manifestation as well. So those are signs of sort of dengue happening in neonatal period. So just be careful. Dengue in neonates can be congenital, that is a vertical transmission, but also can be a postnatal transmission because they have just been exposed to dengue after the delivery. Thank you.
Okay, well, very difficult situation, right? So there is also another difficult questions, and I think it is out of interest. It is of interest to know that in the COVID-19 pandemic, together with the dengue, okay, in children, MISC and dengue, the question is regarding how to manage MISC in COVID with superimposed dengue and also, it could be a false positive dengue test in COVID. So what do you use in the fluid regime?
All right, okay. So it is challenging, yes, with MISC and dengue. I think the important point here is the quote that I put there, to understand where we understand the underlying problems and where we are with the phase of disease. So we have to review back the history and the physical examination, and that could help us to point more likely whether it is going to be just dengue, is it MISC, or is it actually truly both dengue and MISC happening in the same patient? So if it's dengue, I think management should be the same according to the phase of the illness. The fluid regime should be according to that as well. In terms of MISC, if we could differentiate the two well through the history, physical examination, and investigation that we do, then we could manage accordingly. I think in terms of fluid, there's not going to be too much of an issue, because unless the child have evidence of myocarditis, then the amount of fluids that we run with usual dengue regime could overlook the child. So I think we just have to be careful, look at the history, examination, and parameters, and we assess accordingly. So we have just to be careful with the fluids. If you run, the child came in shock in the emergency department, and you're not so sure whether this is dengue or MIC manifestation. For example, they present day 4 and day 5, so we can't really differentiate between the two. If the child's in shock, you have to run fluids, you run the fluids. So the amount of fluids, you may have to be more judicious there. You might just want to run 10 mils per kilo rather than 20 mils per kilo, and see whether, reassess the child, is it improving or getting worse? If it's getting worse, then our concern would probably be whether the child has some form of myocarditis or cardiomyopathy, and then that we have to do accordingly, manage accordingly with echo and pori, the inotropes and so on. So yeah, you have to be careful.
Okay, I truly understand, because this is a very not a very clear-cut situation. Yeah. So another question is in terms of dengue shock, what is the percentage and volume of human albumin? Because you mentioned that in colloid human albumin can be used. What is the percentage of the human albumin, and what is the volume also as well?
Yeah, I think for the human albumin, we use the 5% albumin, so that would be it's about isotonic with our serum, with our plasma. So I think that's the volume that we want to use. Sometimes we have it available in the pharmacy. They have the 5% solution. Sometimes they don't have. They have the 20% human albumin solution. If it's a 20%, then we have to dilute to make it 5%. So you run the same volume that you run for colloid. So depending on the situation, maybe 10 mils per kilo up to 20 mils per kilo. And usually, yeah, that's usually the volume that we run.
So, okay. So I see that sometimes in dengue shock syndrome in children, the management of the dengue shock syndrome is, if I'm not mistaken, I'm not a pediatrician, but I've seen our pediatrician, they actually put house officers or doctors by the bedside, and, never leave the baby or the children alone without being monitored. Is that true?
Okay, if you have the staff available to do that, that would be very good. Okay, but I think the important point there is that monitoring must be a close monitoring, especially a child who's very sick. So it cannot be 4-hourly monitoring, 6-hourly monitoring for the very sick one. So if possible, it's bedside. Someone is available on the bedside. Whenever you do an intervention, you reassess again. A reassessment, not just through the cardiac monitors, but also through the actual touching of the child to assess their capillary fills, the pulse volume, and so on and so forth. So I think that's a good idea to have someone close, but it may not be available in all circumstances. And I think most centers cannot do that. But I think the idea is that it must be very close monitoring and bedside monitoring that need to be done.
So in adult, we also have, I think this is going to be my last questions. In adult, we also see, not to say that uncommon, but hemophagocytosis. Did you see this in children?
Yes, actually, it is one of the, as you say, it's not very common, but it is one of the differential diagnoses in a child who has persistent fever, or who develop worsening of condition despite you feel that the child is already over the critical phase. And it does happen, and we do investigate for that, but it's not a very common conditions that happens.
All right. Thank you very much, Dr. Nick. And then I think we have already overshot about 15 minutes. So this is for time. Thank you, Dr. Nick, for your precious time to share with us an update of dengue in children management. And for all the participants, please be back by 2:15 because we push backward 15 minutes because we are a little bit running out of time. So 2:15, please come back and join the afternoon session. The session hasn't ended, and I believe that in the afternoon, there are also very interesting topics to discuss and to hear. Thank you very much.
Choi.
Hi, Bob. How are you?
I'm fine. How are you? Getting handsomer and handsomer. Why are you getting handsomer?
No, just makeup.
Good afternoon, everyone. Welcome everyone again to the webinar on managing dengue in the COVID-19 pandemic, jointly organized by MyICID and NIH. I'm Dr. Patrick, an ID consultant in HUCAM, your moderator for this afternoon session. Thank you for joining us live from social media platforms too. For the Q&A, like usual, please type your questions in the Slido app. Regarding the CPD points, all frontliners, healthcare professionals, and allied health teams, remember to collect your CPD points by filling up the online attendance form. In case you missed it, it will be broadcast again after the Q&A session. Please double check your email address before submitting. For MMA users, you can scan the QR code displayed during the break time or at the end of the webinar. Okay, we will start this afternoon session with a talk entitled Dengue in Special Population. This will be presented by Dr. Neng Kiang Koi, ID consultant from Hospital Tuanku Jafar Seremban. Dr. Neng Kiang Koi, I think it's not most of you would have known him. He obtained his postgraduate in 2011 before joining ID services in 2014. He's now the ID consultant of HTJ Seremban since 2018. We were very privileged to have him with us for a couple of months. Unfortunately, we couldn't lure him to join us. It's a very thorough and very good ID physician. He presented in various conferences and courses. He's also involved in multiple research activities. Without further ado, I now want to invite Dr. Ng to share his presentation. Dr. Tiang Koi.
Thanks to the organizing community for giving me opportunity to present on this topic, dengue in special populations for the current webinars. I'm Tiang Koi, infectious disease physician from Hospital Tuanku Jafar Seremban. This is my disclaimer. For the next 30 minutes, I will touch on the anticoagulant in dengue patients with VAF replacements and venous thromboembolisms. Also, the antiplatelets in dengue patients with cardiovascular diseases who is taking long-term either mono or dual antiplatelet therapy. And the third one is the dengue patients with pregnancy. Case 1, a Miss CC1, 36 years old lady. She has mitral valve replacement for underlying severe mitral stenosis. She is taking warfarin 2 milligrams daily, compliance to medications. She is complaining of fever, arthralgia, myalgia for 2 days. Still able to tolerate orally, seems still well, ambulate around, no bleeding manifestations. Clinically appear well and physical examinations unremarkable. They did the dengue combo test for her, NS1 antigens positive, IgM and IgG negative. Here is the full blood count: white cells 6, hemoglobin 11, hematocrit 34%, and the pellets 108. And her INI is 2.5 with the FTD of 42. Second case, Mr. ZA, 62 years old man, underlying type 2 diabetes, hypertension, BPH, and IHD with 2 vessel disease, recently stented with the drug-eluting stents. He was taking dual antiplatelet therapy on top of other usual medications. He presented with 4 days of fever, dizziness, and lethargy, associated with sore throat and cough during the first 2 days of fever. There was no sign and symptoms of bleeding. Clinically, he appeared tachypneic. Blood pressure and glucose seems uncontrolled. Heart rate is highish, and the temperature setting, saturation is 96%. However, pulse volume is still good, warm periphery CRP less than 2 seconds. Lungs reduced entry over the right base. Abdominal got tenderness at the epigastric regions. Blood counts, white cell 3.1, hemoglobin 15, hematocrit 46.6 with the platelet 68. The pH is 7.4, PCO2 33, PO2 90, bicarb 18.9, and lactate 2.5. The dengue combo test NS1 antigen and IgG positive. Looks like he had secondary dengue. Now we reach a crossroad of the clinical decisions to manage the two cases that I presented earlier. Number one, when to bridge the anticoagulants. Number two, when to stop the anticoagulants or the antiplatelets. Number three, when to reinitiate the anticoagulants or the antiplatelet if we stop it early on. Obviously, there are limited available evidence and no guidelines on how to manage anticoagulants and antiplatelets on such a case. So the risk of the bleeding need to be balanced against the risk of the thrombosis from interruptions of the anticoagulants or the antiplatelets. Hence, the case management is really case-to-case basis based on the expert opinions from various managing teams with extrapolated evidence from the non-dengue patients. However, the thrombocytopenia, platelet dysfunctions, and the coagulopathies in dengue fever are really dynamics. We have the safe platelet cut-off for the anticoagulants from the non-dengue patients. Tufano et al. Suggests that actually the mild to moderate thrombocytopenia of platelet counts more than 50,000 shouldn't be an issue for the VTE preventions. However, in the severe thrombocytopenia, the prophylaxis should be considered on an individual basis. The recently published expert consensus also suggests that the anticoagulations with low molecular weights at therapeutic doses for platelets between 50 to 100 is safe for conditions in acute and non-acute VTE. And actually the platelets of 30 to 50, the doses reduced to 50%. Just now we talk about the safe platelet cut-off for the anticoagulants. What about the interruptions of antiplatelet therapy? It is safe. So now we look at the paper from the Singapore colleague. They looking at the safety of the temporary interruptions of antiplatelet therapy in a dengue fever with thrombocytopenia. This is actually a cohort, retrospective cohort study of adult dengue patients on the antiplatelet therapy for both ischemic heart disease or stroke. And decision on continuation or discontinuation of antiplatelet therapy is made on the clinical ground in discussions with the patients by the attending physicians. The primary outcomes look at the composite outcome of major adverse cardiac and cerebrovascular events and all-cause mortality in hospital and for 1 year post-discharge. Secondary outcomes are platelet and blood transfusions and occurrence of dengue hemorrhagic fever, dengue shock syndromes, dengue with warning signs, and severe dengue according to WHO criteria. Relatively small number of patients in this cohort, 15 of them will continue antiplatelet therapy. 2/3 of them on antiplatelet therapy for ischemic heart disease, while 1/3 actually for ischemic stroke. 11 patients actually had PCI with coronary stents in the cohort. Comparing the two groups, those patients continue on antiplatelet therapy had a higher median Charlson's comorbidities index and also higher median platelet nadir. Only 5 patients developed non-fatal ischemic stroke. 2 out of 15 for those who continue, 3 out of 51 who discontinue antiplatelet. None of them actually had the coronary artery stent thrombosis or major cardiac event. So there's no difference between the both groups for the primary and secondary outcome. And from this paper looks like the clinical judgments based decisions on the continuation or discontinuations is safe. However, more study needed for the conclusions. We look at higher evidence of the antiplatelet interruptions, but from the non-dengue cohort. So this paper were actually looking at the bleeding and ischemic events for the adults who undergone non-cardiac surgery. Cochrane's systemic review showed that there were no difference between both arms for the all-cause mortality up to 30 days. Similarly, for all-cause mortality up to 6 months. And the risk of ischemic event within 30 days was similar between both arms. Even though the half-life of aspirin is only 20 minutes, the effects of aspirin may last for a few days up to 10 days due to the turnaround times for the COX activity to recover. In dengue fever, the immunosuppressions and peripheral destruction of platelets causing thrombocytopenia and also the platelet dysfunctions actually may prolong the effect of aspirins. In a nutshell, how are we going to utilize the evidence that we have to approach the anticoagulants and antiplatelets in dengue fever? These are the few situations that we need to consider. Whether the patient has a significant bleedings at the moment, what is the phase of the dengue fever at the junctions, presence of the warning signs of severe dengue, what is the platelet trend, risk of the thrombosis and the bleedings for the particular patients. Hence, the multidisciplinary team approach is needed. And don't forget, we always need to discuss and make decisions together with the patients and our family. If the patients have significant bleedings, obviously we need to stop the culprits, which is the anticoagulants or the antiplatelets. Give the antidotes if available, such as vitamin K for the warfarin, idarucizumab for the dabigatrans, and fresh frozen plasma or prothrombin complex concentrates, and the platelet concentrates, and or plaque cells or whole blood transfusions. Stabilize the hemodynamics is the priority now. If the patients without significant bleedings, I would suggest withhold anticoagulant or antiplatelet in the dengue fever with severe dengue or the platelet less than 50,000. Consider withhold anticoagulant or antiplatelet in dengue fever in febrile phase with warning signs, or reducing platelet train to between 50 to 100,000, especially those actually with high risk of bleeding but relatively lower thrombosis risk. If the situation that require us to continue with the anticoagulants, especially in patients with high risk of thrombosis but relatively low risk of bleeding, then switch the anticoagulants to low molecular weight heparin or conventional heparin infusions when they're INA subtherapeutic. If the platelets range 50 to 100,000, or even earlier when the platelets more than 100,000 in a febrile phase, because we expect that platelets will drop sooner or later. Multidisciplinary team management with the cardiologists, hematologists, intensivists or NS, patients and the patient's family needed actually for the decision making. Just to make sure we are on the same page. Looking at the clinical course of the dengue fever, the platelets actually gradually dropping during the febrile phase to the nadir level during a critical phase. And only after recovery, the platelets were expected to slowly increasing after. When we reinitiate anticoagulants or antiplatelet, generally, it can be resumed once every dengue patient in recovery phase and the platelet improving trend to 50,000 and above, unless any specific contraindications. Now we move on to case number 3. 28-year-old Primi Gavida at 32 weeks and 6 days. She was referred from private for sepsis. She presented with only high-grade fever for 1 day, without any other specific symptoms. BP on arrival lowish, 90/60, pulse tachycardic 106, afebrile, just took paracetamol. Her blood count, HB 12.9, hematocrit 38, platelet 250, and white cell 13.9. Likely this is the reasons why they refer for the sepsis because of the high white cells with a lowish BP and tachycardia. She was given 2 pints of normal saline bolus in the casualty, repeated blood pressure 100/66. Then was followed by the drips 1 pint normal saline over 2 hours, which is equivalent to about 3 mL per kilo per hour. This table shows the clinical and investigations trend according to the time frame. So initially, the dengue was not that obvious, or only apparent on the day 3 onwards when actually the white cells and the platelets started to drop. And they did the dengue NS1 on the day 3, it was positive. What's striking here actually is the bicarb persistently lower side, and it gets worse despite hydration. You can see the clinical parameters relatively stable, even though the blood pressure lowish and the pulse looks a bit tachycardic. And he appeared to be dyspnea on the day 4 onwards, after much fluids was given, about 4 liters. So what we can see from here is the obviously initially missed the dengue. Second actually is the patients having overload due to the overzealous fluids given just purely based on the tachycardic and lowish blood pressure and the metabolic acidosis. Likely, I think the subsequent worsening metabolic acidosis due to the hypercholemic metabolic acidosis from the normal salines given. After notice the issue with these patients, and the fluids actually was stopped, and the patients actually were transferred to ICU for the non-invasive ventilations. Just to refresh our memory about the physiological changes in pregnancy. So what happened actually is the dilutional anemia happens when actually the blood volume was much more than the increments of the red blood cells relatively. And the similarly actually for the thrombocytopenia due to hemodilutions and also the increased consumptions, aggregations causing the thrombocytopenia in about 7 to 8% of all pregnancy, especially the second half of the pregnancy. The cardiac outputs increased by 30 to 50% in pregnancy due to the increase in the stroke volume, increase in the heart rates, and reduce actually in the systemic vascular resistance and also the pulmonary vascular resistance. Here, similarly, you can see that the enlarging uterus and the hormonal changes affect on the respiratory functions in pregnancy. The tidal volume increase, but reduce in the total lung capacity and the functional residual capacity. So from the blood gases, we can see that in a pregnancy, they have a respiratory alkalosis with compensated metabolic acidosis, especially in the 3rd trimester. The pH will be around 7.4 to 7.45, PCO2 around 28 to 31, and the bicarbs around 18 to 21. We observe a higher percentage of severe dengue infections among the pregnant women compared to non-pregnant women when contract the dengue fever. The significant bleeding due to the thrombocytopenia is not that common, but increased risk of hemorrhage in the presence of dengue shock syndromes. What is the risk of the dengue in a pregnancy towards the fetal outcome? This systemic review and meta-analysis show there is various adverse fetal outcome in terms of miscarriage, stillbirth, preterm birth, and low birth weight. However, this meta-analysis done a year later show that there is no adverse fetal outcomes from the maternal dengue virus infections. So what is the truth behind? Obviously, we need more studies to prove that. Now we reach the terminal end of the pregnancy. Dengue infections is not an indication for elective delivery. Majority of the patient actually can allow to progress to spontaneous vaginal delivery. Premature labor can occur during the acute infections. It is advisable to delay the delivery until the acute infections resolve with the tocolytics if indicated and appropriate by the obstetricians. Close fetal monitoring is required in this group of patients to detect the fetal distress, and decisions for the delivery can be made. All pregnant mothers with dengue should be co-managed in the hospital by physicians, anesthetists, and obstetricians. Deliveries should be conducted by the obstetricians or the senior medical officer if it's in a hospital without specialists. Instrumental delivery should be avoided wherever possible, and if indicated, the procedure should be done by an obstetrician. If the decisions of instrumental delivery or operative delivery is met, the blood and the blood products must be made available. Active management of the third stage of the labor in preventing postpartum hemorrhage is required by the use of intravenous uterotonic agents. Avoid the intramuscular injections in thrombocytopenia. Pellet transfusion is only recommended if the manifestations of bleeding, decisions for cesarean sections, or instrumental delivery, and the pellet transfusions should targeted to achieve minimum of 50,000 to ensure the maternal safety. In summary, there is no clear guideline available for the management of anticoagulants and antipellets in patients with dengue fever. The risk of bleedings need to be balanced against the risk of thrombosis. Multidisciplinary approach is required for these cases. For the dengue in a pregnancy, hematocrit value in pregnant women usually lower compared to normal adult due to hemodilutions. The dengue infections in pregnancy had a higher risk of developing severe dengue and mortality. Dengue infections in the pregnancy has higher adverse fetal outcome. Routine pellet transfusions is not indicated unless there is presence of bleeding manifestations or the patient is planned for procedure. Intramuscular injections must be avoided in pregnant patients with thrombocytopenia. Here is the end of my talks. I would like to thank everyone for your attention.
Thank you very much, Dr. Tian Koi, for that excellent overview on the management of dengue in patients with difficult situations. Currently, there's still no question relating to your topic. So I'm going to just start the ball rolling first. For that Singapore study that you mentioned, did they say when to restart in the cases of when they stopped the aspirin, or they didn't mention it in the study on those cases where they stopped the aspirin?
Okay, thanks, Dr. Patrick. The study actually is retrospective study. So the those are the from the notes that they managed to find, some of them actually got the records on when actually they start. But there's as a general, there's no clear cut off when they start. As long as most of them are platelets improving trend, their patients recovering, then they started. Some actually they restarted the antipellets after discharge and come for the TCA.
Nevertheless, I think it's very reassuring, although the numbers are few, that gives us some confidence in stopping in cases where, like you mentioned, the 6 parameters to consider before you stop the aspirin. So there is a question now in the silo. It says, in view of hemodilution in pregnancy, do we still monitor hematocrit according to normal value?
Oh yes, for these questions, the hemodilutions cause the baseline for the pregnant patients actually to be lower than the normal the populations for the female. So it's better actually if we have the baseline hematocrit trend from their antenatal book or any previous or of the recent blood counts record. So otherwise actually is the serious hematocrit trends during the management that will be matter the most.
Okay. Since we are on the pregnancy topic, Jankoi, you mentioned that keep the platelet at least 50 if you are surgery, going for a cesarean section and all that. But many of the times, doctors might be also afraid if the platelet is less than 50, do we do anything to allow spontaneous delivery? Should we keep the platelet also above 50 or we allow normal delivery? What is your opinion?
For the normal delivery, if it's not expected to have any in terms of the difficulties in the delivery that we might need to use any procedure such as the instrumental delivery, then I guess that is that's fine. So unless there's such situations that we think that these patients might need to go for instrumental delivery, yes, I of course always be prepared in terms of the at least patients grouping is available so that they can get any immediate platelet transfusions ongoing if needed.
Okay. I still put you in a spot, Tiangkoi, and I'll push you further on this because sometimes we have breaking points. What if the platelet is below 20? People will be very afraid going for spontaneous. Is there a cutoff where you yourself might consider prophylactic platelet transfusion in normal delivery?
Yeah, honestly, I don't really. Just that have to make sure the every preparations actually is available for the patients in case we need it. Because in most of the time, if it's needed, if having bleedings post SVD and so on, so of course all the measures actually can be taken as soon as possible.
Okay, thank you. In terms of your major thrombosis risk that you mentioned, good that you have mentioned on, you have tell us how to consider stopping warfarin, as you mentioned around 50 to 100, the multidisciplinary approach, 6 things to consider. And you also told us that we can actually start the heparin together, starting heparin and to bridge it. And I think if there's any evidence of bleeding, you mentioned that we should actually can stop the heparin test bleeding. Do you when you do start back, and I assume that the platelet is improving, on the way up or at least 50 and up, do you usually bridge warfarin and heparin together, or normally how do you recommend to us when we restart it back when the platelet is improving more than 50?
Okay, so for the once actually is recovery to the safe level of the platelets of 50, so we able actually to use either the continuous heparin infusions or low molecular weights heparin first to bridge with the warfarin, as long as the patients are already out from the severe dengue and there's no bleeding manifestations at that point.
Okay, thank you. There's something pertaining to the current situation, Tiangkoi, is about I think the previous speaker spoke about it a bit, but COVID and dengue with low platelet, and would you start antithrombotic therapy, or assumingly you've seen a confirmed co-infection dengue and COVID, God forbid, and you have a low platelet, how would you advise us on Clexane or antithrombotic one in co-infection? Don't know whether you've seen a few in your center.
Right. So far, I never encountered with the in terms of the severe COVID together with the severe dengue concurrently. So yeah, it's fortunate on the unfortunate pandemic seasons. The form in terms of the pulmonary embolisms. So I guess it depends on the needs, whether these pulmonary embolisms is at the point of time actually is the main concerns. Number two, actually also look at the severe dengue at what phase actually we are dealing with. So still go through the various how to say, the considerations that I presented just now. Also look at the actually patients whether got any active bleeding at the point of times, whether patients in what phase of dengue, whether any severe dengue or not. So all this actually to make into the judgment. Of course, if it's in terms of patients at the point of time hemodynamic stable, there is no evidence of severe dengue, and just that the platelet counts is only around 50 to 100s. So I did discuss with hematologists in the past before for our patients that have same scenario, not in the dengue, but with the thrombocytopenia and pulmonary embolisms also. So this kind of cases actually is that if it needed to give the treatments, then at least the safe level of platelets is there. Unless if it's occasionally the platelets is below 50, but we need to treat the pulmonary embolisms, they advise actually to give anticoagulant and transfuse the platelet at the same time.
Okay. So that's interesting. All right, good to know. All right. So I don't see any questions for you, Tiankoy, at this moment. So I think with that, I think I would like to thank Tiankoy for your excellent presentation and spending your Saturdays with us, enlightening us on this difficult topic.
Thank you very much, Paul.
Thank you. Thank you.
Thank you.
Thank you. We move on to our second presentation. I'd like to welcome Dr. Vijayan. He's a consultant in infectious, consultant in internal medicine and advanced acute internal medicine in Hesta Klang, to enlighten us on a presentation on ultrasound imaging in dengue fever. Dr. Vijayan has completed his master's in internal medicine from University of Malaya in 2014. Before completing training in advanced acute internal medicine in 2020. He has extensive experience in internal medicine, especially in acute medicine, in hospital and clinical settings, including managing severe dengue cases. Without further ado, I would like to invite Dr. Vijayan to share his presentation.
Thank you. Hi, good evening. Today I'll be presenting on ultrasound imaging in dengue fever in COVID pandemic. In this presentation, we will be fully focusing on ultrasound as a method which going to assist us on the diagnosis and treatment in dengue patients. This will be my disclaimer. So the outcome of today's presentation will be we should be able to master probe position and interpreting formed image to guide us in our clinical assessment and treatment in dengue patients. As I know here, we have a mixed group of doctors who's listening to this CME. They might be a group of people who have no experience on using ultrasound. Some might have some experience using ultrasound, and some who never had a proper guidance, teachings on using ultrasound. So in my presentation, I will start from the basic and we will move on to advanced in ultrasound in dengue patients. So the outline of my presentation will be two parts. The first part, I will touch little on the basics, the principle of ultrasound for dengue in COVID pandemic. Then once we covered some of the basic, we will move on into a detailed discussion on dengue patients, and we also will look into some of the pitfalls and some evidence that we have in our latest guidelines. So let's move on to my presentation, and this is going to be my first slide for my presentation. Where this part, I'll be touching a little bit on the basics. So we will talk a little bit on the equipment and cleaning, especially focusing on infection control, as we are now currently in the COVID pandemic. Then later on, we will move on into diagnostic ultrasound. And when we talk about ultrasound in dengue, there are few various types of scan. That includes echo, IVC, lung, abdomen, especially looking at the perinephric collection and gallbladder. And if you see, there's a huge topics here, which encountering ultrasound in dengue. So I won't be able to cover in detail all of this, but I'll try to pick up those are very important scans, especially focusing on dengue cases. So now let's talk about the basics of this ultrasound. If you see currently in this COVID pandemic, I are more comfortable to use a portable ultrasound. If you see what I'm using nowadays is a portable ultrasound, which is Lumify. So it comes with a probe and a wire, which I can attach this wire to a tab or phone. And the second important part is the cleaning of this instrument. So we can use a Saniclot. Saniclot is a non-alcohol base and is proven for coronavirus. So what we will do is we will clean the machine before and after scanning a patient, and the waiting time is 2 minutes. What I mean by that is you clean the machine, wait for 2 minutes to get dry, then you can use to a patient. And once you're done your scan, before you're coming out, you need to clean the machine again and wait 2 minutes to bring it out. And whenever I go inside to scan a patient, most of the time this patient will be a SARI patients or COVID patients. I will bring in a few packets of lubricant gel. But if you don't have lubricant gel and you have a bottle of gel, you can refill this gel into a syringe, 10 cc syringe, bring it inside, and you discard that syringe once you use. So if you look at this, the only two equipment which will be going in and coming out with me, that will be the ultrasound probe and the phone or the tab that I'm carrying with me, which I'll be cleaning it pre and post. So by doing this, we reduce the transmission, the infection transmission from one patient to another patient, especially in this current COVID pandemic. So, somehow we have covered about the basics of these equipments and how to clean the machines. Let's move on to a bit detail on ultrasound in dengue. So when we talk about ultrasound in dengue, as I mentioned earlier, we will be looking into echo, IVC, lung, and abdomen. So I'll be moving into echo first. When we talk about echo itself is a huge topic to be covered, and we need a day or 2 days to cover the whole echo points. But as this is only a 30-minute talk, I will only focus in one window, that is parasternal long axis. I'm not going to cover on parasternal short axis or 4-chamber, which will continue with 5-chamber and 2-chamber view, and I'm not going to look into subxiphoid 4-chamber view. So let's only focus at one view, and one point that is about third or fourth intercostal space, left sternal edge. And our focus will be looking at the LV function and LV collapse or LV kissing. That's one of the most common thing need to be picked up in hypovolemic shock in dengue. So this will be in this echo presentation. I think this will be the most important slide. I'm going to play a video where when I play this video, you need to focus on few points here, where how this probe is positioned on the patient, and look into the marker, how this marker has been placed to do a proper parasternal long axis view. Okay. So this will be a correct method where you will place your probe somewhere around third or fourth intercostal, left sternal edge, about 1 or 2 centimeters away from the left sternal edge. And the pointer usually should be placing towards patient's right shoulder. Once you had that position, you may need to do a minor adjustment like swinging or tilting the probe to get a very good view. And you can see the patient can be positioned in the supine. And if you can't get a very view, you can even change the patient into a left lateral cubitus to get a better view. So once you position your probe appropriately for the parasternal view long axis, you will be seeing such image in your monitor. So I'm going to play the video. As I play the video, I will explain about the findings here. This is a normal echo. So you can see here the LV. That will be our main focus in this presentation. And you can focus on this wall. This is an infralateral wall, and this is an IVS wall. We are not going to look much into mitral valve, the mitral valve pathology, LA pathology, or right ventricular outlet. No, we are going to mainly focus on the LV. So this will be a normal echo. So when we are encountering a patient with dengue shock or patient with hypovolemic shock, most commonly we will hear ventricle kissing. So what is this all about? When the lumen of LV been obliterated and when the ventricle walls touches each other, that's when we come with the term of when the ventricle kissings. That means the IVS wall and the infralateral wall start to touch each other where it is collapsed. And the LV will be very hyperdynamic, and the ejection fraction can be normal or higher normal as it contracts vigorously to pump the blood to the aorta. And there are many papers that have proven this ventricular kissing, especially patients in hypovolemic shock, not only in dengue, even in the other causes of hypovolemic shock. And whenever we see this ventricular kissing, is already an alarm sign that patients are already going into a shock. Maybe patients still are compensated shock, and if no proper fluid resuscitation, patient may go into a decompensated shock. So what we are going to see now is an example of a patient dengue shock in hypovolemic. Patients basically on compensated dengue shock. So let's focus on the LV function here. So you can see here, this is the ventricle, and you can see both walls are touching each other. That means these both walls are kissing. That proves that this patient have hypovolemic. So these are two videos here. On my right side here, this is pre-resuscitation, patient in shock. And on my left side, This is post-resuscitation, the same patient. This is not a dengue shock patient, but this is just a patient who came in with hypovolemic shock. So the reason I'm showing is just hope you can differentiate the ventricular kissing in a shock and how the ventricular contraction improves post-resuscitation. So here you can see the ventricle kisses touches each other, and here the contraction is quite good. So now we are going to look into a common pitfalls that happens when we do a echo to look for LV function and LV kissing. So what I will do is I will play the video first, then I will explain the pitfalls that you can understand better. So you can see here in this imaging, it looks like the LV is kissing, but in a real scenario, it is not, patient not hypovolemic shock. So what happening is the clinician actually not exactly had placed the probe at the middle of LV, but he's scanning at the end, at the side of the LV. So the lumen becomes smaller, the diameter becomes smaller, and it appeared as it is kissing. So when you have this kind of a situation, what we will suggest is try to slide your probe towards or away from sternum about 1 cm, so that you can confirm that your probe are exactly at the LV cuts at the center of LV to get a proper diameter and not looking at the side. So this is the common pitfalls that happens in LV function. And this is going to be my last slide for echo before moving towards IVC and lung scan. So here I've included a pericardial effusion. This is very uncommon findings in dengue patient, but the reason I included here is as we are doing echo, I thought we just learn about pericardial effusion. As I play the video, you need to identify first the descending aorta, which I will be labeling it later. Then from the aorta, we will identify the pericardial layer. Once we identify the pericardium layer, the fluid above the pericardium layer will be pericardial effusion. If the fluids happen to be below the pericardium, then it's going to be a pleural effusion. So that's the most pitfall that happens in dengue, where they can have both pericardial and pleural effusion together. So I'm playing the video. So you need to identify the descending aorta. That's the round structure. Then the highlighted layer will be the pericardium, and the fluid exactly lies above the pericardium. And if the fluid lies below the pericardium, it's going to be a pleural effusion if it lies here. So that's how we differentiate between pleural and pericardial effusion. So now we are going to move to IVC. In this IVC scan, which is quite commonly needed and is quite important in dengue management, we again going to look the same thing. We're going to look at the probe position, the basic, the normal findings, how to do a normal measurements, and then we look at the pitfalls and the pathological part of it. So now in this video, again, I'm going to play how to position the probe. So here you have to again look into a few things where the probe will be positioned at the midline. Then you can see the operator will drag the probe towards patient right, about 1 or 1.5 cm. As we know, the IVC lies towards patient's right, as the descending aorta will be exactly at the midline at the center. So I'll play the video now. So you can see he plays at the midline. Then he drags the probe slightly towards patient right. So that will be the proper method. So here I'll be playing a video. exactly the IVC scan. So this will be the main three structure that you need to identify when doing IVC scan. That you must have a view of RA, and you will have a view of liver. Sometimes you will view of this hepatic vein here. Then you should judge your IVC. So in this video, we are going to look at the common pitfalls or the common mistake that all of us do is, or the biggest challenge that we have when we scanning IVC is, sometimes we mistaken scan the descending aorta and we start to measure the descending aorta instead of IVC. Because these two lumen is lying side by side, and it's very easily, commonly, you can do the mistakes. So what I'm going to do is, before we go into detail to differentiate between IVC and descending aorta, I'm going to play a video. At the beginning, I'm going to scan the IVC. After a few seconds, I'm going to drag my probe towards midline, and I'm going to scan the descending aorta. So you try to view, and I think you must be able to differentiate how this IVC looks like and how descending aorta and how the pulsation of this descending aorta looks like. So let me play the video first. So this is IVC. You can see the liver RA, and it's collapsing when I'm pressing. So now I'm dragging the probe towards midline, and you can see this is a descending aorta where it is pulsatile. The lumen is very straight, it's going a bit towards down. So let's look detail how are we going to differentiate these two anatomical structure when we scan in the abdomen. So usually if you see the aorta will be smaller, and it will be towards patient's right, and the IVC will be towards towards patient's right. This will be left at the center. The aorta will be circular in shape. The IVC will be a bit elliptical shape. The aorta will be pulsatile, as I shown the earlier video. IVC is not pulsatile, and IVC will be able to be compressed, where you won't be able to compress the aorta. And sometimes you can see when patient do a deep inspiration and expiration or sniffing, you can see the IVC will change, will compress. So this is how we differentiate to confirm that we are actually scanning the IVC and not the aorta, because both will give a different findings, different measurements. And in patients who hypovolemic shock, the aorta might give a very good measurement, a bigger measurement, where the IVC might be collapsing. So now, once we manage to make a good view IVC, and we are going to proceed with measurement. So how a proper measurement should be done? So if you see here, this is a proper way to doing a measurement here, where this is RA, this is your liver, and this is your hepatic vein here. So the measurement should be done at least about 2 or 3 cm away from this hepatic vein here, and the measurement should be exactly perpendicular. So if this is your lumen, your measurement should be really perpendicular, about 90 degrees. That's give you a very accurate measurement. And if you, based on our CPG, dengue CPG, the latest CPG guideline, we talk about Cowell index. So what is this Cowell index in IVC measurement? So IVC measurement doesn't come as a single. It comes with two measurements where you should measure it on inspiration and expiration. Then we will calculate with a formula to look at the collapsibility. So how are we going to measure in inspiration and expiration is, when I get this view, I will click the M mode in the scan, and you will see a M mode will appear, and you get an M mode picture. So I will freeze the picture. Then I'll take the maximum diameter and I'll take the minimum diameter. So the maximum diameter represents on expiration and the minimum diameter represents on inspiration. So with that, for example, if I get 2 cm and 1.5 cm, I use the formula of 2 minus 1.5 divided by 2 times 100%. I will get my Cowell index. So this is a collapsibility index. That means the vessel collapsed 25%. Sometimes we do an eyeball rolling. Yes, if the collapsibility is very obvious, it collapses more than 50% or it collapses 100%, yes, we can do eyeball rolling. But when the collapsibility is minor, very small collapsibility, we can't do an eyeball rolling, and we, by right, should do an M mode measurement. And we use the IVC collapsibility index formula to get a very good collapsibility. And now the question back, why should we do this? Why should we measure IVC? And why we should measure the collapsibility? So there are a lot of data have shown that the IVC measurement and the collapsibility really correlates with patient's volume status. So if you have a patient with a very small IVC and it collapses 100%, you can say that patient is really severely under volume. But if you have a measurement like 1.5 to 2.5 cm, and it collapses more than 50, there's a room of roll of fluids. If collapse less than 50, you may say the patient is already in the euvolumic state. But if you see patient's IVC is dilated 2.5 and collapsing less than 50 or no collapsible, then you may be careful that this patient may into a hypovolemic state. So this scan and this measurement may assist us when we deciding on fluid resuscitation, and will help us to decide how much fluids to be given and when to stop our fluid resuscitation. So I'm pulling out a paper that recently I went through. This paper actually looks into ultrasound guided fluid resuscitation in a sepsis hypoperfusion, not in a dengue, but in a hypoperfusion, where they use ultrasound guided treatment, fluid resuscitation. So they had a 2-arm. There's one usual care, about 100 patients, and ultrasound guided fluid management in other arm. If you see in this study, there's no much difference in the 30-day mortality, where 6 hours post lactate clearance was the same, SOFA score was the same, length of hospital stay was the same. There's no much difference between these two groups. Yeah, of course, because even the usual care also, they have given an appropriate fluid resuscitation. But when I look into detail on this paper, the rate of vasopressor, that means inotropic support, and the cumulative fluid administration over 24 hours was lower at ultrasound guided fluid management arm. This is the similar experience that I have when I use ultrasound in managing patients, where it helps me to avoid over resuscitate, and it helps me to avoid under resuscitate a patient. So what I'm trying to say here is a fluid resuscitation has to be done for a patient, but with ultrasound IVC scan, it may guide you to avoid from giving over resuscitate or under resuscitate a patient. Now let's move on into looking into other third space loss in dengue patients. So far we have covered echo, looking at the LV function for fluid resuscitation. We saw IVC scan, which and the measurement of this IVC, which help us in fluid resuscitation. So let's look into the third space loss when patient goes into leaking. And when it leaks, we commonly see pleural effusion. So that will be next few slides. We are looking at the lung scan. Pericardial effusion, I think we already done our echo earlier, and we have seen the pleural pericardial effusion. Then followed by, I will show you a few slides of kidney scan and the gallbladder scan. So again, before moving into detail of lung scan, I will touch one or two slides on the basics of lung scan. Then we will look detail into pleural effusion. So this picture actually I've taken from scan in COVID patients, which is very useful. We do a 6-point scan on the right and the left. So total will be 12-point scans, especially in COVID patients. So we can use similar points when we scan for dengue patients. And patient can be either seated up or patient can lie down in supine position. So when we do scan, we need to place the probe vertically. So this will be a probe and the marker will be pointing to the cephalic. So when we point the probe, we may need to get this bat wing sign picture in our monitor. Once we get a proper image, then only we can judge, is this patient's a normal scan or does this patient have an abnormal scan? So why we call this bat wing? If you see, if you put a probe here, and this will be a marker here, so the patient's head is here. This is how image you get it. So this line is actually your ribs. So you can see a shadow. It's a rib, it's a bone. So there's no echo frequency transmitted beyond it. So you get a dark area. And this is your skin, this is your subcutaneous tissue, and here will be your intercostal muscle. And this will be your first anatomical structure that will be picked up by your echo. That is your pleural line. That is a line of your vesical and parietal pleura. And followed by that, we're going to look at the A line. So this is what they call as a bat wing, as they imagine as a shadow of this bat wing shadow here. And as I told you earlier, to be more detailed, this is your pleural line, and this is your A line. So this is a normal structure that you get when you do to a normal lung. What does this A line means? When you put a probe here, the echo touches the pleural line. It goes back, then it comes down, and it reflects back the A line. As you know, the lung is a hollow organ. So every time it reflects back, it gives you an A line just to show that this patient has normal lung. When the patient have pulmonary edema or the patient have ground glass appearance, especially in COVID patients, you will see a B line, a vertical line. I'll be showing you in the next video. So this video is a lung scan of a patient of COVID, not a dengue patient. The reason I put up this scan is just to show you a difference between an A line and a B line, where this patient have a ground glass appearance appearing in the lower lobe, where the upper lobe was normal on the right lung. So here I'll be scanning his right lung, and I'll be dragging the probe down towards patient's lower lobe, where you will see a B line appearing. So I'm scanning his upper lobe, A line. I'm dragging the probe down to the lower lobe, and you can see a lot of B line appearing now, and there's also some pleural thickening. This is a very classical finding for COVID pneumonia. So you might be able to differentiate between A line and B line now. Now, before looking into pleural effusion, we must know curtain sign in normal lung. So what this is curtain sign, which is a normal lung shows. When patient inspiration, the lung extends, it overlaps the liver. And on expiration, the lung collapses and the liver will be seen in the scan. So here you can see at this angle, a liver. Here will be the lung. And at the middle, you can see the lung will be like a curtain overriding the liver on inspiration, and the liver will appear on expiration. So I'll play the video first, so for you to appreciate a curtain sign, which shows a normal lung without a pleural effusion. So this is a normal lung without a pleural effusion, and what we are seeing is a curtain sign. So now let's move on to pleural effusion. This is a dengue patient had a severe leaking and had a pleural effusion. So this will be liver. Here will be the hemidiaphragm, and this will be the lung, collapsed lung. So I'll play the video. So hope you can appreciate. This whole is a lung atelectasis collapse, and this is all a pleural effusion. So this is the hemidiaphragm. So I put it in a captured picture. So to appreciate a pleural effusion, because sometimes we may mistaken with ascites. So you must be able to appreciate a liver, or if you're doing on the left side, it's a spleen, then you must be able to see your hemidiaphragm. Then anything above hemidiaphragm will be a pleural effusion, and this will be your lung. Okay, so with this, I hope you can understand and differentiate between a pleural effusion and ascites. So now we are going to move on to abdomen scan. So in abdomen scan, two structures that you want to see will be kidney, looking at the perinephric collection. And we always know that perinephric collection of fluid accumulation around the kidneys very significant for patient bleeding and occult bleed and leaking. Okay, and then later on we'll be looking into a gallbladder wall measurement. So this will be the probe position for the right and the left kidney, where you're going to put it exactly at that below around 11 or 12 rib space, and your marker will be pointing to the head, and the probe will be horizontal. So if you put it at probe position, you will get a kidney view and a liver. So the way you're going to differentiate is the liver will be more homogeneous compared to the kidney. So now here you are looking at the space between liver and spleen, liver and kidney, and we can see some perinephric collection. So this will be your kidney, and this is your liver. So now you can see some perinephric fluid collection here, which is very significant in leaking and occult bleed in dengue patients. So now we are coming to our last part of our presentation, gallbladder wall thickening. This gallbladder wall thickening is one of a very good manifestation, which very significant to show the capillary permeability state, increased capillary permeability state. And whenever we scan and if the wall is more than 3 mm, it shows that patients are already into a severe dengue, possible of severe dengue, and patients are leaking. And when we see the wall thicken more, a higher thickness like 5 mm, it shows a very highly significant for patient to go into volumic shock. Even though it's a very sensitive measurement and very significantly, a lot of papers have shown that this is very significant to highlight patients leaking and shock. But this is not a very easy scan to be done. Even if you ask me, I prefer to do an echo, IVC, lung scan, and also look into a kidney perinephric collection compared to gallbladder. Because sometimes it's not easy to scan and to capture gallbladder. Sometimes it's contracted after post-meal, and if you see the measurement, it's very minute type measurement. It's 3 mm and towards 5 mm. So the difference is about 1 mm or 2 mm, and is easily mistaken by the operator. So you can have two persons to scan the same patient and they can come up with the different findings. So these have made a lot of difficulty for me to scan gallbladder. So I always try to avoid scanning this gallbladder wall thickening. But let's we look into a patient. This is actually a patient. It was in a critical phase, and the patient had a hemoconcentration and lactate was 2.2. But there was no any much evidence of third space loss. So let me play the video. Okay. So this was the echo finding. The ventricle was good, not kissing. So then I proceed with abdomen scan. I didn't see any perinephric collection. But when I proceed with IVC, yeah, you can see it collapsed about 75%. So then the IVC diameter also is not that great, 1.8 cm. So that have triggered me, is this patient into a hypovolemic? Is this patient is leaking? So I did a gallbladder scan, and the wall, this is the wall measured, is 4 mm, which this suggested that this patient have a higher tendency to go into shock if we don't appropriately resuscitate this patient, and to measure the IVC after the resuscitation to look into the IVC collapsibility. But again, the gallbladder scan is very sensitive. As you know, the measurement may differ from one operator to another operator. So we need really to have some experience and should have been trained well before proceed with gallbladder scan. So with this, I would like to end my presentation. My take-home message today will be, we need a trained personnel, as accuracy of finding influenced by training and experience. That means it doesn't mean you just listen to this talk, you take a probe, you start scanning, you put a measurement, and you start managing a patient based on the measurement you does. It may lead to a wrong pathway. You may need to have bedside teaching, one-to-one teaching, and you may need some experience of doing few numbers of scan before you independently to take a role of managing a patient based on your scan. And I think this point will be the most important point. You should take overall assessment, not fully dependent on single finding alone. That means IVC scan or LV scan alone is not a gold standard for us to fluid resuscitate. A fluid resuscitation or management are based on few parameters: clinical findings, your clinical examination, your all the laboratory findings, vital sign findings, plus your echo findings. So this your echo or scan findings. So your scan is going to be an added value to support your clinical findings and to help you on fluid resuscitation. So don't take one single scan, IVC or LV, and jump into a fluid resuscitation without looking into other parameters. And another thing most important in this current pandemic is risk of infection control. I think, as I presented on my first 1-2 slides, how to follow proper SOP on cleaning these equipments. So ultrasound is always should be integrated finding with overall clinical presentation, physical findings, and laboratory tests. Thank you. And if there's any questions, you can post here. So I will try to answer your questions. Thank you.
Thank you, Dr. Vijayan. Now we will start the live Q&A. Please type your questions in Slido. We will try to answer as many clinical questions as possible. We will not be addressing any policy-related question. It's because it's beyond our scope of clinical practice. All right, so around 10 minutes, it depends on our time. Okay. Let me just check if there's anything on the Slido. Okay. Dr. Vijayan, I'd like to thank you for your very detailed presentation. So I'm going to take questions from the Slido first. The first question is, how do you interpret the IVC findings in patients with congestive cardiac failure?
Okay, so when this patient have an LV failure, at the baseline, this patient's IVC will be dilated. If this patient currently clinically on LV failure, but even though patient is CCF but stable, patient is currently under euvolemic, then your IVC should give a normal finding and the collapsibility should be around normal range, about 25 or 40 or 50%. If the IVC is dilated and non-collapsible, that indicates that the patient is in an acute failure. So not all CCF patients have a dilated IVC unless they go into an overload state. If they are in the euvolemic state, CCF, your IVC usually going to be at the normal range and the collapsibility is going to range around 30 to 50%.
Okay, thank you. How about the IVC accuracy in terms of intubated patients? Do you have any concerns?
Okay, so mostly this kind of intubated patient will be in ICU where the anesthesiologist will be doing. My role is more towards into medical acute cubicles where mostly it's unintubated patients. So most of my experience are not intubated patients. But of course, yes, when intubation is done, NS do have some adjustment need to be done for the IVC readings because when they have a high peak settings, it does do disturb the IVC. I mean, do influence the IVC measurement.
Okay. Dr. Vijayan, I'd like to thanks for telling us how you are coping during the COVID season in terms of doing ultrasound. So it's very useful thing. So you have also shown us a lot of our pitfalls in doing the scan. I'm going to put you in a spot and ask you the controversial question. Do you think that any of us should manage dengue without, without having an ultrasound at the bedside? Do you think it's mandatory these days? We know how difficult it is to manage dengue. Do you think one should invest in ultrasound and also, invest the time to actually learn an ultrasound, that no person should be managing dengue, at least in the tertiary center, without the ultrasound? What would your comment be?
So I will just share my experience. When I do manage a patient with ultrasound beside me, it gives me a lot of confidence. And I felt the accuracy of the fluid resuscitation and the outcome is always better. For example, a patient is tachycardic. Maybe you are looking at the hematocrit, which was done 2 hours ago. Maybe the lactate, which was done 30 minutes ago. So when I put my probe real time, and I can see the ventricles are almost touching, and the IVC is a bit collapsing, and patient is tachycardic, a young patient. So I'm very confident that this patient is compensating his shock. That means he's in the compensated state. The ventricles start pumping vigorously to compensate the blood pressure. So this gives me a lot of confidence that I go for fluid resuscitation without, while not wasting time waiting for repeated bloods. And within 20-30 minutes, I will scan back after the fluid resuscitation, and it gives me a confidence when I can see the IVC improve, the ventricle improve. So this gives me a real-time diagnostic evidence to manage these patients. So as we know, dengue is a very dynamic disease. So this using bedside ultrasound scan will going to assist us. And once you are trained and you have a confidence, I think it's going to give us a very good diagnostic and pre and post resuscitation assessment. So I think, yes, at the tertiary center, when we are managing a complex dengue,
Thank you, Dr. Vijayan. I assume I agree with you, and I just want to know, is there like for the younger MOs, is there like a training program, and how much time should one invest before? Of course, we don't want to be experts. We just, like you, we are very also concerned about the pitfalls you mentioned. I can imagine myself doing the echo and doing all the mistakes you mentioned. So how much time, energy does one presume? And you know, in a busy schedule with COVID around, between kissing ventricles and IVC dilation, should we master them both to be roughly adequate? Which one is easier, and how much time do you think one should invest to be having at least a basic knowledge, avoiding the pitfalls you mentioned?
So basically, there are a few stages when we are mastering scan. The first stage is the basics, where you must be able to hold the probe and able to get a very good window. I think that's the basics. Once you manage to have that, you know, there are fast learners where within few minutes they can get that view. There are doctors who may need few section, you know, 2-3 times, to third or fourth patient they can get that view. It's just your muscle memory. So once you get that view, that's it. Then you can learn through your YouTubes. You know, you can download videos, you can learn, and as you manage, you will develop your confidence level, where, you know, the ventricle kissing, your IVC accuracy, you manage, then the patient improve. That's where you get a confidence. So for me, I think the probe position and get a very clear, proper window will be the basic things that need to be mastered. Yeah. So it can happen within one patient, it can happen within 2-3 patients. So we also do AAIM also do run some online classes nowadays. Actually, we wanted to have a bedside teaching, but because of this COVID scenario, we do run sometime online, and there are a lot of other courses like INCOF, Focus, who's also running some online classes. Yeah.
Thank you very much, Dr. Vijayan. Certainly, it's reassuring to learn that there is something, there's programs out there to master, and I think for those who are in the fence, I think you quite convinced us that this is a very useful tool at bedside, and it's worth investing time and money in learning this for the management of dengue. Thank you, Dr. Vijayan. I think there's no further questions here. Oh, sorry, there's last one here. Any differential diagnosis for gallbladder thickening?
Even in acute cholecystitis, that will be another differential diagnosis when there's an inflammatory or infection taking place in a gallbladder. Slough, infection, inflammation. So that will be the main differential diagnosis when you see a gallbladder wall thickening.
I think I see no more questions there. Thank you very much, Dr. Vijayan, for spending your precious Saturday with us. All right, our webinar has come to the end, and I believe everyone has had a very fruitful session with us. I'd like to thank NIH and MyICID for actually organizing this event for us. With regards to CPD points, remember to collect your CPD points by filling up the online attendance form. Please double check your email address before submitting. For MMA users, you can scan the QR code displays at the end of the webinar. Thank you, and see you again.
you.